Good afternoon, Madam Chair.
Good afternoon, Senators. Today is Tuesday, February 10th, and today we're going to hear 10 bills. I'm going to read the bill order, and then we're going to start with the Lieutenant Governor and the administration bill. So the first bill is 385, then 340, 419, 370, 380, 18, 394, 333, 348, and 326. So that's our bill order. And Madam Lieutenant Governor, it's a pleasure to have you in the committee for this important bill, and you have with you the Secretary. You both have as much time as you need to describe this bill. After the two of you testify, the rest of your panel will each have 2 minutes. And I really ask people today to stick to the 2 minutes because we have 94 witnesses today. So we'd like to get home before 8 or 9 tonight. But you're also going to see that we have senators coming and going because they're in other committees testifying. So don't think that your testimony is not important. We're just in a lot of other committees too. So with that, Senate Bill 385, Public Health Recommendations for Immunization, Screenings, and Preventative Services. And Madam Lieutenant Governor, you can go. Thank you.
Thank you so much, Chair Bidle. Good afternoon, everyone, Vice Chair Hayes, and members of the Senate Finance Committee. And I know some of the senators are missing here, but I know they have bills in other committees. But I did want to give a shout out to Senator Ellis for his service to our nation as a U.S. Air Force veteran. And for those of you that may not know, my husband is also an Air Force veteran. And I believe Senator Lamb is also gone. I just wanted to say how important his medical expertise brings to this important, bill that we have before us today. And let me just say, for the record, there's nothing my parents would have loved more than seeing me become a doctor like him and Secretary Seshamani on the panel here. Clearly that didn't happen, but I'm honored to be here on the panel with her, as well as many of my mom's and dad's dream panel that are sitting behind me. For the record, I am Aruna Miller, Lieutenant Governor of Maryland, and I'm pleased to join you today in support of Senate Bill 385, the VAX Act. Under the Constitution, states have the authority to protect public health. The 10th Amendment gives states authority to pass laws that promote the general welfare, including disease prevention, sanitation, and emergency response. Senate Bill 385 reflects that responsibility. It would give our Secretary of Maryland Department of Health clear authority to issue official recommendations on immunizations, screenings, and preventive services based on science and clinical guidance. Recent and rapid shifts at the federal level have created tremendous confusion and instability, putting public health at risk. For example, just last fall, the U.S. Department of Health and Human Services significantly changed childhood vaccination schedule, reducing the number of routine vaccines from 17 to 11. So now the CDC no longer recommends routine use of vaccines for children against diseases such as rotavirus, COVID-19, hepatitis A, hepatitis B, and many others. Vaccination protects both individuals and communities by reducing the spread of disease in shared spaces like schools. These changes bypass the established evidence-based process, including independent medical and public health expertise, and broke from standards of transparency and scientific consensus. That lack of clarity creates uncertainty for states, providers, and families, and underscores the need for Maryland to ensure its public health guidance is clear. So simply put, the VAX Act protects Marylanders from these sudden changes. The federal government provides nationwide public health coordination that states cannot duplicate on their own. At the same time, states have a responsibility to act when clarity or continuity is needed locally. Maryland is doing exactly that, working in partnership with all of you in the Maryland General Assembly, the Moore-Miller administration has taken a series of steps to safeguard broad access to vaccines. Last year, Governor Moore signed House Bill 1315 to ensure that insurance providers continue cover the cost of all vaccines that are recommended by the Advisory Committee on Immunization Practices as of December 31st, 2024. That means that protection was limited to recommendations in effect at that time and does not automatically carry forward. Governor Moore also signed Senate Bill 18 to expand vaccination authority for pharmacists, allowing them to administer flu and COVID vaccines without a prescription to anyone 3 years and older. Both of these bills passed out of this committee, so I want to say thank you all for the work that you did on this. In 2025, Maryland joined the bipartisan Northeast Public Health Collaborative and the GovAct Public Health Alliance, partnering with other states and jurisdictions to dispel information, develop recommendations based on scientific evidence, and ensure broad access to quality care and evidence-based guidance. Governor Moore also announced a first-of-its-kind adult vaccine program to expand access to critical immunizations for uninsured and underinsured Marylanders. Access to lifelong medicines like vaccines is essential to the health and safety of every Marylander. This legislation is not about politics. It's about continuity, clarity, and care. Senate Bill 385 provides all three. I respectfully ask for your favorable report on Senate Bill 385. Thank you.
Thank you. And Madam Secretary, would you like to go?
Thank you so much. Good afternoon to you, Chair Beidel, Vice Chair Hayes, and members of the committee. For the record, I am Dr. Mina Seshmani, Secretary of Health for Maryland. I am delighted to be here with Lieutenant Governor Aruna Miller and our Deputy Secretary for Public Health Services, Dr. Meg Sullivan, to discuss the VAX Act with you. This bill responds to ongoing federal changes to vaccine policy, including recently altering longstanding recommendations for the children's vaccine schedule. In the face of uncertainty, Maryland has chosen to act deliberately and in good faith to protect access to evidence-based care. As the Lieutenant Governor described, the Moore-Miller administration, together with this General Assembly, has already taken important steps to preserve the care and the information that Marylanders rely on. Because of this, Maryland has some of the broadest vaccine access in the country. Even so, over the past year, the department has been required to repeatedly respond to federal changes through standing orders, clinician guidance, public communications, and extensive engagement with stakeholders. This legislation will build on our strong foundation by grounding our state's recommendations for immunizations, screenings, and preventive services in sound science and clinical expertise. Specifically, the bill allows Maryland to follow the trusted guidance of the American Academy of Pediatrics, the American Academy of Family Physicians, and the American Colleges of Obstetricians and Gynecologists. In doing so, it establishes a clear and durable framework that buffers clinical decision-making from shifting federal politics. The bill also preserves private insurance coverage for recommended vaccines without cost sharing and maintains the ability of pharmacists to administer recommended vaccines. While vaccines are the most visible concern today, we are also mindful that federal recommendations for other screening and preventive services, such as cancer screenings and family planning, may face similar challenges. This legislation allows Maryland to move from a reactive posture to a proactive one. It preserves a deliberative, transparent process focused on what is best for Marylanders and reinforces confidence in our public health infrastructure. I want to underscore that this bill does not create new mandates for individuals. Rather, it safeguards rigorous processes, clear information, and the access that Marylanders deserve. Like vaccines themselves, these efforts will prevent disease, protect communities, and support long-term health and prosperity across the state. And no new funding is required. This work will draw on the department's greatest resource, our experts and staff. Thus, we respectfully request your favorable vote on SB 385. And I'd like to now turn to our Deputy Secretary for Public Health and remaining panelists.
Okay, we'll do your Deputy Secretary. Deputy Secretary, come up, and then we'll do questions if we can with the three of you, and we'll go from there, because I see Senator Hershey has a question. Thank you, Deputy.
So good afternoon, Chair Beidel, Vice Chair Hayes, and members of the committee. For the record, my name is Dr. Meg Sullivan, and I serve as the Deputy Secretary for Public Health Services at the Maryland Department of Health. And thank you for the opportunity to speak today in support of the VAX Act. This bill represents a promise that we make to Marylanders, that decisions about their health will be guided by the highest clinical standards and by rigorous science. It establishes an essential framework to prevent debilitating disease across the lifespan or detect them early when treatment is most effective. The bill also allows health professionals to practice in accordance with the best evidence in their professional oaths. In addition to leading public health services, I'm a pediatrician with more than 15 years of clinical experience, both here in the US and abroad. I'm also a mother of 5 children, and I share the same goal with parents across Maryland, to keep our children safe and healthy. When I see patients in the clinic or take a late-night phone call from a worried parent, I'm trusted to provide guidance that can have serious consequences for a child's health, and I take that responsibility and my words very seriously. I have also seen firsthand the devastating outcomes when access to life-saving treatments, preventive services, or vaccines is limited. For me, as a public health leader, a pediatrician, and a mom, that is what this bill is about. The VAX Act preserves access to effective care and accurate information, including at pharmacies. Maryland needs policies that prevent illness, prevent missed days of work in school, prevent costly hospitalizations, and prevent premature death. Health professionals need clear and unambiguous guidance rooted in vetted science and clinical standards. And patients and parents need reliable information from real experts to make informed decisions for themselves and their families. And the health and well-being of our children, families, and communities depend on it. And for that, we respectfully request a favorable vote on this bill. Thank you.
Thank you, Secretary Sullivan. Let's start with Senator Hershey.
Thank you very much, Madam Chair, Lieutenant Governor. I know you didn't have time to recognize everyone in the committee, but the 9 others here certainly still do an outstanding job in representing the state in their public service as well, too. Real quickly, I'm trying to determine the exact need for this legislation. We've heard over and over again that Maryland has the broadest access of vaccines available in the state. What is actually happening that is either eroding that or making it necessary that the Department of Health has to step in the role of the federal government and now take over the vaccine program?
So, Senator Hershey, thank you for that question, and I second the fact that every one of the senators here play a valuable role in shaping Maryland. So that said, why is this needed? I think you heard from all of us that it is creating a lot of confusion right now. What the federal government is basically stating on vaccines. We are not changing any of that, but basically what we're saying is individuals who still desire to get the vaccination can do so, and those that do not want to do not have to. I think by giving the authority to the Secretary of Maryland Department of Health, we decouple from the federal government on some of the decisions that are coming through that we believe are not helpful for public safety when it comes to health. And that's essentially what it is, that the Secretary has the authority to recognize the vaccines. As I indicated, the federal government has said it's went down from 17 vaccines to 11. So there's vaccines they're saying that's not needed. And I think that's creating a lot of confusion amongst the residents. And so this basically gives the Secretary the authority to say, no, you can get all 17 of them. We have the authority to do so.
Okay, thank you. So, Secretary, then following that line, if the number of vaccines has diminished, the position of the Department of Health would then be what, to try to reestablish those? Or how would the Department of Health handle this?
Yes, thank you for that question. So what this legislation would do is enable the recommendations to be in accordance with leading medical organizations, such as the American Academy of Pediatrics, the American Academy of Family Physicians, the American Colleges of Obstetricians and Gynecologists. So enabling a following of leading medical organizations. And I think importantly, to build off of what the Lieutenant Governor was saying, one of the concerns right now is that if the recommended vaccines from the ACIP, the number decreases, then there might no longer be potentially a link with required coverage by insurance companies. Maryland currently has a law that requires the coverage of vaccines frozen in time with ACIP from December 31st, 2024. What this legislation would do is enable the required coverage of vaccines by insurance companies to, again, continue to evolve with the guidelines of leading medical organizations and other such organizations, including federal and state organizations.
So those organizations that you mentioned are on the bottom of page 2. Does the federal government, in making their determination on vaccines, consult with these groups as well?
I would say traditionally there was alignment between the two. I think that what we have seen more recently is that there has been divergence. For example, with the ACIP recommendations that have been put out, the American Academy of Pediatrics has come out saying that is not what is recommended by the clinicians who are caring for children.
Okay. So with respect to what you're speaking about with the bill, it's preserving the access. It's allowing the vaccinations to still be utilized and paid for. What is it doing with mandates then? Is the federal government saying they're no longer mandated?
This legislation does not create any mandates. What this legislation does is say that the Secretary can have recommendations for vaccines, and that translates to what commercial insurance should cover at no cost sharing, and also what pharmacists are then able to administer at the pharmacy.
So it doesn't translate into a mandated vaccination. You mentioned, and I guess this is the benefit of the governor having the bill, there's no fiscal note to it, right? That you can be doing this with in-house staff already, is that accurate?
Yes.
And why are they able to? I mean, it seems like it's quite a departure from what we're currently doing, and that this would take some time and be quite a process to go forward. How are these individuals able to, and how are they qualified, actually, to be able to take this on?
You want to address that with your staff?
Yeah, first, thank you for that question. I will say, and I know Secretary Seshamani and the Lieutenant Governor alluded to this in the testimony, if you look at some of the things that Maryland has recently been doing in the Department of Health, whether it was issuing guidance around respiratory vaccines and the COVID-19 standing order, whether it was issuing updated recommendations and a hepatitis B standing order, again, when there was confusion at the federal level related to the new vaccine recommendations, this is the type of work that we do, and this is the type of work that would go into making these new new recommendations as well. And so I think first, to answer the question, again, this is already kind of ingrained in what we do, and this is something that we would take very seriously. We have a highly qualified group of individuals that work at the Department of Health who have dedicated many years of clinical service, and have clinical training, background, expertise in immunizations and infectious disease prevention that would be at the table, have already been at the table for some of the actions that have recently been taken, and would be at the table here too.
Okay. When the federal government decides what's on the vaccination list, I've heard it's been a fairly public process in doing that. Does this bill require a public process to go as well too, or is it simply going to be just the recommendations of the Department of Health?
This legislation enables recommendations that are in accordance with the leading medical organizations, which, when they come up with their guidelines, follows decades of trials and other evidence that has been accumulated. So very much based on the science.
Right, but we've thrown this all into the hands of these three organizations, right? Is that what you're saying?
No, it is in accordance with these leading medical organizations and taking into consideration other federal and state organizations. So it enables, if you will, a broader scope in terms of the various inputs that can be provided.
Do you think this is a more inclusive process than what the federal government uses, or less inclusive?
I don't know that I can speak to inclusive or not vis-a-vis what ACIP is doing. I think this is a process that enables science to continue to guide public health recommendations.
Mm-hmm. And so am I assuming you meaning that the federal government is not looking to science as they're being guided towards their decisions?
Meaning that as the American Academy of Pediatrics, American Academy of Family Practice, American College of Obstetrics and Gynecology, major leading medical organizations have issued recommendations for vaccines, which for the first time in recent history are deviating from what the federal government has been recommending. And this legislation would enable being able to account for that in recommendations by the Maryland Department of Health.
Okay, so that's what this has got. There's been a difference of those organizations and what the federal government is doing, and then this bill now will choose to pick those organizations rather than the federal government.
This legislation says that recommendations will be in accordance with these medical organizations and considering also federal and state organizations.
Okay. Okay, thank you very much. Thank you, Madam Chair.
Thank you, Senator Mounts.
Thank you, Madam Chair. And I appreciate the Madam Lieutenant Governor, very, very good to see you today.
Great to see you.
Thank you for that back and forth. And my question is for the Secretary. So if this were to become law, and, well, first off, have any vaccinations, are there any that aren't recommended right now that would be recommended? Is that other than, I understand that these groups are deviating, there's some differences, but have any of them any of the vaccinations been taken away?
Yes, hepatitis A, hepatitis B, rotavirus, COVID-19. I've got my pediatrician here to list all the specific vaccines.
Okay, great. So
yes.
COVID, that's so the federal government's taking COVID away, and so say this were to go into effect, and the state of Maryland would say no, all children should have a COVID vaccination, and then and then we know what happened with COVID vaccinations in children, and then you have that injured child. Who's liable?
So what this legislation does is it enables, if someone chooses to get a COVID vaccine, that their insurance will continue to pay for it at no cost sharing. It is still ultimately the choice of the family with the clinician deciding on something like a COVID vaccine. But it enables that access and it enables that choice.
It enables that access and enables that choice, but you've got the practice of medicine, and you have a doctor treating a patient. In this hypothetical, we're talking about a child, right? And so we know a number of children that took the COVID vaccination that were injured from the COVID vaccination. Using that example, what recourse does the doctor have if it's being recommended and the doctor doesn't want to give that vaccination? And then, of course, for the child and the child's family, the information that they have and the decisions they're making, what recourse do they have? Because they're now no longer is this the CDC. You've got two different entities you're dealing with. Am I correct in that? So we would deviate from what the CDC is recommending?
So what this does is it enables recommendations from the Department of Health that then will lead to, for commercial insurance, that those are ones that have to be covered at no cost sharing. So that thereby, if a family, a parent in working with their clinician wants to be able to provide, say, a COVID vaccine, cost will not be a barrier to that child being able to get the COVID vaccine.
Yeah, I understand. So the bill is primarily focused at cost coverage, correct? But aren't there other implications from this? Could there be other implications from this bill if it were enacted, having a different standard, a Maryland standard versus the CDC standard?
The idea here is that we would have recommendations from the Department of Health that is in accordance with these leading medical organizations and considering federal organizations and state organizations so that we can ensure that we continue to have an evidence base for these guidelines.
So I think there might be a little difference of opinion. I don't see this just as being a financial thing. I see there's a lot more that goes into what this bill would implement. But that's for other testimony. I really appreciate you engaging with my questions. So, Madam Chair, thank you.
Thank you. Senator Kramer?
Thank you, Madam Chair, and always a pleasure to see all of you. Just a quick question to make sure I've got the net of this, Madam Secretary. Would I be correct in asserting that the legislation before us is a thoughtful, responsible, science-based response to the non-science-based, irresponsible lunacy coming from our tinfoil hat wearing current Secretary of Health and Human Services?
I can say that as
well. Actually, I can say it. You don't.
No,
have to
what I was going to say. like Dr. Sullivan, I am also a physician. I'm an otolaryngologist, ear, nose, and throat surgeon. So respiratory viruses are near and dear for me. I also am a mom. I know in my communities where I am talking with other parents, I know as secretary, when I am talking with people in my community, going out to visit every part of the state, which I have done every region before I hit my 1-year mark, the confusion around vaccines is palpable. And I think it is very important that we in the state are able to provide information to our families as they are making decisions with their doctors and other clinicians, and that we remove any financial barriers that could exist to being able to get the care that people need. And that's what this legislation does.
Thank you very much for that. Thank you, Madam Chair. I needed that clarification.
Senator Lamb, I see your light, but before you go, I want to go back onto the confusion issue. I actually sat in, I won't name the store, when the confusion had started with the COVID and the flu shots, where a family that I know, the dad had ALS, and they were refusing to give the children, the adult children, teenage children, the COVID and flu shots. And so that was the issue we were dealing with when these recommendations started changing from the federal government, that pharmacies and insurance companies for a while were not paying for the immunizations that were no longer recommended by the federal government. Great deal of concern for people that do want their vaccines. And I understand this is not a mandate. This is a recommendation. It's still our constituents' choice. But I saw the confusion firsthand. So I thank you for the legislation. Senator Lamb.
Thank you, Madam Chair. Good to see everyone. Thank you all for being here. Apologize. The county executive, Stuart Pittman, was meeting with me earlier, so we got hung up a little bit and it was got here late. But certainly appreciate the testimony from all of you to introduce this bill. This is, in my opinion, a very important piece of legislation that we need to see. The General Assembly took steps last year preemptively to ensure that health insurance companies would provide and continue to provide for coverage, payment coverage for individuals that still want to get vaccines as of December 2024's guidelines from the federal government. As the chair mentioned, there has certainly been a lot of confusion, and I've seen and heard a lot of this myself as a physician. I'm not a pediatrician, but a lot of folks, ask for informal advice, and it's clear that many folks in the public have received conflicting information about where vaccines are and whether they should be accessible to individuals or not. That these changing guidelines has certainly led to a lot of confusion, and there's been a lot of pushback that I've heard from my constituents on the politicization of vaccines as well, and the concern certainly is palpable, to my colleague's point across the room. And so, this is something that is certainly needed because we had a gold standard process that was set up by the federal government, led by CDC, that has been gutted and made a mockery of across the country. And so other states have had to step up, and I think Maryland has to step up as well to make sure that we put in place a structure that will restore confidence amongst the public of their access to important and necessary vaccines. And it's not just vaccines as well. I want to point out to folks, and you can speak to this as well, there is a provision here on the U.S. Preventive Services Task Force, too, which is the primary federal body that sets screening guidelines for individuals. So that could be colon cancer screening, that's breast cancer screening, that's screening for individuals coming to their primary care clinic for mental and behavioral health conditions. And that's an important piece of this as well, right? And is that something that was built in intentionally because the U.S. Preventive Services has not been allowed to meet for the last couple of months?
Yeah, I think, first, I really appreciate you pointing that out. I think we talked a lot about preserving access, providing clear guidance for families, for patients, as well as for clinicians, which I think is a really important piece here that I know has been touched on in some of the questions. And I think, yes, while the focus has been on vaccines, a recognition of the importance of preventive services and screenings, and that historically there has been a very transparent process at the federal level, whether it is through the U.S. Preventative Services Task Force or HRSA, the Health and Resource Services Administration. And there are a lot of concerns about what is happening at that level, too. And so this bill is aimed to protect those critical services we know as well that can be life-saving.
Right. And with the U.S. Preventative Services Task Force, which has met since, I think, the 1980s, and on a regular basis issued new recommendations for screening and other processes that healthcare providers and clinicians, particularly in primary care, turn to for guidance all the time, has not been allowed to meet over the last few months. Their staff has been gutted, and it's the same level of concern that we had seen take place at a more high-profile level with ACIP and the CDC, that the federal government is no longer behaving in a science-guided, evidence-based fashion. With all due respect to my colleague here, I think, I have a lot of concerns about how they've turned their back on science and really installed a sloppy, slapped-together process led by stooges of RFK Jr. And that is certainly concerning. We need to restore confidence here in the state of Maryland with folks that actually understand science. And I think this process, which is not a mandate, right? It's important to point out to folks that this is giving people choices and restoring the confidence that they have with guidance that's coming from the state of Maryland, as well as working closely with their clinicians, right? And all of these decisions are conversations that parents or adults have with their primary doctor or their pediatricians to be able to come to the best decision. This is not a mandate, but this ensures choices and affordability for Marylanders. Is that how you see the primary aim of this bill? There are no new mandates in this.
I think absolutely. I think first, as a clinician, it gives me something to look to, clear recommendations that I can use when I'm having those conversations with my patients about what is recommended, and again, talking through all of the considerations and working through informed consent. And then it also, though, gives clear recommendations for parents and patients to look to, but I think just as importantly, as I know Secretary Sheshamani has touched on, that we can clearly say this also will be paid for by your insurance, and so that cost is not a factor as well. So again, I think it is that clarity, it is that ensuring access, it is by no means any new requirements or mandates.
And while there's a lot of uncertainty with how the federal government is spiraling out on these important issues, this does restore, we do have confidence in our state government to be able to make the proper decisions. So in instances where the different medical societies may be providing information to you, the state ultimately has the ability to compile all of that together, look at it in a evidence-based and science-guided fashion to be able to make a decision, right? We're not just taking guidance from different medical societies carte blanche. We will look at this in a holistic fashion to compile sensible and confidence-inspiring recommendations from the state of Maryland.
Yeah, and I think the bill, and I know, again, Secretary Sheshamani has said, was carefully worded to talk about in accordance, right, with major medical organizations, which again, I think ties the science to it, but also in consideration of other a list of different organizations, but again, a very thoughtful, holistic process based in science that will be transparent.
Right, and ultimately decided by the department, by the secretary.
Correct.
I think it's also important to point out that while we've been talking about vaccines and access to vaccines that are already here, there may be potentially new vaccines that could be developed as well, which is great from my perspective. And I think it's important for people to have guidance on that. My expectation, and I have very low expectations for this federal government, is that they won't put out any new guidance on new vaccines. And so setting up this process is also important for those new vaccines to have some type of guidance for our clinicians that are operating in the state of Maryland to have some information about what the science-based guidance is here for them. Right?
Correct.
And that's an important piece that's for new vaccines, not just vaccines that are already in place.
I think that is absolutely correct. As we said, the legislation right now ties it to December 31st, 2024. But again, looking forward, as science does evolve or new vaccines do come to light, this does provide that flexibility to make those new recommendations.
Okay. And then finally, I think with this, a lot of this is talking about coverage, right? To make sure that coverage by insurance companies is still there for these vaccines, which is important because we know that if coverage goes away, that becomes an access issue. People will get their vaccines less simply because they don't want to pay for a copay. But the coverage for this does not mandate things, and individuals will still be able to choose whether they get it or not. What's important to recall about this bill is that by having if this were to pass, we would ensure that people, if they choose to get vaccinated, would still have that covered by their insurance company.
Correct.
Okay. Thank you.
Thank you, Senator Lamb. I don't see any other questions for this panel, no other lights. Thank you all very much. I'm going to call up 4 more favorables that were part of the original panel. Dr. Mar Dugar, I don't know, Dr. Mar, Dr. Monique Sola-Burke, Javier Vasquez, and Marie Grant is here if you want to come to the table in case there's questions. I see that you have it for questions only, so thank you. If we can not repeat the extended conversations we just had and present new issues, that'd be great. Thank you.
Sure. Hi, good afternoon. My name is Monique Swallow-Burke. I am a general pediatrician in private practice in Howard County, Maryland. I actually wear several hats, so today I'm going to speak from all of those, the most important being that I am a mom of a wonderful just turned 18-year-old who thinks she's an adult but isn't. I am currently speaking, like I said, I'm a general pediatrician in Howard County. I am also the immediate past president of the Maryland chapter of the AAP, and I'm currently a national officer on the American Academy of Pediatrics. And thirdly, I am currently the chair of the statewide advisory commission on immunizations. So first, just kind of talking about why we're here today and why we're speaking out in support of this bill is because of the concerning changes that we've seen with the CDC and ACIP. We have data. The data has been presented, the data has been revisited multiple times, and we feel very comfortable and confident in continuing to ascribe to what the AAP has been doing for many years. As a general pediatrician, I am in my office every day seeing patients. I really have never met a family that didn't want to do what the best thing for their child. And the concern and really confusion that I'm seeing every single day in these exam rooms. I had a patient this week, has a child with a complex medical history, 10 or 12 years old, and she said to me, Dr. Burke, I've never, ever had a conversation with you about concerns that I had about the flu shot. We've gotten the flu shot every single year since he was born. Very, very concerned. And we spent a lot of time talking about it. I think it's important. Pediatricians and physicians, we want to answer these questions, but it's important that we have the support of the Maryland Department of Health to really kind of back us up. The AAP has been making recommendations for immunizations for over 90 years. They only were kind of coordinating with the CDC since the 1990s, so this is something that's been going on forever. And the AAP, we're very lucky that one of the big advisors to the AAP Commission on Infectious Disease is right here in the state of Maryland. So I just want to thank again the MDH for making sure that they're supporting pediatricians, and I just want to ask that we vote in favor of this bill.
Good afternoon, Chair Beidel, Vice Chair Hayes, and members of the committee. My name is Javier Vasquez, and my testimony today is in the capacity as Board Secretary for the Maryland State Board of Pharmacy. Although I am also employed by Johns Hopkins, I need to know that the views expressed today do not necessarily reflect the policies or positions of the Johns Hopkins University or Johns Hopkins Health System. The Board of Pharmacy proudly supports the VAX Act and the efforts to improve vaccine access for Maryland residents based on sound clinical guidance and scientific evidence. Last fall, the Board of Pharmacy worked closely with the Maryland Department of Health to ensure that Marylanders had access to certain vaccines. The board feels that SB 385 is a continuation of the department's efforts to provide access to vaccinations based on sound clinical guidance. Therefore, the Board of Pharmacy is in full support. Moreover, SB 385 provides much needed clarity for pharmacists who do provide vaccination services to a significant number of Maryland residents. Since the COVID-19 pandemic, the state has increasingly relied on pharmacists to provide immunizations. The bill will ensure that pharmacists can continue to provide these vital services without the risk or ambiguity that may arise from potential deviations from prevailing clinical guidelines. For these reasons, the Board of Pharmacy requests a favorable report on SB 385. Thank you.
Chair Beidel, Vice Chair Hayes, and the members of the committee. My name is Dr. Amar Dugarala. I'm a board-certified family physician practicing in Poolesville, Maryland for the past 18 years. I currently serve as the president of the Maryland Academy of Family Physicians, and I'm also here on behalf of MedChi, the Maryland State Medical Society. Both organizations strongly support Senate Bill 385. We believe that vaccine recommendations should be guided by the best available scientific evidence and should prioritize both public health and the individual health of each and every Marylander. Unfortunately, many of the changes made over the past year by the Federal Advisory Committee on Immunization Practices and the CDC were not driven by any new scientific evidence. This has created uncertainty and undermined longstanding evidence-based guidance that physicians rely on to care for their patients. The VAX Act addresses these concerns by aligning Maryland's vaccine recommendations with those of the American Academy of Pediatrics, the American Academy of Family Physicians, and the American College of Obstetricians and Gynecologists, organizations that have consistently applied rigorous evidence-based standards to their guidelines. This act will give the Secretary of Health the authority to give guidance not only to healthcare workers and providers, but also confidence to the general public on how to protect themselves and their families. The recent federal changes have also created uncertainty among physicians and patients over how this will impact insurance coverage for vaccines. The Vax Act will ensure insurance coverage for these recommended vaccines and give Marylanders their continued options of getting these vaccines either at their physician's office or at the pharmacy, without having any concerns about access or affordability. As a family physician trained in public health who cares for children and adults in my community that are affected by conditions that are easily preventable by safe and effective vaccines, I urge this committee to support Senate Bill 385. Thank you.
Thank you. Do I have any questions for this panel? Any questions for Senator Kopp?
I'll be brief. And I apologize. I don't know if this question was asked of the previous panel, but I was thinking, and I don't know who might be the appropriate one to answer this question. But let's say when this administration changed, I realize that this bill was brought about in response to the decisions that are currently being made by the administration, the federal administration. When this administration does change, do you see us going back to what we had before, that we've had in place for decades, or do you think that this is going to be the new policy, I guess, to abide by? I don't know.
I would say I hope
Or
so.
what do you think we should do?
Yeah, I hope so. I think as Senator Lamb had mentioned previously, the federal agencies, including ACIP and CDC, have always taken into account good science, good evidence, and also took into account the studies that have been done by and the guidelines stated by American Academy of Pediatrics, American Academy of Family Physicians. And I'm hoping that the federal government at some point will go back to those.
Okay. And when I say that by the assumption that we have a new health secretary who is not wearing a tin hat, so to speak. So you would think that we could possibly then just go back to what we have right now. Is that fair to say?
I would say so as well, supporting that, because I think if we're going back to, the reason that things have been, I would say, using the word stable, is because we have really, truly always, I always tell people I'm a pediatrician, not a politician, and we've always really focused and based those recommendations on science. And I think if we go back to doing that, I think that would be a reasonable thought.
Commissioner Grant?
Thank you, Senator. I think your question is an excellent one. I think that the bill is drafted to accommodate both the potential for state changes as well as federal changes. It really locks in to that science base. If the recommendations of those leading medical societies are in line with what the federal government is doing, then the bill encapsulates that situation, if that makes sense.
It does.
Yep.
Thank you. Thank you, Madam Chair.
Senator Mounts?
Thank you, Madam Chair, and I'll be very brief. It's a technical question for Dr. Dugarala.
Dugarala, perfect.
Thank you. And so this is a technical, and it's a little off the bill, but it's to the bill. I've helped a couple of medical practices that have had issues with coding and Medicaid. And so when there's an issue with Medicaid coding, all of a sudden you have Medicaid fraud, and it's a huge problem for a practice. So if this were to go into law, and it would be covered by the state, but isn't your coding according to federal standards, not state standards? So when you're going to get reimbursement, or is that not a problem because it would be handled by the state? Trying to understand that.
So I don't think this would impact, as far as I can tell, any coding issues. If we're talking specifically about Medicaid, those vaccines are actually covered under the Vaccines for Children program, which is I don't think is covered by anything in this act. But our coding is already based on certain requirements, so I don't see any way that this would impact our coding.
Yeah, and the previous panel was asking questions about a vaccination for a child using the COVID hypothetical. Not talking about that at all right now. I'm talking about specifically that practice. So there's all kinds of different vaccinations. Do you think there ought to be something in this legislation that would protect practices from somehow being accused of, particularly in the Medicaid realm? That's my experience, is when practices have had problems with the Attorney General's office or whatever for Medicaid fraud. Do you think there should be something in there to protect them from an investigation based off of a vaccination that's authorized by this law? You don't see the need for that?
I don't, I guess I can't speak to that. That's beyond my expertise, but I would say that as far as, these vaccine recommendations, these are vaccines that we've been giving for a long time and are well established. And the coding for that is also well established. Fortunately, coding for vaccines is actually pretty straightforward. It's not very complicated.
Okay.
So.
All right, thank you.
Thank you, Senator. Senator Land?
Yeah, thank you, Madam Chair. Just very briefly, I know this is not the sponsor panel, so just to kind of help my colleague and some of the folks back there out. So my understanding from the bill is that this new process that the state creates would also take into consideration the applicable guidance of, we're going to set up our Maryland Statewide Advisory Commission on Immunizations, but also can take into the applicable guidance of the CDC's advisory committee, of the FDA's advisory committee as well. Those are the ones that currently exist. And so in a environment where the federal administration is more science-based, we can still revert back to and lean heavily on those guidelines that are coming out of the CDC, out of FDA. We will also have our own statewide advisory commission on immunizations, which I think is great, given that we have some phenomenal institutions here at the University of Maryland and Johns Hopkins to be able to help populate a commission that can give us some weight and guidance directly here in the state of Maryland as well. And so I think to the earlier point that's being made, can we lean back on the existing guidelines out of ACIP and out of the FDA's advisory commission as well in the future? I think that's probably the case, right? And it gives us the flexibility, right? This bill is about choices, right? This bill is about choices, giving patients choices of whether they want to take this vaccine or not in consultation with their provider, and have that paid for, as it has always been, by health insurance companies, because these are preventive services that make a lot of sense and have good health outcomes for individuals. And so, I think maybe just direct to Commissioner Grant here, I think this does allow us to have those choices, right? To revert back as well to those federal guidelines at a point in time when the state feels comfortable to do so.
Yeah, absolutely. I think that, thank you, Senator. I think that there is a shall. We need to make sure that we are tied to certain medical organizations, but also need to take into account all of those science-based. And so it really, really focuses those recommendations for vaccines and preventive services on the science.
Correct. Thank you.
Thank you, Senator. I don't see any other questions for this panel. Thank you all for your testimony. I have a panel, 5 more favorables: Catherine Kirk Robbins, Kelly Schultz, Alea Horton, Andrew Zirkle, and Monique Ashton.
Madam Chair, I'm just letting you know that Adam Zirkle was also signed up for me just in case I couldn't be here.
I wondered, I saw the association. Thank you for being here. Who would like to start?
Do you guys want to start down there? Or? Okay. Madam Chair and members of the committee, my name is Catherine Kirk Robbins. I'm here today on behalf of our individual organization, Maryland Citizens Health Initiative, not the Full Healthcare for All Coalition, just because we didn't have an opportunity to put this bill before them ahead of this hearing. I will keep it brief. I first want to thank the Moore-Miller administration for introducing this important legislation. Organizationally, we're very supportive of this bill because we are in favor of anything that preserves access to essential preventive medical services. It's good for public health. Childhood vaccinations in particular are really good at saving money down the line. Every dollar spent saves $3 in direct medical care after that. So we are a big fan of that. Personally, I'm also here as a parent, as some other folks are. I'm deeply appreciative that this legislation establishes a trusted voice that can offer, clinically relevant guidelines, while also preserving safeguarding the ability for me to get my children fully vaccinated. So very simply, we are in support of this bill and urge a favorable report.
Good afternoon, Chair Beidel and members of the Finance Committee. My name is Aaliyah Horton. I am the Executive Director of the Maryland Pharmacists Association. We are the professional society for pharmacists, student pharmacists, and pharmacy technicians. And we are in support of Senate Bill 385, the VAX Act. We believe that this bill meaningfully future-proofs pharmacists' vaccination authority in Maryland and supports the sustainability of pharmacy-based immunization services that continue to be critical for routine to emergent public health needs. And we appreciate that the committee passed House Bill 1315 last session, but we understood that it was a protective measure for a specific period in time, and appreciate the efforts of the governor as well as the Secretary of Health and Department of Health in finding this bill, in creating this bill to continue to protect access to vaccine recommendations that are rooted in science. We also support this bill in that it creates a framework that is modernized and adaptable so that Maryland has the flexibility to authorize pharmacists to administer new vaccines, expand use during outbreaks or emerging public health needs, and avoid future legislative delays every time guidance evolves. The insurance coverage alignment also ensures the continued practical usability of pharmacist services, which provides for less confusion when interacting with patients, stronger payer alignment with pharmacist-delivered vaccines, and fewer reimbursement barriers when recommendations are updated, as several folks have mentioned already. So again, we support this legislation. We believe it reinforces that pharmacists are embedded in the public health infrastructure. It recognizes the role of pharmacists not just as sort of permitted vaccinators, but as recognized implementers of Maryland's public health strategy and system-level preventative care providers. And I'll just mention that the Maryland Pharmacy Coalition is also in support of this bill. So thank you.
Thank you, Aaliyah. I never know if I should call you delegate or secretary or the honorable, but thank you, Kelly Schultz, for being here.
Kelly works really good, Madam Chair. It's good to be here, Madam Chair, Mr. Vice Chair, members of the Finance Committee. My name is Kelly Schultz, and I'm the CEO of the Maryland Tech Council, and we are here in support of Senate Bill 385. Maryland is one of the nation's leading life science hubs, as we all know, home to vaccine innovators, manufacturers, and global biopharmaceutical companies whose success depends on a predictable, science-driven immunization ecosystem. Senate Bill 385 strengthens that ecosystem by ensuring that Maryland's immunization recommendations remain aligned with the most current scientific and clinical guidance from leading medical authorities, giving manufacturers and researchers confidence that new vaccines will be evaluated and adopted through a clear, evidence-based process. The bill also improves vaccine access by enabling pharmacists to administer recommended vaccinations more broadly and by ensuring health insurance coverage for recommended immunizations without cost-sharing barriers. Key steps that help translate scientific innovation into real-world vaccination rates. For vaccine manufacturers and life science companies, predictable adoption pathways and strong vaccination infrastructure are essential. When states provide clear regulatory alignment and stable coverage policies, companies are more likely to invest in manufacturing capacity, clinical development, and workforce growth locally. Senate Bill 385 sends a strong signal that Maryland supports innovation, public health readiness, and rapid deployment of next-generation vaccines, positioning our state to remain competitive for future federal partnerships, biomedical investment, and pandemic preparedness initiatives. By reinforcing science-based decision-making and improving access to recommended immunizations, this legislation simultaneously protects public health and strengthens Maryland's life science economy. We respectfully urge a positive support to Senate Bill 385. Thank you, Madam Chair.
Well, that's certainly a different twist for the reason to support it, so thank you very much.
That's why I like to be here for you, Madam Chair.
Nice to see you again. Monique Ashton?
Yes. Good afternoon, Chair Beadle, and all members of the Senate Finance Committee. My name is Monique Ashton. I am the mayor of Rockville. I thank you for this opportunity. I also appreciate Senate President Ferguson and the colleagues who've submitted this bill. We strongly support the Moore Miller administration's efforts to protect public health. The Rockville Mayor and Council unanimously support SB 385, which aligns with our priority to protect the health of our residents. We strongly support vaccines as they remain one of the most powerful health tools to protect us against severe illness. Recent shifts in the federal processes away from evidence-based medical guidance grounded in rigorous science are very concerning. We support this for the following reasons. It establishes the authority for the Secretary of Health to recommend immunization, screening, and preventive services. It takes the politics out of public health. We are at a time where states need to do more, given some of the federal changes. It's time to have a proud Maryland moment. SB 385 decouples the state's vaccine authority from the federal government that have recently shifted their processes. We also support the bill's efforts to following leading national authoritative medical organizations that issue independent, science-based recommendations, including many of the top medical societies, family physicians, pediatricians, obstetricians, and gynecologists. It also protects access and who can give the immunization and access to our residents to be able to get them, requiring Maryland insurers to provide coverage at zero-cost share for immunizations. This bill provides for choice, and without it, there could be situations where residents may not be covered. We also understand the importance of signaling to the life science community that we believe you should continue to innovate. Maryland is a huge part of the life science ecosystem, and this also supports that initiative. We applaud the Moore administration to protect our communities by quickly adjusting state vaccine policy in response to shifting federal policy landscape. Personally, I also want to add, I am a public health professional as well who has done global and national public health work and have worked in immunization education and outreach. We need to support access. There are diseases that have been mostly eradicated where we're seeing spikes now. Thank you.
Thank you very much. Do I have, Senator Crane.
Thank you, Madam Chair. And I just wanted to say it's always a pleasure to see Secretary Schultz when she comes to visit us, my former colleague. But I also want to note, colleagues, that Senator Kagan likes to preference her introductions by saying the proud senator from Rockville and Gaithersburg. Well, I do want to share with you that I have some of the great city of Rockville in my district, and what a pleasure it is to see the outstanding Mayor Ashton here today. So just had to flag that.
Thank you.
Good to see you.
Thank you. Likewise, and I'll just note there are 120 biotech entities in the city of Rockville. So.
And there's that. Thank you.
Thank you. I don't see any other questions or comments. Thank you very much for your testimony. Now we have a group of unfavorable: Sarah Cusack, Emily Tarsel, Valerie Borak, John Kelly, and Jill Capper. Okay, obviously we're missing one. Please identify yourself before you start and go ahead.
Good afternoon, Chair Beidel, Vice Chair Hayes, and members of the Finance Committee. Excuse me. My name is Sarah Cusack. I'm with an organization called the Alliance for Science-Based Policy. We understand the good intent of the bill. We are unfavorable because we don't think all of the implications of this bill are being addressed. So I'm going to talk to you about liability. In 1986, vaccine manufacturers were inundated with injury claims and lawsuits, and they worked with the federal government to create the National Childhood Vaccine Injury Act. The act dictated that the federal government will assume liability for vaccine injuries and deaths, and it created a compensation program. It removed liability from vaccine makers, and it removed liability for the administrators of vaccinations. In 1986, the childhood schedule had very few vaccines, and administrators were physicians and nurses. Today in our state, administrators include pharmacists and pharmacy technicians. So, as an adult, even if you get a flu shot, if you are injured by a flu shot, even though you are not a child, because the flu shot appears on the childhood schedule, you cannot sue, and you still go through this federal liability and compensation program. Because the federal government has reclassified some of these vaccinations as not routinely recommended, but decision-making between patient and physician, administrators in our state are no longer going to have liability protection. SERVA, or shoulder injury via improper vaccination administration, is the most frequently compensated injury in the federal program. You're going to have pharmacy techs now who are liable for, these injuries occur a lot in our state. They're now going to be liable for if they give a child a COVID vaccine or a flu vaccine and there's an injury. So I haven't seen anyone addressing that.
Good afternoon. My name is John Kelly, a citizen of Maryland. I'd just like to
John, why don't you pull the mic closer? Yeah.
My name is John Kelly, a citizen of Maryland. I'd like to follow up on one of the comments the speaker just made in terms of the history of the Vaccine Act, and make the point that this vaccine hesitancy or concern with vaccines did not start with the second Trump administration or the Secretary of HHS. It started more than 40 years ago, before the 1986 Vaccine Act, by mothers, parents whose children were harmed by vaccines. That's where this started. This is nothing new. The Vax bill assumes that science is a collection of information not open for debate, that it resides in our authoritative institutions. There's another view, however, that says science is a process of learning and discovery, and debate is the heart of it. The bill's supporters call for rigorous evidence-based science, but don't seem interested in pursuing it. Rather than providing reasons and evidence for disagreeing with the CDC's change of the childhood vaccination schedule, they dismiss the changes out of hand. Supporters ignore the fact that the CDC schedules, past and present, do not meet the demands of evidence-based science. None of the vaccines on the schedules has ever been tested for safety and effectiveness against a true placebo. There are no long-term studies for safety, the bill ignores millions of injuries and deaths, and this is not vaccine science. Ignoring the historic failure to investigate the causes of vaccine injuries and deaths is not science. Ignoring the failure to investigate possible connections between the number of vaccines doses and the significant increase in the chronic illness and autism is not science. Ignoring CDC's past attempts to hide evidence of potential harm from vaccines is not science.
Mr. Kelly, please wrap up.
And I would urge the committee, the legislature, to do their own. It's good that they're not outsourcing the decisions on these, but to do their own research and to have a panel of experts, pro and con vaccines, because the stooges that were referred to are qualified scientists working for the secretary.
Thank you so much for your testimony. Next.
Yes, I'm up. Hi, my name is Valerie Farrell. I'm from Cecil County, and I'm sorry I forgot my tinfoil hat, but we'll just bear with it today. My main point here, I'm going to go off the cuff a little bit because of comments I heard today. I'm just going to say I do think that, as Senator Hershey brought up early in this hearing, that this bill is unnecessary with respect to what it's doing for Department of Health. Just last night, I went on the Department of Health website, and their vaccine guidance for the respiratory illness season is, quote, aligned with updated guidance released by AAP, AAFP, and ACOG. And similarly, a previous speaker testified to the fact that there were standing orders for the COVID-19 shot and also for the hepatitis B shot, which happened in response to what the federal policy changes did. And so I can see that notably absent from that list is the CDC. So it seems to me like Department of Health already has the authority. It can and is acting independently from federal policy guidance. And so there is no reason for a bill like this to change any language. This bill is actually creating a new chapter under Title 18 to specifically tie with the word shall, as a previous speaker noted, shall follow the authority of the AAP, the AAFP, and ACOG. So from my point of view, with that legal word, that mandatory language, this is removing authority from the Department of Health. It requires them to mirror the national policies. It tells them they're not the trusted or valued public health authorities in this state, and instead it's unaccountable outsiders. And I note there was talk about mandates changing and whether that would happen or not, but we're looking especially specifically with the AAP. This is an organization that has a policy statement to eliminate religious exemptions. They believe that non-medical exemptions are contrary to public health and that they should be eliminated. So I do wonder about how these shot schedules would change, especially for schools, if DOH has to follow their policy, because as somebody noted, there's actually 14 shots on the schedule where Maryland only has 8 required right now. And then also, what are the implications if we're following an organization that wants to eliminate religious freedom?
Thank you so much for your testimony. Ma'am, you could pull the microphone closer to you.
Okay, good afternoon, everybody. I'm Emily Tarcell, a therapist, former therapist and mom. I oppose SB 385 based on personal and professional experience. On March 3rd, 2018, I attended a symposium sponsored by the Maryland Department of Health, funded by Merck. The event titled HPV Vaccination, Doctors Are the Key, was all about increasing uptake, and they used examples of bribes, unethical strategies, and false narratives to increase uptake of vaccination, i.e. increase sales. You have some slides from that event. The providers were urged to create competition among staff by tracking and posting the shots they gave, publicizing it, and then using an enticement like a, quote, cheap bottle of water to be presented to the most aggressive seller. The same is true for doctors, but they were offered bonuses for increasing uptake. Some unethical strategies was a change in the strategy for increasing uptake was to go from knowing, which meant educating, to doing, i.e. assertively administering the vaccine, saying, your child is due for 3 vaccines. Providers were advised to put the vaccine, the HPV vaccine, in the middle of the list, vaccinate and move on. This is unethical. The messaging was to falsely claim that the HPV vaccine is, quote, cancer prevention. However, there is no evidence that the vaccine has prevented even 1 case of cervical cancer, and HPV-related cancers are very low in this country at 0.001% due to Pap screens. The vaccine was never needed. My daughter and I fell prey to the propaganda. Chris died 18 days after her 3rd Gardasil shot, and after 8 years litigating, HHS conceded she died from her HPV shots. And when I shared that information at the symposium, the presenter shut me down, said it was anecdotal, and berated me as an anti-vaxxer. So on behalf of my beloved daughter and the thousands of other vaccinated, injured who were shut down and robbed of fulfilling their lives and achieving self-fulfillment, I urge you to oppose Senate Bill 385. Thank you.
Thank you all for your testimony. I don't see any, we do have a question. Senator Reedy.
Thank you, Madam Chair, and thank you all for being here. And I was listening earlier to both panels. I had to be out of the room to present a bill to another committee. So if a question that I say was asked, I apologize. But I think I was curious, Sarah, Ms. Cusack, what is your take on it's been raised here that part of the challenge with this bill, from my perspective, is that we're sort of outsourcing all of a sudden our decision-making to professional organizations that are certainly reputable in many ways, but are not. They're interest groups. They're professional organizations.
Yeah, we did provide in our written testimony the corporate sponsors of the American Academy of Pediatrics. And basically, I just want to warn Maryland has to be careful as they deviate from the federal recommendations. So, right, you see the liability protection will not be available anymore if the Maryland recommendations deviate from the federal ones.
And I'm only asking one question to one person on the panel because we're trying to keep it brief. But I think Ms. Borick mentioned that AAP wants to get rid of. One of their positions has been that it's dangerous to have religious exemptions for?
Yes, they also still recommend the full COVID series for six-month-old babies.
Well, it's interesting you said that because that was presented before I had to step out. That was presented by, I think, the Lieutenant Governor or the Health Secretary as being like one of the shocking things coming out of the federal government, that somehow the idea that we might suggest that 6-month-olds don't absolutely have to have the COVID-19 vaccine is some sort of controversial take when most parents are questioning that. Is that?
Yeah, if you look at the uptake rate in the state, it's very low. Maryland has very high vaccination rates, which makes me think that some pediatricians are not recommending it. I feel like this bill is creating confusion.
Do you think pediatricians should be the ones generally recommending, like with
Yes.
childhood stuff, that people should because do pediatricians, they're required really as their code of conduct to be looking at the latest information from federal sources, state sources,
Well,
correct?
What's funny after hearing all of the testimony, I actually think that the VAX Act is doing the same thing that the federal government did. So the federal government reclassified some vaccinations as clinical decision-making, meaning that the parent and the patient work with the physician. And that's actually what the VAX Act is doing, because there are no mandates. It is saying you should work with your physician and make decisions. So that's why I didn't really feel it was necessary. I kind of feel like it's much ado about nothing. That's what the federal government is recommending anyway.
If you, and anyone on the panel, but if you have ideas about the bill that would, I don't know that, I don't think the bill's necessary either. I imagine it might at some point get movement, so we'd love to know if there are ways to maybe at least try to address some of these issues if the bill were to move forward. I appreciate the input from everybody today, so thank you. Thank you, Madam Chair.
Thank you. I don't see any further questions for this panel. Thank you for your testimony. We have two virtual people, Catherine Garrett and Jenna Butler. So Catherine, let's start with you if you'll unmute.
Hi, good afternoon. Thank you so much for hearing from me today. My name is Catherine Garrett. I am the chair of the Love Maryland PAC, and we have several concerns with SB 385. We would ask that the committee give an unfavorable report to the bill, as it is unnecessarily confusing for parents of our state and is contributing to the politicization of all healthcare policy. We have over 3,600 members in our state, many of whom are parents of young children. We're hearing a lot of confusion around access to vaccination, but the truth is that at no point did Maryland families lose access to vaccines, nor did their insurance companies here or anywhere else in the United States cut access to vaccinations. Media coverage has been unnecessarily sensational, and bills like this only cause trust in public health to further decline. Maryland is one of the best states in the nation for vaccination rates. 5 years ago, messaging coming from the governor's office was to never question CDC guidance on vaccination. Now, the governor's office is saying to not listen to anything that the CDC has to say. This bill is a recipe for distrust. It is very short-sighted and potentially harmful without any clear purpose or benefit to the public. For the people of Maryland, nothing has changed. Insinuating it has is harmful to faith in our public health policy. Having policies like this outside of the legislature are destructive to continuity. Today, we have a Democrat governor, but out of our last 4 governors in Maryland, 2 have been Democrats and 2 have been Republicans. Even within one administration, as we all know, there is a significant turnover in appointed positions. Marylanders deserve to have their elected officials making these important policy decisions to help ensure a continuity of policy. We elected you because we trust you, and we would ask that you do not outsource this policy making. With respect, we request that you return an unfavorable report on SB 385. Thank you so much for your time.
Thank you. And finally, we have Jenna Butler. You need to unmute, Jenna, if you can.
Yes, can you hear
There
me?
we go. Yes, we can hear you.
Okay, thank you. Sorry, that always gets me. Thank you, Chair Beadle and Vice Chair Hayes and the committee members for your time. I'm a mom and small business owner from right outside of Annapolis. And just to clarify, I heard this touched on for a second. I'll follow up with an email not to take up time, but the updated CDC guidelines did not remove anything. It just moved it. They were basically category reclassifications and not a removal of access or of anything from the guidelines. But my main concern is bringing these organizations into Maryland policy, the AAP, ACOG, and the AAFP. They all have corporate sponsors, including all of the major vaccine manufacturers. I'm a parent. I talk to a lot of parents, and I just feel like, I don't know if the money has introduced bias or what, but there's definitely a disconnect from these organizational guidelines and real life, what is actually happening. COVID vaccines for 6 months old, they're not recommending that at 6 months old. Later ages, but not at 6 months old. And the AAP constantly prioritizes that recommendation for 6 months old. So it just seems like there's a disconnect there. And it was mentioned over and over again, restoring confidence, the trust issue. I can tell you as a parent, and from talking to a lot of parents, this bill does nothing to restore confidence. The parents are being exhausted. They're finding political plays and corporate influence when they're looking for guidance. They can look to their pediatricians, but it's not necessary for this state to step in this way. It would really be a shame for the state of Maryland to burn so much trust and just add more confusion for Maryland families on a complete non-issue. I'd also like to add really quickly, by my count, only one of the 9 favorable speakers did not work in healthcare or mention Maryland's biotech companies. So please, I'd like you to also consider that, and I urge an unfavorable report. Thank you.
Thank you. Do I have questions for Jenna or Catherine? I don't see any questions. Thank you for your testimony. And that ends the hearing for Senate Bill 385. We're going to be out of order a little bit, budget and taxes voting, so we're going to now go to Senator Simonaire, if he's here. There he is, Senator Simonaire. Senate Bill 419, Health Occupation State Board of Massage Therapy Examine.
Can I have my panel?
Do you have a panel? Sabrina Lopez and Sharon Oliver. Yep, thank you.
Thank you, Madam Chair. Senator Brian Simonaire, for the record, Senate Bill 419. This is a consensus bill that follows up on the revisions made in 2022 to the practice of massage therapy and the transition process by, 1, authorizing an individual registered as a massage therapist practitioner to continue to practice beyond October 31st, 2026, altering the educational requirements for applicants from an out-of-state program, clarifying which entities may accredit a massage therapy curriculum, revising the administrative penalty, and lastly, altering the reinstatement provisions, including those on inactive status. I have the experts here with me today, and they can go into more detail, so I won't belabor it. And with that, I will ask for a favorable committee report.
We're trying to figure out what to do when half of our people that are supposed to testify are in budget and tax voting. Thank you for your patience, Senator. Do you want to go ahead? Thank you.
Good afternoon, Chair Bidell and members of the Finance Committee. My name is Sharon Oliver, and I'm the Executive Director for the Board of Massage Therapy Examiners. I'm here today to express the Board's support for Senate Bill 419 and to respectfully request a favorable vote. Senate Bill 419 addresses 3 important and practical issues. First, it repeals statutory provisions that would unnecessarily limit registered massage practitioners from continuing to practice in Maryland. In 2023, the General Assembly enacted legislation prohibiting the board from issuing initial registrations to massage practitioners after September 30, 2024. However, not all currently registered massage practitioners meet the requirements to convert to a licensed massage therapist status. If the existing statutory provisions remain in place, more than 1,100 registered practitioners would be prohibited from practicing after October 31st, 2026. This outcome would unnecessarily disrupt Maryland's massage therapy workforce. Repealing these provisions ensure continuity of care for the public while preserving appropriate regulatory oversight by the board. Second, the bill repeals obsolete statutory language related to qualifications for RMPs. Because the board no longer has the authority to issue new registration, the provisions no longer serve a regulatory purpose, and we are requesting that they be removed so that they do not confuse the licensees and the public. And third, the bill clarifies requirements for individuals to return to practice after being in inactive or non-renewed status for more than 5 years. The bill, because the board can no longer issue registrations, they are required to qualify under the new licensure standards. We ask for a favorable vote, and we would like to thank Senator Simonier and Augustine for sponsoring the bill and for your time.
Thank you, Sharon. And Sabrina.
Good afternoon, Chair Bedell and members of the Finance Committee. My name is Sabrina Lopez. I am the Vice Chair of the Maryland Board of Massage Therapy Examiners, and I'm here today to request a favorable report on Senate Bill 419. This bill introduces critical reforms to the licensure of massage therapy, prioritizing public safety, professional accountability, and administrative efficiency. By closing existing regulatory gaps, this bill ensures that the facade of legitimate practice cannot be used to mask illicit activity. The board supports establishing clear and transparent licensure pathways for applicants educated outside of Maryland. This bill ensures that graduates of out-of-state massage therapy programs meet the same educational standards required of in-state graduates. Given the national proliferation of diploma mills, this provision closes a potential loophole that could otherwise allow inadequately trained individuals to obtain licensure. Strengthening these requirements protects consumers and maintains the integrity of the profession. The bill authorizes the board to require a state and national criminal history background check when a license or registration is reactivated and after 5 years or more an inactive or non-renewed status. When the criminal background check requirements became effective on October 1st, 2016, they were not retroactive and did not apply to individuals who were already licensed or registered at that time. Currently, 206 inactive licensees and registrants were credentialed prior to the enactment of this requirement. If these individuals return to active practice, this provision ensures a comprehensive background review and supports the implementation of the FBI's RATBAC program for massage professionals. Under the current law, the board is required to hold an administrative hearing before imposing a civil penalty for minor violations, such as failing to notify the board of a name or address change within 60 days. The cost of conducting such hearings often exceed the maximum allowable penalty of $100. Eliminating the hearing requirement for minor non-disciplinary violations reduces unnecessary administrative burdens. We urge you to give a favorable report. Thank you.
Thank you for your testimony. I don't see any questions. Well done, Senator. Thank you. I think next we're going to go to Senator Guile. Senator Giles' bill. Public Health Senate Bill 394, Public Health Expedited Partner Therapy, and it's your panels, Anna Powell, Robin Elliott, and Christine Crone. Are they here?
You know,
Yep. I see Robin.
I don't see Christine. I'll see if she's out in
I know we're bouncing around a little bit.
We left her sticker.
She got it. We got it.
Well, I guess we'll just get started.
Okay, thank you.
Madam Chair, Mr. Vice Chair, members of the committee, I'm here to present Senate Bill 394. This bill we'll just start off as a bit of background. Expedited Partner Therapy, or EPT, enables providers to prescribe, dispense, or otherwise provide antibiotic therapy to a partner of a patient diagnosed with a sexually transmitted infection without first examining the partner. In Maryland, we currently authorize expedited partner therapy for chlamydia, gonorrhea, and trichomoniasis. I'm thinking that's right. Trichomoniasis. SB 394 would add bacterial vaginosis as a condition authorized
to be treated by expedited partner therapy in Maryland statute. I've also submitted a clarifying amendment to ensure that licensed certified midwives acting within their scope of practice may provide expedited partner therapy where otherwise authorized. This bill was inspired by new guidance issued in October 2025 from the American College of Obstetricians and Gynecologists, which aims to change the way people experiencing recurrent bacterial vaginosis are treated. You will hear today from Dr. Anna Powell. Actually, I'm not sure if she's here, but who authored ACOG's clinical practice update on this topic. This guidance follows new data and increasing evidence supporting the efficacy of sexual partner therapy in reducing recurrences of bacterial vaginosis. Recurrent bacterial vaginosis is extremely common. Up to 66% of women experience a recurrence within 1 year of treatment of the original diagnosis. If recurrent bacterial vaginosis goes untreated, it can pose significant clinical risks over time, including increased susceptibility to sexually transmitted infections, a higher risk of pelvic inflammatory disease, and for pregnant patients, potential pregnancy-related complications, including preterm birth and post-delivery uterine infections. Historically in Maryland, there has been no opposition on this issue. The most recent bill was in 2017, Senate Bill 110, which added trichomoniasis to the expedited partner therapy statute. There is no fiscal note associated with this bill for these reasons, or fiscal impact associated with this bill. And for these reasons, I respectfully request a favorable report on Senate Bill 394. Thank you.
Good afternoon, Chair, Vice Chair, and members of the Finance Committee. Thank you for the opportunity to testify. My name is Christine Crone, and I'm here on behalf of the American College of Obstetricians and Gynecologists, the Maryland section. On behalf of Maryland ACOG, which represents Maryland physicians who provide obstetric and gynecological care to women and families, we support Senate Bill 394. For decades, bacterial vaginosis was treated as solely a woman's issue, even though bacterial vaginosis-associated bacteria was known to be present on male partners. Treatment focused only on the patient, leading to high reinfection rates. That all changed with a 2025 landmark New England Journal of Medicine study called the Step Up Trial. Researchers followed 150 heterosexual couples. Women received standard antibiotics, and half of all male partners received oral and topical antibiotics. The results were so strong that the study was stopped early so that all participants could receive partner therapy. The conclusion was clear. Bacterial vaginosis can be sexually transmissible, and treating partners can dramatically reduce its occurrence. The study was a turning point in gynecology. It validated what clinicians had long observed in practice, that reinfection often comes from untreated partners. Following publication of the New England Journal of Medicine study, ACOG issued updated clinical guidance recommending that clinicians consider treatment of sexual partners for patients with recurrent bacterial vaginosis. Partner treatment reframes bacterial vaginosis as not a you problem, but a shared health issue with a sexual partnership. Regardless of terminology, the science is clear. Ignoring partner treatment has harmed patients, and evidence-based policy now allows us to do better. I'd like to highlight that the bill does not have a fiscal note, and for these reasons, we urge a favorable report. Thank you.
Good afternoon. Robin Elliott here on behalf of the American College of Nurse Midwives in support of the bill. We wanted to thank Senator Dial for sponsoring an amendment clarifying on which type of midwives can provide expedited partner therapy. We very much appreciate it. We looked at and discussed the ACOG recommendation, so thank you. And so it was an unequivocal and unanimous support among the nurse midwives. Thanks so much.
Thank you. I don't see any questions.
Thank you.
Well done, Senator. Thank you very much. That ends the hearing on Senate Bill 394. Next, we're going to have our very own Senator Kramer, Senate Bill 333, Interstate Podiatric, did I say that? Medical Licensure Compact. And do you have Richard Block and Priya Parthasari with you?
Good afternoon, Madam Chair, Mr. Vice Chair, members of the committee. Ben Kramer to introduce Senate Bill 333, which is the Podiatric Medical Licensure Compact. Colleagues, Senate Bill 333 establishes a voluntary expedited licensure pathway for podiatrists who are already licensed and in good standing in a member state to obtain licensure in another compact state. Importantly, this bill does not alter Maryland's Podiatric Medical Practice Act, nor does it diminish the authority of the Maryland Board of Podiatric Medical Examiners. Under the compact, podiatry is practiced where the patient is located, meaning that any podiatrist treating a Maryland patient remains fully subject to Maryland law, Maryland regulations, and Maryland disciplinary authority. State sovereignty is absolutely preserved. Licenses are still issued by Maryland, and Maryland retains full control over scope of practice, investigations, and discipline. SB 333 responds directly to Maryland's growing need for podiatric providers, particularly as our population ages and demand for foot and ankle care continues to rise. The compact modernizes licensure while reducing unnecessary red tape for already vetted professionals, making it easier for Maryland to recruit and retain podiatric specialists without lowering standards. This approach is neither new nor experimental. Maryland already participates successfully in licensure compacts, including the Interstate Medical Licensure Compact, which, by the way, colleagues, this compact models identically, hence my little visual aid here, which I will hold up to document that, as well as Nurse Licensure Compact. The Podiatric Compact is virtually identical in structure and function to the Physician Compact, allowing greater workforce mobility while preserving state authority and patient protections. Momentum is building nationally as Iowa, Arizona, and Florida have introduced legislation. Arizona's bill has moved through the House, and Pennsylvania, Michigan, Connecticut, Ohio, and the District of Columbia are expected to introduce this legislation, and other states, including Texas, Massachusetts, and North Carolina, are getting ready to do the same. Eligibility standards under the compact are rigorous to participate, and a podiatrist must have completed an accredited educational program, approved residency training, passed national boards exams, and maintained a clean professional and criminal record. This compact expands access without compromising professional standards. You're going to love this, Senator Lamb. Patient safety is further enhanced through interstate information sharing, coordinated investigations, and mutual recognition of disciplinary actions. The compact does not interfere with Maryland's existing systems. Instead, it strengthens oversight by allowing regulators to communicate more effectively across state lines. You will see that the Maryland Board of Podiatric Medical Examiners submitted a letter of concern, and I am going to address that. And colleagues, you have on each of your desks, as well as in your computers, my commentary with regard to that concern. And I will also share with you that the rest of the planet supports this bill. That letter of concern originated at the last minute this past Friday, and I believe the concerns that were expressed in that letter are in fact misplaced and represent a misunderstanding of what this bill does. With that, let's quickly address those concerns. Again, you have a letter on your desk that more thoroughly, point by point, responds to everything that was brought up. And real fast, once again, I want to show the committee that this compact models the exact same physicians compact that was passed in 2018, implemented in 2019, and has been working flawlessly. And that's the model for this compact. So in the letter of concern, there was some reference to this bill creates some kind of a super board, and there would be a loss of state authority. The fact of the matter is, the Interstate Podiatric Medical Licensure Compact Commission is not a super board and does not replace or supersede the Maryland board. Maryland remains the sole authority that issues Maryland licenses, defines the scope of practice, investigates complaints, and disciplines podiatrists practicing in Maryland. There is the assertion in the letter of concern that an applicant who does not qualify for licensure in Maryland could nonetheless somehow mysteriously receive a Maryland license, which is absolutely incorrect. Every compact license is in fact a Maryland license issued by the state of Maryland and governed by Maryland law. The board expressed concern the commission becomes an unnecessary gatekeeper. And the fact of the matter is, a podiatrist must maintain a full, unrestricted license, remain free of disciplinary or criminal disqualification, and Maryland retains the ability to impose additional discipline, monitoring, or license action under state law at any time. So in conclusion, Senate Bill 333 is modeled directly on a proven, successful framework already operating here in Maryland. The concerns raised by the board are largely speculative, inconsistent with existing compact experience, and not supported by the bill's text. With that, I ask for a favorable report. Thank you, Madam Chair.
Thank you, Senator. Your panel can go ahead.
Sure. All right. Dear Madam Chair and members of the committee, my name is Dr. Priya Parthasarathy. I'm a Maryland licensed podiatrist and president of the Maryland Podiatric Medical Association, representing over 266 podiatrists. I'm here today in support of Senate Bill 333, the Interstate Podiatry Licensure Compact. Podiatrists are licensed healthcare professionals who diagnose and treat conditions of the foot and ankle, care that is essential to mobility, independence, and overall health. We care for our patients with diabetes, vascular disease, trauma, and chronic pain, and we play an important role in preventing hospitalizations and amputations. Maryland is facing a shrinking podiatric workforce. Enrollment in podiatry medical schools has been declining nationally. The pipeline of young podiatrists is limited, and Maryland has only one in-state podiatric residency program. At the same time, our population is aging, and the demand for foot and ankle care continues to grow. These challenges make it increasingly difficult to recruit and retain podiatrists in our state. The Interstate Podiatry Licensure Compact is a common sense and patient-centered solution. One of our members, and a good friend of mine, works in a two-podiatrist office in Cumberland, Maryland, and shares that they're the only practice between Hagerstown and Pittsburgh, and sees up to 40 patients a day, 5 days a week, with 40 exceeding the average of most podiatry clinics. The surgical podiatrist is scheduled out to November 2026, and this does not include inpatient podiatry, wound care, and complex reconstructions requiring hospital admissions. These patients are seen across state lines. For Maryland patients, SB 33
improves access to timely pediatric care, particularly for seniors, patients with diabetes, and individuals in rural and underserved areas. As a podiatrist deeply committed to Maryland and to the patients I serve, I respectfully urge a favorable report on Senate Bill 333.
Well done, thank you.
Thank you, Madam Chair and members of the committee. My name is Richard Block. I'm the Executive Director and General Counsel to the Maryland Podiatric Medical Association, and I'm here along with Dr. Paratharthi to ask for your favorable report on Senate Bill 333. In view of the exceedingly well-documented information provided by the sponsor, I will not try and repeat everything. Rather, I would like to address the fact that I was shocked by the late emergency meeting called by the Board of Podiatric Medical Examiners last Friday for a 7:30 emergency meeting to discuss this bill. The board had long been aware of this bill, having received the first draft in October of 2023, and had previously indicated its support for the bill, having heard from numerous resources explaining the bill and there being no such concerns raised. However, the concerns were raised. Senator Cramer has very nicely addressed most of those concerns. They are without foundation and unsupported by the authority granted only to the State of Maryland Board of Podiatric Medical Examiners. It does not take away any of that authority for anyone admitted to practice podiatry in Maryland through the Interstate Commerce Compact. The only issue which has not been addressed is the potential financial impact on the board. And I would like to say that all of the startup technology or infrastructure costs to the state are non-existent. Startup technology and services are covered through existing medical compact commission infrastructure and grants. These are funded. The other costs are through the application fees paid by the applicant through the compact. Thank you very much, and I urge your support for this bill.
We have a question from Senator Lamb.
Thank you, Madam Chair. So looking through the bill folder, the only oppositional testimony is from the Board of Podiatric Medical Examiners.
Letter of concern, Senator. Letter
of concern. Okay, all right. To be clear, yes. You know, I guess they point out this, concern about the format mimicking a super board, which, I'm just a little bit skeptical about. I think, when we look at how these other compacts have been created by this body for other health occupation specialties, this one compared to others is actually pretty narrow, like in how it's being crafted. And this whole contention that it is a super board, I think, we just haven't seen that occur with any other, with any other compacts that have existed out there. And so, has there been additional conversation with the board? Have they,
If I can respond to that, sure. And I'll let Dr. also. No, there is not, because they held this meeting on Friday at 7:30, 7:45 in the morning. They already had this letter of concern prepared, apparently, because it was filed promptly after the meeting. And we tried to explain to them that these concerns were unfounded based on the language of the bill and the corresponding operation of the medical interstate compact that has been very successful.
Right, and so in this instance, if this compact were to be established, an applicant that may have a podiatric license in another state would be able to essentially have a fast track to get licensed here in the state of Maryland, right? They would still, there are some compacts out there where you don't need to actually get a license here in the state of Maryland, where because of the compact and because you have a license somewhere else, it kind of dually covers the state of Maryland. This instance is even more narrowly crafted, where an individual that has a license somewhere else still needs to get a license in the state of Maryland. This just expedites that process to be able to get them that license here in Maryland faster. So it's not as though, in the instance of how other compacts are created, they don't need a Maryland license. In this instance, if this were established, they would still need a Maryland license.
I'm familiar with the SIPAC because I represented the association when it was passed. And that's exactly what that PAC does, which this PAC does not. You have to apply to each state. Yes.
Yes, I recall SIPAC as well. And, you know, I imagine some of their concerns with the board, maybe, you know, I guess the fees that might be generated for that, you know, that it may have some budgetary impact, for example, to the board. But this bill, based on how I'm looking at it, still allows the board to charge a fee, right? So there shouldn't be any budgetary impact to the board.
That's correct. And the board, the compact is funded. It's gotten a grant. And Dr. LeBeau, who's here unofficially, is in charge of the compact on behalf of the FPMB, the National Board of Podiatric Medical Boards. And they have a significant amount of funding for this commission to go forward. And the fees for application are still paid for each applicant to the Maryland Board.
And I just want to add to that, that we had every opportunity for questions. I held an open information session with all Maryland members. Everyone was invited. I gave a presentation to the board. Dr. LeBeau gave a presentation to the board. I've personally attended their open board meetings, especially their last two. I also held an open information session at our last state meeting. So there's plenty of opportunity for any concerns to be addressed.
And this should not, if the board chooses to still have a fee requirement for people that qualify under this compact, that should not affect the budget of the board itself, then, right? So there should be no budgetary impact. And the compact also does not affect the laws governing the regulation of podiatry in Maryland, right?
Not at all.
That all stays the same.
Not at all.
Okay. All right.
I told you you'd love it, Senator Lamb.
All because of the sponsor. So, but you know, I think this has been very narrowly crafted, and you know, I think has taken some of the lessons learned from other PACs. You mentioned SIPAC. You know, I recall that from a couple years ago, to have the most minimal impact and yet be able to help support those podiatrists who want to come into the state of Maryland. Thank you.
Thank you, Senator Lamb. I don't see any other questions. Thank you for this hearing on Senate Bill 333.
Thank you, ma'am.
Thank you very much.
Thank you. So we have our first member from the Budget and Tax Voting Session is here. So Senator Hettleman, would you like to come up for Senate Bill 340? See if you have a panel.
Do you have a panel?
You do? Okay, bring your panel up. Carrie Craig, Roxanne Montgomery, and Sarah Westbrook.
Hi, how are you? Thank you very much, Madam Chair, Mr. Vice Chair, members of Finance. I'm very happy to be here today. I'm Shelley Hettleman, Senator from District 11 in Baltimore County, and I'm here today to present Senate Bill 340. This bill really, the long and short of it is to get some additional funding to the Office of the Ombudsman, the Long-Term Care Ombudsman. This is a really, really important program, and its importance will only continue to grow over the near and middle term. It exists to protect the health, safety, dignity, and autonomy of older adults and individuals with disabilities who live in nursing homes, assisted living communities, and other long-term care settings. They advocate for residents in situations including routine quality of life concerns and access to services, as well as serious cases of abuse and neglect. And my written testimony has the data in terms of the number of visits they have made to nursing homes and assisted living communities, the number of complaints, and the number of educational events they host in the community. I know if your office is anything like mine, you get calls regularly from constituents who are frustrated and concerned about their loved ones, about themselves. And we have regularly called our local ombudsman, and they've been incredibly, incredibly helpful. We have the state ombudsman, and you'll hear directly from her.
This is, as I said, an issue that is only going to continue to grow because the number of people turning 80 each year will almost double in the next 15 years. That will be growing at an average of 4% per year, and that is more than double over the last 15 years. The boomers, whether we like it or not, and technically I'm the last year, I was born in the last year of the boomers, so I don't really identify, but is coming of age and will need more and more services, and that's why the services of the Ombudsman's office is more and will continue, just grow in importance. There's a lot more information in my written testimony. In the interest of time and in the interest of the expertise of my panel, I will end it there. Happy to answer any questions you will have. I will say one thing. One of the controversial thing, the most, I think, controversial thing of this bill is its funding source. We are very aware of that. I serve on the Budget and Tax Committee. I've had a conversation with my chairman about it. It makes sense to me intellectually that this would be the funding source, but I also understand that diverting some of these funds does have an impact on our federal funds that come into the state. And so I am happy to have that conversation and to continue to work with the committee on how best we can get to our goal and increase funding to this very, very important office. So thank you.
Good afternoon, Chair, Vice Chair, and members of the committee. Thank you so much for this opportunity. I'm Carrie Craig. I'm the State Long-Term Care Ombudsman. I first want to say that we in no way want to take money from residents or nursing homes. That's not who we are. That's not what we do. We believe that there's enough money in this fund to also support the Ombudsman program. About 12% of states across the country utilize this program for these funds for this purpose. We recently received a call from a resident who was involuntarily discharged with no notice to what we believe is an unlicensed assisted living. She was cold, her needs weren't being met, and she was scared. She called the local ombudsman. That ombudsman advocated and got her right back to the nursing home, which she considered to be her home. We receive calls on a regular basis from residents saying that their direct care workers tell them, because they're understaffed, just go to the bathroom in your diaper. There's no dignity in that. There isn't. I don't want to live like that. I'm sure none of you want to live like that. And the residents in long-term care absolutely don't want to live like that. We are increasingly concerned about funding, Medicaid funding. If the cuts happen at local levels, more people will end up in long-term care. If our funding, which is very vulnerable, is cut at the federal level, then we're going to be sitting here next year behind the 8 ball saying, we need more funding. And residents there'll be a higher rate of abuse and neglect because they don't have an ombudsman to advocate for them. And OHCQ will be inundated with phone calls because the 4,000 complaints that we resolve to the satisfaction of the resident will go directly towards them. So this program is so important, and we need a favorable report on this, please. Thank you.
Good afternoon, Chair Beidel, Vice Chair Hayes, and members of the Finance Committee. Thank you for the opportunity to testify on Senate Bill 340, and thank you to Senator Heddleman for sponsoring this bill. My name is Sarah Westrick, and I'm the Advocacy Director for AARP Maryland. I'm also a member of the Oversight Committee on the Quality of Care in Nursing Homes and Assisted Living Facilities. AARP Maryland represents 850,000 members in the state, many of whom rely on high-quality nursing home and assisted living care. SB 340 makes a targeted, responsible adjustment to the nursing facility quality assessment by dedicating a small portion of existing revenue to support the Office of the Long-Term Care Ombudsman, all without affecting the primary purpose of that assessment. At its core, this bill is about strengthening resident protections and stabilizing an essential oversight function. By dedicating just 3% of assessment revenue, SB 340 creates a reliable, predictable, and ongoing funding stream for the Ombudsman's office. And this point is extremely important because last year, the federal government withheld or delayed funds, and this created an enormous amount of uncertainty and unnecessary stress across the system. This bill ensures that the Ombudsman is never put in this position again. With predictable funding, the office can shorten response times, expand outreach to residents and families, and maintain continuity in staffing and training. Ultimately, this means better oversight, quicker problem solving, and stronger protections for residents across the state. In sum, SB 340 is a meaningful investment in independent oversight that strengthens accountability and protects residents. We respectfully request a favorable report on SB 340.
Good afternoon, Chair Beidel, Vice Chair Hayes, and members of the Senate Finance Committee. My name is Roxanne Montgomery. I live in Howard County. I am a member of AARP Maryland's volunteer advocacy team, and I appreciate the opportunity to testify in support of this bill. For 8 years, I was the primary caregiver of my parents in their home. When my father had a stroke, both my parents needed 24-hour care, and this started a 2.5-year period of long-term care facilities where I witnessed repeated instances of dangerously inadequate care. I would spend 12 to 24 hours a day at my mother's side, ensuring her medications were correct and verifying that her care plan was followed. A turning point came when I returned from an unavoidable 24-hour absence to find my mother on a broad-spectrum antibiotic. I asked staff members why it had been prescribed. No one knew, and no one expressed a plan to investigate. Out of options and distraught, I called on Howard County's long-term care ombudsman. The ombudsman was professional, responsive, and incredibly supportive. Within days, inspectors arrived, conducted an audit, and their findings were later published in the CMS's website, confirming my concern not only about my mom's medication, but similar issues with other residents. Ultimately, I learned that a nurse could not read an illegible prescription and had transcribed the wrong patient's name. Most families, especially those new to long-term care, don't know how to effectively advocate when something goes wrong. Ombudsmen serve as educators, problem solvers, and watchdogs. Ombudsmen help families. They support good providers, and they provide state agencies with reliable insight into problems that require intervention. To ensure this essential work continues, stable funding for the long-term care ombudsman is critical. For that reason, I respectfully request a favorable report on SB 340.
Thank you for your testimony. Senator, the concern is the budget number, so you'll work on that for us. All right, thank you very much. Thank you for your testimony. I don't see any questions of this panel. Next, if I can have Megan Peters from the Alzheimer's Association and Cornelia Bright Gordon, Maryland Legal Aid.
Good afternoon, Madam Chair, Mr. Vice Chair, members of the committee. My name is Megan Peters, Director of Government Affairs for the Alzheimer's Association here in Maryland and in support of Senate Bill 340. This bill will create a stable, reliable funding source to support the long-term care ombudsman operations. This stability is essential to protecting the health, safety, and well-being of residents living with dementia in long-term care settings. People living with dementia make almost 50% of Maryland's nursing home population and almost 40% of residents in assisted living. These are individuals who cannot always speak up for themselves, and they rely on the Ombudsman program to address concerns and protect their rights. We also see from the Ombudsman annual report just how significant the demand is for their services. The numbers tell a clear story. Residents depend on this program. And without this stable funding, Maryland is at a real risk of losing Ombudsman staff if federal support decreases. SB 340 will strengthen protections for thousands of Marylanders living with dementia by ensuring the Ombudsman program can keep following up on complaints, visiting facilities, and protecting residents. For these reasons, we urge a favorable report. Thank you.
Thank you. And Cornelia?
Thank you. Chair Beidel, Vice Chair Hayes. My name is Cornelia Bright Gordon, and I am from Maryland Legal Aid. We thank you for the opportunity to submit testimony in support of Senate Bill 340. We've also submitted written testimony in support of the bill. Legal Aid is a nonprofit law firm that provides free legal services to low-income and vulnerable Maryland residents. Many of our clients are living with disabilities, and most also depend on Medicare, Medicaid, veterans benefits, and these programs form the safety net that provides life-sustaining assistance to people living below the poverty line. Maryland Legal Aid has maintained a dedicated practice representing nursing home and assisted living residents for more than 45 years. The Office of the State Long-Term Care Ombudsman is mandated by the Federal Older Americans Act. The program is designed to prevent and investigate abuse and neglect of vulnerable, disabled, assisted living, and nursing home residents. 1 in 10 older adults report abuse. As the percentage of older adults increase, so does the likelihood of abuse or neglect. SB 340 would not take funds away from the residents of facilities. It would rightfully be used to ensure a small funding stream devoted to the protection of assisted living and nursing home residents. Maryland Legal Aid strongly recommends that the bill receive a favorable report, and we urge the passage of SB 340. Thank you very much.
Thank you very much. Do you have any questions for this panel? I do not see any questions. Thank you. Thank you. Our last person to testify on this bill is an unfavorable, Dana Kaufman.
Always alone. Good afternoon. For the record, my name is Dana Kaufman. I'm here on behalf of Lifespan Network, and we do oppose this bill. But what we do agree on is that the long-term care ombudsman, which is federally mandated, needs to have a sustained funding stream and that they are underfunded. But at the same time, we cannot support this funding stream. The nursing facilities are also underfunded. And I want to be very clear, and I'm using the information from the recent report on the quality assessment because the numbers have been a little different depending on what you're looking at. But what this really would do, given the amount of money that is generated from the nursing homes paying this provider tax, it would generate about $5 to $6 million. But when you remove that from the nursing facilities, you're also removing the federal match, which brings it to about approximately $12 million, which translates to about a 1% rate increase. If the governor's office in the budget had reduced our rates by 1%, we would be opposed to that as well. So we agree that there needs to be a sustained funding. It doesn't seem to be the best source to have that money coming directly out of our rates, which is going to impact our ability to provide care. So we're happy to work with trying to figure out a sustained funding source, but I think that's the issue for most Medicaid providers now. We did not see any rate increase this year, nor did we see a rate increase last year, but our costs are going up. Our costs went up about 6% year over year. So that is our main concern, and we don't want to see this continuing to become a pot of money for other uses. So with that, I would request an unfavorable. Thank you.
Thank you, Dana. I don't see any questions. Thank you for your testimony. And that ends the hearing on Bill 340. I think next we have Senator Karen Lewis Young. And I'm flipping all over the place today. We have a lot of changes. Senator Lewis Young, you're doing Senate Bill 380. Physicians licensing internationally trained physicians, and you have Jen Krenke and Lisa Robin as your panel. Thank you.
Thank you. Good afternoon, Madam Chair and Mr. Vice Chair, committee members. This is a bill that should sound familiar to you. It crossed over last year. It's been heard in the House 2 prior years. So I'm just going to try to do a refresher for you. It is about international physicians and their licensing. You are well aware of the physician shortage in the United States, in particular our state. Senator Kramer elaborated on it just a few minutes, or maybe it was an hour ago. But what this bill does is it tries to provide a pathway for internationally trained physicians to practice in our state. At the core of the legislation, it's an effort to address a very burdensome requirement that's placed on international medical graduates under our current law. So there is a pathway. It's just very redundant and complex. So, for example, an internationally trained physician who has completed postgraduate training in another country would have to complete another 2-year residency here in the United States as we are operating today. This is true even if that physician has had significant practice experience abroad. And it is that group of physicians that we're trying to focus on in this legislation. During the 2024 interim, there was a work group. At least 2 of you were on that work group. It was conducted by the Maryland State Medical Board, and the work group studied licensure of foreign trained physicians and international medical graduates. I'm going to refer in the future to those two groups as FTPs and IMGs. So this work group that Senator Lamb and Senator Beidel participated in looked at the challenges that were faced by these 2 groups, looked at models in other states, and made recommendations from the Advisory Commission on additional licensing models, originally formed by the Federation of State Medical Boards. So the bill you have before you is largely based on this recommendation. You'll also notice an implementation date of October 1st, 2028. So this rather long implementation time frame allows for not only further examination of other states' best practices, but a sufficient amount of time for the board to do all the preparatory work in establishing a reasonable standard of care. So I'm not going to go through all of the aspects of the bill, but the highlights are just that the individual will have completed the equivalent of 2 years of postgraduate training in their previous country, provide proof of practicing medicine for at least 5 of the most 7 recent years, pass a U.S. licensing exam, and show that they're in good standing in their country's medical licensing board, and of course, pass background checks. Since this work group was formed in 2024, this concept has expanded throughout the country. There are now a total of 18 states which have some form of licensing. 2 things are of interest to note. One, they represent the entire country from a regional perspective. And the other thing is it's very bipartisan if you look at the states. Actually, I'll add a third observation, and that is our neighbors. Virginia has passed an interesting model, and I say interesting because they're all somewhat debatable. And that is, as I see it, competition for us. Pennsylvania has a process in place, and I believe they are scheduled to enact it sometime in March. In fact, there are about 20 additional states above and beyond the 18 I mentioned that are in some form of a proposal moving forward. I might also mention another reason why addressing this shortage is so important. All 24 of Maryland's counties are federally designated primary care shortage areas, and particularly areas of shortage we have a total of 57 primary care health professional shortage areas and 49 mental health shortage areas. The particular practice areas that are undergoing the most shortages are anesthesiology, cardiology, gastroenterology, primary care, and radiology. So by providing a clear pathway, which the stakeholders in this group have essentially been working on for 3 legislative sessions, we do truly believe that we can strengthen healthcare and achieve a more diverse medical expertise in our state. 2 concluding comments. One is about the fiscal note. I just want to remind everyone that the State Medical Board is a special funded entity and has a fund balance that can be used towards implementation of this program and the hiring of a licensed analysis. Also, you'll notice there are a couple of amendments, far fewer than previous years. We really have come together in working out some compromises. Several of these just came in Friday evening. One looks very reasonable. Another one, I do have some concerns about the risk of utilizing foreign-trained physicians as inexpensive labor. So I think that we might need more work on that one. Certainly the MedChi amendment is very reasonable. And with that, I thank you for your time. Hope this is the year we can move forward on this and pass it on to my panel.
Thank you, and good afternoon. I am Lisa Robin, the Chief Advocacy Officer at the Federation of State Medical Boards, and I speak in favor with amendments to SB 380, Physicians Licensing Internationally Trained Physicians, for the following reasons. SB 380 creates an additional licensure pathway for certain internationally trained physicians, just as similar legislation has been enacted in 18 other states. Although there are commonalities among them, there are key differences in the provisions that can create confusion among employers, physicians, regulators, and patients. For this reason, in 2023, the Accreditation Council for Graduate Medical Education, the FSMB, and InThealth established an advisory council to study the various approaches being discussed and issue guidance to address both eligibility and a process to safely transition from a provisional or limited license. The council's goal was to meet the legislative intent to expand patient access to care without compromising patient safety. In developing its recommendations, the Council heard from regulators, policymakers, think tanks, physician and hospital professional organizations, and the public. While SB 380 is largely aligned with the Advisory Council recommendations, the FSMB urges the committee to consider the following 3 amendments, also supported by the Maryland Board of Physicians, and, if accepted, will strengthen the legislation. Number 1, referring to the credential as a limited license better communicates to the public its supervised scope-limited nature and distinguishes from a full unrestricted license. Number 2, requiring the issuance of the limited license to be dependent upon an employment offer with an appropriate clinical facility which has the capability to supervise and assess the physician during the limited licensure period. And number 3, adjusting examination timing to expand eligibility while preserving standards, requiring passage of steps 1 and 2 of the United States Medical Licensing Examination for entry into the pathway, a complete employer-based assessment and successful passage of the USMLE Step 3 should be completed prior to determining eligibility for a full and unrestricted medical license. Thank you for the opportunity to testify, and I welcome any questions. Thank you.
Go ahead, Jane.
Hi, good afternoon. Thank you, Chair Beidel, members of the Finance Committee. My name is Jane Krinke. I'm here on behalf of the Maryland Hospital Association in support of Senate Bill 380. Really appreciate the sponsors' work on this and the work of the work group on this legislation. As you know, Maryland hospitals really struggle to recruit physicians, especially those in rural and underserved areas. We have the highest need in primary care and certain specialties like cardiologists, anesthesiologists, things like that. And there are many barriers that internationally trained physicians face when they're looking to practice in Maryland, and it makes it challenging to recruit. So although this bill, it won't remove all the barriers around licensure, but it would help ease some of the challenges for those internationally trained physicians that are living here in Maryland. The current pathways to licensure for internationally trained physicians are very cumbersome. Like the process of conceded eminence has an extremely high bar where you have to have proof of extensive research experience, you have to have contributed to the field of medicine by developing a surgical technique, things like that. In addition, the J-1 visa program only has 30 slots for the whole state. So anything we can do to really improve the licensure process will help in that international recruitment. And we look forward to continuing the conversation about how we can improve these pathways. And so with that, we ask for a favorable report. Thank you.
Thank you. Do I have any questions for this panel? Senator Lamb?
Conversations about this, and I think, I have a bill coming up later, I think for hearing next week, similar but different flavors, and happy to continue to work with you on that as well. I think the issue is very complex and complicated, as kind of was referenced here. We want to make sure we kind of balance all the stakeholders out, so look forward to continuing the conversation, so happy to have that.
Thank you so much.
I don't see any other questions. Thank you very much. We have obviously 2 in opposition. Well, really favorable with amendment, so that's good. Thank you for this testimony. Michael Tran from the Maryland Board of Physicians and Steve Wise, MedChi.
Thank you, Madam Chair, members of the committee. Steve Wise on behalf of MedChi. I think our amendment's a little simpler maybe than the board, so maybe it's good that I went first. Our involvement with this came after Delegate Hill first put the bill in a number of years ago. We participated on the work group that was alluded to. And really, the stickiest issue during the work group remains somewhat the stickiest issue now, which is currently, if a physician comes here after working internationally, they still have to do a residency. And in some cases, that's repetitive. The question is, how do we measure whether or not the residency that was done overseas is substantially similar to a residency that would have been done here? Coming up with that standard is one of the areas where Senator Lamb's bill differs from this bill. And this bill purposefully delays implementation for two years while that provision, among others, is worked on. We simply offered an amendment to make sure we're part of that process as it goes forward. And we'll also be here in support of Senator Lamb's bill, which takes a slightly different approach. Thank you.
Michael?
Good afternoon, Madam Chair, committee members. For the record, Michael Chan with the Maryland Board of Physicians. First, Dr. Harry Arjawad, our board chair, was supposed to be here to testify today. He's a little bit under the weather, so he just wanted to send his apologies, as well as thanking the senator for her leadership and hard work on this bill. You have our written testimony that kind of goes into depth, so I'll kind of just touch on the amendments that we're proposing. As Senator Lamb said, this is a very complex issue. I think we're all on the same page as this is a good workforce solution. But just kind of going about it is kind of where we kind of want to nitpick. And in regards to last year's bill, this is kind of in the same posture and language as last year's bill, so we wanted to continue the conversation and kind of talk to FSMB and the other states that have started implementing this type of legislation to come up with areas and points where we can kind of deviate or make this better legislation for our state. So first off was the large fiscal note from last year. We wanted to figure out a way to kind of address that, and we kind of did it to kind of do two birds, one stone here. So with the fiscal note, I think we had around a $2 to $2.5 million fiscal note with this last year, and incorporating a supervision aspect into this bill, which was recommended by the advisory commission, would kind of remove and lower that fiscal note in the sense of with having a supervision or employment requirement, there's going to be some oversight for these individuals outside of just reviewing documentation and kind of transcripts from other nations. With that, we don't have to solely rely on a third party for their credentialing and or their evaluation of these physicians. So if we have something else to lean on, as in a hospital and employment supervision, we can kind of have two areas where there is oversight and two guardrails where it can allow these people to come in and kind of work more. I know that was my time, but you have a written testimony, and can I address any questions you may have?
Council tells me we have the amendments from MDH, so obviously we'll work on that. Will there still be a fiscal note?
So there will still be a fiscal note, but we expect with these amendments, it would be drastically lower and something very much more palatable than in the million range. We would still have to bring on additional staff and kind of go through those areas, but the credentialing aspect of this was the big part of the fiscal note. That alone was around $150,000 a year just for those services alone, and we think this would just kind of remove all of that.
Thank you. Senator Land?
Yeah, thank you, Madam Chair. This question, I guess, more for the board. Thank you for that information. I just want to clarify current law first. I think, so under current law, the Board of Physicians has the ability to be able to grant licenses to foreign trained physicians under two different pathways. One, which is the eminence pathway, right? So kind of distinguished or renowned, faculty from other foreign-based institutions coming here, they can be granted, a license. There is another pathway for the Board of Physicians, I guess, recognizing any successful completion of 1 year of training in another foreign-based medical training program, residency program that's overseas, that's accredited by a board-recognized organization, right? So there's that second pathway. Has the board ever identified another accredited Board of Physicians recognized accrediting body?
So I don't know if that's a two-part question. The first part of that was the eminence. The intent there was not necessarily, I think, for the same population or
right. I didn't mean to ask about the eminence. I'm just pointing out that there are two pathways. Two pathways. It was more about the second pathway. There is a pathway that the board could recognize a accrediting body that they're comfortable with designating that anyone who has completed this accrediting body's residency training program overseas can get a license. Has the board ever done that?
The board has not. There is that pathway. I believe it's in Health Occupations 14308. That was intended for U.S. citizens or U.S. medical grads who then go to residency abroad and then come back to the U.S. I don't believe that the board has approved one of those programs, but similar to this legislation, there isn't really an entity yet that the board feels comfortable with to do that vetting. There's a couple, I think it's the ACGME-I, which we've talked about in some form or another, and then the WFME, which has began its process of kind of doing this, but they're not there yet. So there's a mix of situations here where it can come into play, right? So with the delayed implementation, we can kind of see those programs get up and running and kind of get more programs that they're vetting and making sure that they can get an answer to us. But as of right now, there's just not enough. And then the ones that are currently running, we don't believe that they are as viable as something that we would need this moment to kind of fix our workforce issue. Even though they exist, that doesn't necessarily address some concerns of substantially similar. We really just want to make sure that all physicians practicing in our state are educated and trained to the same standard, or in this language, substantially similar. And that's going to be our goal in however way we kind of go with moving forward with this.
Mm-hmm. And I know that at least my office has a meeting coming up with the U.S.-based accrediting body, which is ACGME. They also do some accrediting of foreign-based residency programs, and to use that perhaps as a benchmark standard for the Board of Physicians to accept ACGME-I-based training programs, which, from my perspective as a residency director, like, I do have some faith in the accrediting bodies, like accreditation of foreign-based programs. And I think that's why I bring up this distinction, that I think one of the distinctions here with the various bills that are considered before this committee is that the board has, under the current law, the ability to grant some flexibility to be able to grant these foreign trained physicians a license. They have not exercised that yet. They have kind of, you as the board have kind of deferred. This bill gives a little bit more prescriptive guidance, but still defers a lot to the board. When you look at the last page of this bill, it's really under conditions that are established, that are applicable to licenses by the Board of Physicians. The Board of Physicians must provide a pathway. The pathway is defined by the Board of Physicians, which, you have the authority currently to do that. The bill that's going to be coming up uses the ACGME-I, the accrediting body that currently exists in the U.S., and is starting to accredit foreign-trained residency programs as a standard that the board must use to be able to review these applicant licensees. And so, I guess, is that the main kind of distinction that I think we're trying to figure out here? That's probably a large part of what we're still trying to navigate.
Right. So with our amendments, we want to take in programs such as the ACGME-I, but we believe that isn't enough of a guardrail to say, okay, these folks can come in and start practicing and provide that quality of care that we want and that we regulate. So we've talked with our board, and we are comfortable with establishing ACGME-I into our regulations. I believe it's coming up next month to get that into our regulations. But with our amendments, what we're saying is we're okay with doing that and having that leg to stand on, but we need more, right? We need more when it comes to supervision, making sure that these folks are okay in their limited practice over the span of these 2 to 3 years of this license to kind of be supervised by their employer, by their supervising physician, getting the additional training, getting acclimated to the U.S. healthcare system. We want to see that and kind of those two with whatever accreditation program, ACGME, WFME, those all play a part into making sure that we are okay with giving them a full license to practice unrestricted. And we think that is going to be the best solution to kind of move forward with this. It also opens up this intended population by a lot. I think currently as written, this is going to be a very restrictive qualification list, and not a lot of people are going to actually qualify. So with the supervision aspect, we really want to open it up to a larger amount of folks and make sure that this is actually going to address the workforce solution while kind of maintaining a standard of care that we are charged with kind of overseeing as the board.
Well, happy to continue that conversation.
Absolutely.
Thank you, Mr. Tran. I know you've been very accessible to our office to kind of navigate this with us and, other bill sponsors as well. That's been incredibly helpful. I think we're obviously all trying to march in the same direction to try to get this, implemented as soon as possible in a way that, will open up to other licenses to help address our workforce shortage. We'll continue the conversation, but thank you.
Absolutely. Thank you for the question, Senator Lamb.
Thank you, Senator. And that will end the hearing on Senate Bill 380. Thank you both very much. Next, we're going to have Senator Augustine, Senate Bill 370. He's got 3 panel members in person and 2 virtually. So Tiffany Smith-Williams, Amanda Rodriguez, Dr. Sharon Jennings-Roja, and then virtually we're adding Brandy Gary from the Maryland Board of Acupuncture Chair, and Amy Magger, American Society of Acupuncturists.
Okay, great.
So that's our panel.
All right.
Thank you, Senator.
Thank you, Chair Bidel, Vice Chair Hayes, members of the committee. Senator Malcolm Augustine here on behalf of Senate Bill 370, which is a state acupuncture board revisions. Colleagues, in East Asian medicine, manual therapy, body work is an umbrella term for the mind-body therapy that practitioners use to promote and optimize whole person healing and functioning. It includes forms of East Asian massage as well as cupping, scraping, and applying the non-needle therapeutic touch and pressure synonymous with acupuncture, acupressure. It's also important to highlight that acupressure is often used in the practice of East Asian medicine when providing care for pediatric and geriatric populations and or with any condition or in any situation in which the use of needles are not advisable. Acupressure is identical to acupuncture in that it relies on the system of East Asian medical principles and theories, indicating the application of pressure to mapped areas on meridians and acupoints. Applying pressure to mapped areas positively impacts energy flow and remedies health conditions. It's one of the cornerstones taught and reinforced in acupuncture school across the country. It's integral to the graduate level curricula and standard to the tenets that are included on the national board exams for acupuncturists. As such, it is imperative that acupressure be included solely under the scope of practice the system of East Asian medicine. The Board of Acupuncture is aware of the perception that licensed acupuncturists only perform acupuncture. And that's not entirely correct. Licensed acupuncturists are skilled in the full practice of East Asian medicine, including manual therapy, bodywork. Board of Acupuncture has further learned that this perception has contributed to the unlicensed practice of acupuncture in East Asian medicine via manual therapy, bodywork, which there's an inaccurate perception additionally being used to evade licensure requirements for massage therapy through the Board of Massage Therapy Examiners. The Board of Acupuncture is aware that taking action around manual therapy may raise some concerns for other practitioners that too employ manual therapy in their practice and cause a bit of a reaction to and concerns about scope of practice. The Board of Acupuncture's ability to protect what is inherent to its scope of practice is very important. Such responses, we understand those responses, but the board is addressing an existing and founding element of the law since its inception as a board in 1994 and possibly dating back to its time under the Physicians Board before that. And so, colleagues, in consideration of the Board of Acupuncture's mission to protect the public, through the regulation of acupuncture and East Asian medicine, the board seeks approval of this bill, Senate Bill 370, to accomplish the following. Update the practice law to make clear that manual therapy is bodywork and that acupressure is just one form of East Asian bodywork and therefore requires license to advertise and practice legally. 2, to prevent bad actors from using acupressure as a business model that does not require state licensure via the boards of acupuncture and massage therapy examiners. 3, to prevent bad actors from using acupressure as a business model that can exploit both employees and customers. Employees who are often misled to believe that they have paid for training and are now licensed healthcare practitioners, and employees that may additionally be victims of sex trafficking and slave labor. And customers that pay for services believing that they are being treated by a qualified practitioner. And 4, this will further the Board of Acupuncture's ability to enforce practice law by adding sanctions for those that aid and abet the unlicensed practice of acupuncture in East Asian medicine. Now, these sanctions go further, following the example of fellow health occupation boards, by providing criminal penalties that afford law enforcement the ability to charge these bad actors with a misdemeanor on the first offense and a felony on subsequent offenses. Colleagues, this piece of legislation was brought together by working with different groups of people to include the Board of Massage Therapy Examiners. We've also worked with local officials, elected officials at the county level, and also sex trafficking task force who have seen this be problematic, and law enforcement as well. There's been quite a bit of discussion around the language and making sure we get the language right, and particularly in working with the the massage board, and there's an amendment that's been put forward and hopefully put forward to the committee that really makes it very clear about this distinction between the massage board and this board of acupuncture, because we do want to be clear, there is a space for a massage board, and we've been working with them, and we will continue to do that. And those amendments should be we should be able to make those available to council. And with that, I'm happy to answer any questions after hearing from the panel. Thank you, and I ask for a favorable report on Senate Bill 370.
Mayor Augustine, just want to remind the panel that the sponsor has an unlimited amount of time, but each panelist have 2 minutes. Who's going to go first? Thank you.
Good afternoon, Chair Bidle, Vice Chair Hayes, and committee members. I am Tiffany Smith-Williams, the Executive Director for the Board of Acupuncture. My testimony is in favor of Senate Bill 370 to address a public safety issue that the board, based on its mission to protect the public, is mandated to address. Without repeating too much of what the senator shared, because it was pretty thorough, I'll just go on to share some things that are in the statute currently. Acupuncture is the form of healthcare based on East Asian medical theories of energetic physiology that describe the interrelationship of body organs and functions. Currently in statute, the practice of acupuncture is defined as the stimulation of the insertion of needles, which is the most well-known treatment, the application of moxibustion, manual, mechanical, thermal, electrical, and other East Asian medical therapies only when performed in accordance with such principles and practices. Like Western medicine, it is a whole person approach to health restoration. It includes herbal medicine, dietary therapy, mindful movement, aka therapeutic exercise, and manual therapy, aka body work. None of these things infringe upon the scope of our fellow Western medicine practitioners. The board learned that acupressure is being used to circumvent state laws that require manual therapy, body work, and massage therapy be performed by licensed professionals. It is being used as a cover for sex trafficking and slave labor activities and some body work businesses in our communities. This is in part fueled by both licensed practitioners and unlicensed persons attending a weekend, often virtual CEU course to obtain an acupressure certificate. The belief is that acupressure is a form of unregulated holistic massage. The board's law currently includes manual therapy, and it has since its inception. This is East Asian bodywork that includes treatments such as acupressure, all performed according to mapped meridians and acupoints. After several investigations in collaboration with the Board of Massage Therapy Examiners, a Montgomery County Coalition, including Councilwoman Lutke, who will be testifying in person for the House tomorrow, the Police Department Vice Unit, the Commission for Women, a member of the local Human Trafficking Prevention Committee, the Baltimore Reflexology School,
Thank
the
you
American...
so very much for your testimony. Who's next?
They've had a long day. Gotta stay within the time.
Go next. Good afternoon, Honorable Chair, Vice Chair, and members of the Finance Committee. I'm Dr. Sharon Jennings Rojas. I've been in the healthcare and education arena for almost 4 decades. I'm here on behalf of the Maryland Acupuncture Board, where I serve as a professional member with almost 4 decades of public health experience. I also serve as a vice chair of the executive board. Acupuncture and herbal medicine physician as well, serving nationally and internationally in a variety of healthcare venues and initiatives, including 30 years dedicated to military installations like Fort Belvoir and carceral settings like the Baltimore City Prison and the Howard County Detention Center. As it impacts public health, the art of learning and healing are healthcare practices in their own right and are paramount. Many of us have witnessed the bridges that are formed when all healthcare modalities work in concert, integratively, collaboratively, and in community. Whether providing care at someone's bedside, within community health centers, hospitals, health departments, military installations, and/or carceral institutions, ensuring that any scope of practice is adhered to is essential. Acupressure, by its definition, follows the same system of medicine that is the foundation of acupuncture in East Asian medicine. It is a large but clearly defined umbrella that consists of many different tools utilized to bring relief, healing, and to restore health. Acupressure utilizes specific pressure and hand movements used to manipulate tissue, where there is discomfort or dis-ease. The use of acupressure encourages flow and revitalization of blood and energy to encourage health and healing. This practice, taught and steeped in the system of medicine that is acupuncture and East Asian medicine, is a cornerstone and is within the standard national curriculum utilized in acupuncture and East Asian medicine schools. Sadly, there has been an uptick in inappropriate usage and not only negatively impacts the public, but also diminishes the power of the medicine that many Marylanders rely on for their health and healing journeys. Essentially, these persons are practicing
Dr.
and trying
Rojas.
to get around licensure.
Wrapping up. Thank you.
A dangerous circumstances for Marylanders who are simply looking for relief and recovery. Thank you for listening to our testimony.
Thank you so much for your testimony.
Madam Chair, Mr. Vice Chair, members of the committee, my name is Amanda Rodriguez. I am the co-chair of the Legislative Committee of the Maryland Human Trafficking Task Force. The task force was formed in 2008. It is made up of law enforcement, victim service organizations, survivor leaders, government agencies, and local task forces. The task force has facilitated the recovery of thousands of survivors and prosecution of hundreds of human traffickers statewide. On the face of this bill, the bill may not appear to be a human trafficking bill, but it is supported by the anti-human trafficking community here in Maryland. I'm a former prosecutor with Baltimore County, where I handled all of the human trafficking cases for almost a decade in the county. Task force partners have found numerous labor and sex traffickers utilizing illicit massage businesses, utilizing this loophole for acupressure and bodyworks as fronts for criminal enterprises. However, when regulating these businesses, they deny utilizing traditional massage therapy techniques, which allows them to exist on the fringes without regulation. Survivors in these cases often have threats against their immigration statuses and families, making it nearly impossible to engage in victim services and the criminal justice system. As a result, these criminal enterprises see little to any repercussions for their criminal activity. I want to quickly paint a picture of what survivors in these cases often go through. They're required to sleep on the same table, where they are forced to perform sex acts multiple times a day, completely isolated from the outside world. They have strict quotas that coerce them, including performing more than 10 sex acts per day. In one case that I prosecuted, the trafficker opened an illicit massage business in the same street time after time after time as they were being hit by police in an attempt to crack down on the illicit activity. Ultimately, they reopened a facility in Montgomery County in an attempt to evade police. However, we were unable to fully prosecute her because the victims were unable to seek services and to get the support that they needed, mainly because she threatens them. It's quite, to be very frank, she had a sign in Mandarin and Korean that said that any disobedience would lead to beheading. For these reasons, we do ask for a favorable report for Senate Bill 370. Thank you so much.
Next, we'll hear from the two virtual witnesses that. No, this is all part of the panel. Okay. Yeah, thank you. So we have Brandy Gary. Brandy, will you unmute and testify for us?
Okay. Excuse me. Good afternoon, Madam Chair and Vice Chair and members of the Finance Committee. My name is Dr. Brandy Gary, DACM. I am the Chair and professional member of the Maryland Board of Acupuncture. I'm a licensed acupuncturist and East Asian medicine practitioner in multiple states, nationally certified. I'm a disabled Army veteran. I hold compact nursing licenses. I am educated, trained, and practiced in Asia and in America. I was the first clinical acupuncturist that Kaiser Permanente hired in the Mid-Atlantic region, and I helped to expand the department to 12 locations in the DMV. I was the first non-medical doctor to lead the department. I educated our physicians in the benefits of East Asian medicine and was the only practitioner that was able to provide treatment to children under the age of 12 for anxiety, GI problems, side effects of medications, using manual therapies, Tui Na and acupressure specifically, in addition to acupuncture when possible. I obtained approval for to conduct research studies under the oncology department, as well as in conjunction in our department in acupuncture and East Asian medicine. My testimony is in support of Senate Bill 370. The bill manual therapies are among the oldest forms of medical treatment in history, with roots reaching back to the Stone Age between 2000 and 8000 BCE. Some studies of the architectural findings place that the origins of Tui Na, other form of East Asian manual therapy or bodywork, is about 2,600 years old.
Thank you for your testimony.
Thank you.
And we have Amy Major from American Society.
Major. Thank you so much. Hi. Thank you, Chairwoman and members of the Finance Committee, for hearing my testimony. My name is Dr. Amy Major. I am the Federal Advocacy Chair of the American Society of Acupuncturists, and I also serve on the board of Safe Passage, which is an organization that supports survivors of domestic violence. I echo the comments of my colleagues, and I have submitted written testimony in detail with citations. Thank you, Senator, and my colleagues for expressing so much of what we need to express to move this bill forward, to have it reported out of committee favorably, which is the goal, because we need specificity, demonstrated competency, and the ability not to harm. And we do this by having specific structures in our legislation to support consumers to know that their providers have been verified, trained appropriately, examined appropriately. So I do want to ask for specificity in the examination, that it be the NCB-AHM examinations, because all of these components are tested within that examination. As I have submitted written testimony, and you have heard many people speak through this hearing, I want to thank you for your help, time, and skill, and encourage you to report HB 370 out of committee favorably. And I thank you again for taking the time to listen. If you have any questions, I'm available to answer any.
Thank you very much for your testimony. Do I have questions? I do have one question, Senator Kramer.
Thank you, Madam Chair. So I'm trying to make sure I understand the bill, and maybe Senator as the sponsor. Am I correct that this is pulling folks who are doing acupressure into the definition of somebody who does acupuncture? What is because we've now created definitions for manual therapies, and then I have the impression that manual therapies now means it's part of acupuncture.
Yeah.
Explain to me what I'm missing, because
Sure.
I'm reading, and I just want to make sure I understand correctly, some opposition testimony from someone, and I believe she's going to be coming up, who does do acupressure. Will she now have to learn to use needles?
No.
And do acupuncture to continue practicing acupressure, or will she be able to do what she has always done, but maybe it just now there's a licensing regime for it? Can you? That's what I'm trying to grasp.
Yes, thank you for the question, Senator. It is that while we call, just broadly speaking, while we call it acupuncture, within that, and what we're saying is a part of that practice is the acupressure portion today. That's just from the art of it itself. But right now, the acupressure, the parts that you were just talking about, which someone might be doing out there, there's no licensure scheme for that. So it's bringing that into a licensure scheme underneath the acupuncture board, with guardrails that were brought on in discussions with the Board of Massage to ensure that those who are in the Board of Massage, it's very clear, even though we're doing this, that it does not negatively impact the Board of Massage. And we're also there's also clarifying information about those who are in the Board of Massage that may have had previous they may have had previous licensure underneath that and training, that it does not include them, but that we're trying to bring in this practice that people are using out there, where there is no licensure, where there is no way for there to be for people to know that these folks are trained in this practice
of acupressure.
Correct.
Not acupuncture.
Correct, because the acupuncture.
If I may. The acupressure already exists in our law under manual therapy, which I think is what the senator is trying to get to. We're not bringing it in. It's been there from the beginning.
Okay.
There are people who feel like it's not regulated already, and they can teach it in a weekend course as opposed to the licensing person who already has a master's or a doctorate to perform it.
So does somebody who does acupressure and it is therefore considered a manual therapy, are they licensed now in any way?
The people who are not licensed by the board may not be licensed to do it. That's why we're saying they're misleading the public, saying they're performing something they're not licensed to perform.
All right, how will this person get their license to do acupressure?
It's going to fall under the board. It will fall under the board of acupuncture now, Senator.
Okay.
So now, in order for them to be able to perform these things, we're putting into statute.
To perform acupressure.
Correct. This manual, which we're calling it
Right,
acupuncture
manual
here, but
therapy.
exactly. That this specific, that is associated with this East Asian, right, that within that space, just like really within that space, if you're doing that, you have to have a license, and that license that will fall under the board of acupuncture.
And what will they have to do? In other words, what is the standard for them to get that license? So that I understand, what will this woman do differently or have to, because I'm reading her testimony and it says, she graduated from a 620-hour program, doing Asian bodywork therapies. She has continuing education, et cetera. Just so I understand, will this woman be able to continue doing what she does? Will she have to go back for different training? Or what will she have to do in order to now be licensed under the Board of Acupuncture?
So in that situation, that is a historical conversation between massage and acupuncture in the past. She graduated from a shiatsu school of body work. They no longer exist. She also went to our professional organization years past to get an Asian bodywork certificate, which is extremely valid. There are 11 people in Maryland between acupuncturists and massage therapists who have that certification. We have submitted an amendment that would give them the path to continue to practice because they are credentialed by our certification body.
So she will be able to continue doing what she is doing.
Yes.
That's the amendment that I was
Yes,
talking about.
that is the amendment.
And
The
get
peop-
her license, but she will not have to be trained in anything related to the use of needles.
No.
Okay.
No, that's a historical thing that we are making room for based on that amendment. The people who are not going to be able to continue to practice acupressure are the people who receive their weekend certificates from non-credentialed universities or colleges.
Gotcha.
And they unfortunately have been misled to say they're performing acupressure. In our investigations, we're finding it's being labeled acupressure, but it's really massage. And they don't have massage licenses.
Okay, thank you. No, I appreciate the clarification. I was trying to get a handle on that. Thank you. Thank you, Mr. Chair.
And so, am I, Ms. Smith-Williams, am I to understand, so I understand that the person that Senator Kramer talked about,
Yes.
they will go about and they will get their license.
Yes.
But individuals outside of that smaller group, they will be able to get a license to apply acupressure, but not necessarily be an acupuncturist?
Acupressure is the twin of acupuncture without needles. Therefore, in order to perform it, you have to go to school and get a degree.
Right, and so there
Yes.
will be a pathway for them.
They can apply to a university. Virginia is the closest right now since the Maryland school closed recently, to become an acupuncturist. They would have to be an acupuncturist to perform acupressure.
Oh, they will.
Yes.
So no one, other than that select group of historic individuals that have been through the proper training and
Correct.
credentialing, anyone else will actually have to go through the proper process to become an acupuncturist
Yes.
to apply acupressure.
And this has been the case since the inception of the board. It has not changed. We're not making any new rules, and neither is this infringing upon the manual therapy scope of, say, physical therapists or chiropractors. We're simply addressing East Asian medicine, and we're making clear to the public that manual therapy is body work before we have to discipline people.
Gotcha.
Right.
Thank you so very much. Senator Lamb, be bold, be brief, be brilliant.
Yes, thank you, Vice Chair. Just have a quick clarifying question here, and certainly, appreciate the intent of this legislation, but had a question on why, when it comes to East Asian body works and those practices, it seems to be carved out differently for regulation and regulatory requirements here when practices from other cultures are not similarly kind of regulated.
I'm trying to understand the nature of your question. So the board only regulates, as you know, East Asian body work. So this is the only thing that we're trying to address are the manual therapies that come under East Asian body work, and acupressure is, of course, one of those.
I mean, I guess it's more of a baseline question of
Yes.
why was or why is East Asian body works carved out differently than, say, practices from other cultures?
It's the whole reason the board was formed, I guess, just to license and regulate East Asian medicine. That is the only purpose of the board in general. We don't.
But other practices by other cultures aren't regulated in this way?
What do you mean by other cultures? So are you talking
Other, cultural medicinal practices,
well,
that are
everything-
not East Asian, I guess, or not.
Yeah, no. There is, like, we don't have a African medical practice board, to say, no, we don't have that. We just have the East Asian medicine board. Well, chiropractic, yes.
I'm just
But
saying,
that's,
there's
yes.
different ones.
You have chiropractor, you have the physical therapist, but.
Yeah, that I get.
Right,
It just
yes.
seems curious to me that, this is singling out just one culturally based medicinal kind of practice.
Well, that has to do with really the history of medicine in Maryland. I don't know if I have that bigger answer. I
Mhm.
just know that the focus of the board is to regulate East Asian medicine, which includes acupuncture, acupressure, the herbal medicine, those types of things.
Okay. All right, thank you.
You're welcome.
Senator Kramer.
All right, thank you, Mr. Chair. Okay, now his line of questioning I wanted to come back just again to make sure I understand. So the amendment would afford a certain small group
Yes.
to continue to do what they do, but anybody else,
Yes.
if they want to provide acupressure,
Yes.
they will have to learn acupuncture as well.
They will have to go to school to become an East Asian medicine specialist, which includes both.
All right, let me
Yes.
ask you this. I get the idea of somebody puncturing my body with a needle as, yeah, I really want you to know what you're doing and to be exceedingly well-trained. Is the public at that same risk for somebody using acupressure as they would be with somebody taking a very sharp object, puncturing their, skin, sticking it down into nerves, that we are equating them so that rather than just having perhaps a different licensing regime for acupressure that may still fall under the auspices of the board, the acupuncture board, but maybe that's a different standard than having somebody need to learn how to actually use needles as opposed to applying pressure. Do you follow what I'm saying? Is the public at the same kind, because all of this is about public health risk.
Correct.
And we don't want somebody sticking needles in another human being without being properly trained, as opposed to maybe a different level of training for someone who's applying pressure, but not sticking metal objects through people's flesh. Is there a reason we're not looking at maybe, hey, we want to ensure the people who are doing acupressure are licensed, know what they're doing, we'll set a standard for that, but it doesn't necessarily have to be this standard. Do you follow what I'm saying?
Mm-hmm. I think
Okay.
that East Asian medicine it's a holistic approach and it encompasses many things. And I think picking it apart and letting people have pieces of it probably would not be advisable. So the acupressure uses the same acupoints and meridians that acupuncture uses, which means that even though we're not using needles, you're looking to have the same medicinal effect in using that point, and you want skilled practitioners who are educated in the points, in the meridians, and the impact on the entire body and mind
And you
to
could
be
have
skilled.
training for that. But is there a distinction between, in other words?
Nationally, right now, you do not. You go to the school, the university to get
Right.
that degree, or that's it,
Or that's
nationally.
it.
Yes.
Okay.
So can I, yeah, I'm following your line of questioning, Senator, but what I would say is that you could apply that same thing to physical therapy, chiropractor, where people are using hands and manipulation. We have licensure for those things. So I do agree with you that the board would it makes sense for the board to look within itself at the different areas that are there, but it needs to be put inside the board, which is really what this is doing. This is putting it inside the board. It's not as prescriptive as the conversation that we're having right now. What it's saying is that inside the board, you're doing these types of functions, you need to be licensed in the state of Maryland. That's what this is really trying to say and trying to do. I'm with you on what you're saying as far as like, okay, maybe the board,
the skill set,
they might,
level
the
of
board
skill
may
set.
need to do that, but that's the duty of the board once it gets in the board. The point of this is right now, it's outside there. There's no sort of controls at all that are happening. This is the function of our boards of licensure, is to do the kinds of things that we're talking about, but we can't work it out here. It really is their job to work it out within the board and the framework of that. That's what I would suggest.
No, and I appreciate it, and that's where I was trying to, grasp, hey, put it all under the board, but perhaps shouldn't there be consideration that, up to a point, this is what you do, and you don't have to have a physician's license to be doing this, but you want to be a chiropractor, you can do that, but the standards are different.
Yeah.
Because you're not, like I said, in one you're manipulating, the other you're puncturing. That's all. So I was trying to
I
grasp
find this to
why
be
we would-
clarifying about what those therapies are that
Right.
fall within the board itself, not so prescriptive on that, but just that it needs to be licensed.
Okay. Thank you, Mr. Chair.
Thank you, Senator Kramer. Dr. Gary, I apologize. You're not in the room, so it's hard. I know you had your hand up, but it looked like you put your hand
put it
down
back
because the panel appropriately answered it.
Thank you.
Okay. So, sorry to overlook you, though. My apologies. I saw it.
May I
after-
make a comment, though?
Yeah,
Just-
go right ahead. I'm sorry.
That's fine. So just since none of us were able to clarify this, with East Asian medicine, we have rivers that flow through our body, and when we have problems, there's blockages in the problem, creating those pains, blockages. I'll use pain as the example. We have rivers that flow through the body. When we have pain or problems, there's a blockage. The acupuncture, acupressure opens those dams, gets things moving, and makes those problems fixed. The history that of the other practitioners in their medical field not understanding how we do what we do is part of the challenge. And that is with the acupressure. If I press on your shoulder, you may have results somewhere else in the body because that is the connecting river that we have flowing through the body. So if you put a needle there, or if you put my thumbprint there, or massaging with my thumb, I'm benefiting somewhere else on the body where a massage can do something similar, but the East Asian practitioner is specially trained in the reaction that will happen because of that point. And
Thank you,
that's
Dr.
why
Gary.
it's so
I'm
much.
going to end the testimony here unless there's any additional questions from the senators. Are there? Seeing none, thank you all so very much. I appreciate your time.
Senator, may I just add one quick thing? And that is only that.
Maybe next time, shoot, if you could send us an email.
I'll send you
but
an email. I apologize. Thank you, sir.
Thank you so very much. I appreciate it. Thank you. Next, we have Louis Crivelli. I hope I didn't butcher your name. If I did, I apologize. Favorable with amendments. Maryland Chiropractor Association.
Good afternoon. Thank you, Vice Chair Hayes. My name is Dr. Louis Crivelli. I'm the president of the Maryland Chiropractic Association, and we are here to support Senate Bill 370 with an amendment. We've provided written testimony already, and we've suggested some language for the amendment. We want to be really clear at the outset of this. We respect acupuncturists and massage therapists. We are collaborative and we work with everybody in the state. And it is always in the best interest of our patients to have a holistic approach to health and wellness that encompasses everything. That being said, this bill, the way it's written, uses the terms manual therapy and manipulation without really defining what they mean in a clinical context. In healthcare, manual therapies and manipulation can run the gamut of gentle pressure on soft tissues all the way up to high velocity thrust maneuvers that are designed to, move articulations and joints, something that us chiropractors are experts at. These are fundamentally different interventions that have their own indications, contraindications, and risk profiles. We are just, we've suggested some language, and our amendment, doesn't do anything to restrict acupuncture or massage therapy. It just clarifies that high velocity spinal or extremity manipulation, which is also classified as a grade 5 mobilization, is excluded from the definitions of manual therapy or manipulation. And just in the testimony before, I overheard some interchanging of the words manipulation and manual therapy, and our amendment hopefully introduces just some clarity into those language. Mobilization, manipulation are two different things in a clinical setting. And so we just wanted to get that on the record. Thank you. I'm open for any questions if you have them.
Thank you so very much. Is there any questions from this panelist? Thank you so very much, Doctor.
Thank you.
All right, next we have some unfavorable testimony from Tom Swiss as well as Lucille Vigna. Lucille Vigna and Tom Swiss.
Good morning. This is, good afternoon. We are two of the unicorns, apparently. So this was before we heard about the amendments, and they might be on the right direction, but they might not be. So I'm reading what I have written prior to knowing about the amendments. So good afternoon, Vice Chair and members of the committee. Since 2001, I have been an active diplomat in Asian bodywork therapies under the National Certification Board for Acupuncture and Herbal Medicine. This is the same certification board that acupuncturists use. I am a certified practitioner of both the American Organization for Bodywork Therapies of Asia, as well as the Associated Bodywork and Massage Professionals. I graduated from a 620-hour Shiatsu and Asian Bodywork program in 2001 and became a teacher for the school for several years. To keep my diplomat status, every 4 years, I'm required to complete 60 credit hours of training. Much of this training is done by taking the same classes as acupuncturists. I've been helping people for over 24 years as a Shiatsu therapist and Reiki master. I recently asked my clients how my work helps them. Their replies included one client replying that she depended on Shiatsu for relief from severe pain that once made a basic movement extremely difficult. She sought help from many doctors, underwent many scans and imaging, and tried many treatments, including acupuncture. Her acupuncturist referred her to me. Asian Bodywork reduced her pain, restored her mobility, improved her digestion, and eliminated severe pain in her abdomen. She stated, quote, "The gradual non-invasive nature of shiatsu made more invasive treatments unnecessary. Losing access to this care would remove an essential effective option that is not interchangeable with acupuncture or medical treatment." End quote. This bill is written, it would keep someone like me from practicing any form of Asian bodywork unless I become a licensed acupuncturist. To comply, it would require a completion of a master's program during a time when many acupuncture schools have closed or are closing in Maryland. This bill will put me and many others out of business. I want to continue my business of helping clients through shiatsu and Reiki. Please consider how this bill will affect the Asian bodywork and massage industry in Maryland. I respectfully ask you to oppose this bill. Thank you for your kind attention.
Senators, my name is Tom Swiss, and I'm one of the 11 people just mentioned. I'm a graduate of the Shiatsu and Asian Bodywork program at the Baltimore School of Massage. I am certified as diplomate in Asian Bodywork Therapy by the NCBAHM. I'm a certified practitioner of the American Organization for Bodywork Therapies of Asia and a licensed massage therapist. I have practiced massage and Asian bodywork therapy, or ABT, for 2 decades. I'm on the faculty of the Potomac Massage Training Institute. I'll be teaching there in 2 weeks, but I'll have to warn students that acupressure may become forbidden knowledge to them. Because under this bill, if a massage therapist rubs a point and calls it an acupressure point, that's acupuncture. But if they call it a trigger point, they're fine. Will it be criminal to even know that the point is gallbladder 21, shoulder well? Acupressure is not acupuncture. It is a simple and safe practice that is a minute to learn. I could teach you very useful acupressure points, but it is a lifetime to master. I'm a member of the medical staff of Mercy Hospital. I work with cancer patients there. That's an example of how this work is valuable to the people of Maryland. By imperiling it, this bill reduces healthcare access and choice and does real harm. I want to tell you a human story about this work. Just hours before I learned about this bill, I learned of the death of a patient I've been working with for years. I was there when she got the bad news about cancer infiltrating her brain. I tried to use Asian bodywork to take away some small part of the grief and pain with my hands. She was a strong advocate for the work I do. At one point, she went to the head of the oncology department to make sure I could keep working with her. I was processing grief and appreciation for the opportunity to know her, and then I learned about a bill that proposes to incarcerate people who do such work. So if I sound angry, I think you understand why. Please oppose this power grab by the Acupuncture Board. I will be happy to take any questions.
Thank you so much for your testimony, and sorry to hear about your loss. Are there any questions, colleagues? Senator Kramer.
Thank you, Mr. Chair. So just real fast, from what I think I heard, you all would be, I don't know whether I should use the term grandfathered in, pardon me, or licensed under this new, bring it under the Acupuncture Board.
They mentioned that there would be an amendment to do that. I did not believe the current language.
No, and I trust the bill sponsor that, you know, if he stated there's an amendment to do that, it will be there.
Certainly, sir. I just want to make sure that we haven't been able to see that amendment.
Sure. Does that address, though, it does not?
No.
Okay.
We Asian bodywork therapists do exist in sort of an intersection, or in my written testimony, I included a Venn diagram of Asian bodywork therapy, massage therapy, and acupuncture. Like acupuncturists, we work with the point and meridian system, the theory of East Asian traditional medicine. Like massage therapists, we use our hands, but some of our Asian bodywork colleagues do not do techniques that constitute massage under the law. There are historical reasons why they were specifically exempted from massage therapy regulations. Basically, it's because the treatment is so safe. If I may borrow the cell shoulder here again, as I've done several times today talking to people, this is simply a therapy that if I get wrong will not harm her. If I get wrong and I move here, well, she doesn't benefit.
All right, so real fast, because we need to stay tight. Are you creating what I was trying to understand, a distinction between doing some kind of manipulation with the hands as being distinct from putting needles into a
absolutely.
human? That's
Absolutely.
what I'm trying to
Yes,
grasp.
absolutely.
Okay.
Our main teacher was both an acupuncturist and an Asian bodywork therapist. And there are some people who have done that, but just because someone does acupuncture does not mean they are competent in the manual therapies of East Asian medical technology.
But you're also, in your mind, there's a distinction between the risk to the public of having someone use manipulation, acupressure, as opposed to sticking needles in them.
If I can make a 3-level distinction here.
Can it be a quick 3 levels?
Acupressure, nothing is being manipulated.
Okay.
Body work, some soft tissue is being manipulated. Acupuncture, there's a needle.
Okay.
I do think they will need to consider CEUs for, if they're going to let massage therapists continue to use any of it, there needs to be CEUs that are available. Yeah, I think they just need to work on an easier way to get accreditation for what they want to accomplish. Just
it.
putting it under the acupuncture board and saying you need an acupuncture license is a little extreme.
Okay. All right. Thank you, Mr. Chair.
No problem. Thank you. All right. Are there any additional questions? Seeing none, we have 2 virtual testimonies. One, Tuesday Wasserman, who's favorable with amendments, and Jessica Espinoza, unfavorable. Tuesday, you want to go ahead and get us started?
Thank you very much. I really appreciate the opportunity. Can you hear me?
Yes, we can hear you.
Okay, great. Thank you. My name is Tuesday Wasserman. I am a licensed acupuncturist, a doctor of acupuncture and Chinese medicine, and a teacher. And I've taught massage in all the programs, but I'm here representing the NCBAHM, formerly the NCCAOM. And the NCCAOM is the certifying organization for licensed acupuncturists nationally. We are very much in support and in favor of this bill. It aligns with national standards and what we see moving across the states. The favorable with amendments is to clarify that the NCCAOM certification has been around for more than 40 years. And when it first came out, it was a test to demonstrate competency, safety, and those ethical components for graduates entering this profession. And so it's a third-party psychometrically verified accredited examination. At the time when the NCCAOM started administering exams, there was one exam that included everything. But for more than 20 years now, based on feedback from all of the practitioners, NCCAOM acupuncture certification is it's earned through 3 modules. And so to get certification and demonstrate safety and competency, there's the acupuncture exam with point location, the foundations of Oriental medicine, and the biomedicine exam. As this bill is currently written, it says the NCCAOM exam, which I believe might be old language taken from surrounding states back when there was one exam. But I really wanted to clarify that in order to demonstrate safety and competency, it's really important for practitioners to achieve that certification by passing all 3 exams. And it's not only acupuncture and how to utilize and prescribe and treat safely. But when we look at biomedicine, it's really about making appropriate referrals, understanding red flags, and that is where practitioners demonstrate that they can safely engage as first point of contact. So I just wanted to clarify that there are those 3 exams. And because I heard the tail end of that conversation, I will say that NCCAOM also has a certification in Asian bodywork therapy. And it's that same thing where it's about safety and competency. When it comes to massage, one person, one room, there are large safety risks when it comes to appropriate behavior, understanding ethical treatment, proper draping, misconduct. And then there are, of course, risks with certain populations, such as acupressure, massage, shiatsu has increased risk when it comes to treating pregnant women and inducing miscarriage. And
Thank you so much for your testimony today. Are there any questions from the senators? Seeing none, thank you so very much. This ends the testimony for Senate Bill 370. And next, we're going to hear from Senator Jackson in Senate Bill 348. Turning back over to the chair.
A panel: Natasha Mayhew, Kimberly Rouston, Quinn Collins, and Dr. Ann Banfield.
Thank you. Good afternoon, Chair Bidle, Vice Chair Hayes, fellow members of the Senate Finance Committee. For the record, I am Senator Carl Jackson here to present Senate Bill 348, Hospitals and Freestanding Birthing Centers, High-Risk Pregnancies, Communication After Discharge. SB 348 seeks to extend the time frame under current law by which hospitals and freestanding birthing centers must call a high-risk birthing parent after being discharged from a window of 24 to 48 hours to a window of 24 to 72 hours. This patient contact is performed to evaluate the parent's status and, as necessary, provide information about any postpartum complications that might have arisen. Allowing an additional 24 hours for these calls to be made gives healthcare professionals more time to comply with current law and hopefully reach more patients, while still keeping the need of the patient at the forefront. Under the current window of 24 to 48 hours, hospitals are finding that success rates and patient responses are low. For example, MedStar has reported only a 34% response rate to these calls during this time frame. Patients who have just returned home from the hospital, who have next day pediatric appointments, who are discharged near weekends or holidays, and who are generally acclimating to life as a new parent seem unable or unwilling to answer a phone call so soon after discharge. Following up with high-risk patients is important, but it is only beneficial if contact is successfully made. The strict limitations of the 24 to 48-hour time frame and the low success rate means that these patients are simply not receiving the follow-up that they need and that the law intends. Expanding this time frame gives hospitals and freestanding birthing centers additional time to comply with the law and to better serve their patients. In addition to extending this time frame, I have also offered an amendment that changes the modality of contact from call to any form of contact that a hospital might believe is best for their patient, whether it be a phone call, text, chat box, etc. Ideally, this will allow patients more flexibility in responding to the attempted contact and give additional avenues to reach them. MedStar has reported a 76% engagement rate with texting in the District of Columbia through their Safe Babies, Safe Moms program, versus the 34% engagement rate previously mentioned with only phone calls here in Maryland. As we all know, with the large amount of spam calls occurring, people are simply less likely to answer the phone call from a number that they are not familiar with. So this will give hospitals and freestanding birthing centers additional tools when trying to follow up with patients. I believe that by extending the contact window from 24 to 72 hours and expanding the modality of contact, we can take lessons learned, incorporate them into current law, and continue the goal of furthering maternal health, while also offering hospitals flexibility and additional opportunities to successfully make contact with high-risk patients. For these reasons, I respectfully request a favorable report with amendments on SB 348. Thank you.
Thank you, Senator. So we're going to start with the panel. Natasha, would you start?
Yes, good afternoon, Madam Chair, Vice Chair, members of the committee. Natasha Mayhew here on behalf of the Maryland Hospital Association in support with amendments to Senate Bill 348. So hospitals strongly support the goal behind the Maryland's Maternal Health Act, early meaningful postpartum engagement for birthing parents at highest risk. SB 348 does not weaken that goal. It strengthens it by aligning one small targeted part of the statute with clinical evidence, patient behavior, and how care actually works after discharge.
Our support comes from hearing directly from the frontline workers, the nurses and staff who have been making these phone calls since the bill went into effect in July of 2025. They care very deeply about making sure the goals are met and effectively achieve their outreach. We thank Senator Jackson for putting this forward. There's no national clinical guideline that requires outreach to occur strictly within the 24 to 48 hours. Leading authorities, including the American College of Obstetricians and Gynecologists, define postpartum care as a continuous process, not a single, rigidly timed phone call. For many high-risk conditions, especially postpartum hypertension, 48 to 72 hours is a clinically accepted and widely used standard. The reports cited in our written testimony support these findings. Hospitals are not seeking to delay care. We are asking for a modest 24-hour extension that preserves early contact while improving the chance that patients would actually engage. Under current law, as was mentioned, hospitals are not always able to make contact with the patients. Extending the window improves successful contact. And equally important, the amendment to change the modalities allows hospitals to contact patients using methods they actually respond to, such as texts or emails and portal messaging. Peer-reviewed research shows significantly higher engagement through these methods. Some opponents argue that moving to 72 hours creates a gap, but then again, evidence does not support that claim. So, in short, this bill reinforces the most important relationship in postpartum recovery, the ongoing connection between birthing parents and their OBGYN or midwife. And so for these reasons, we urge a favorable report on Senate Bill 348.
Thank you. Who's next?
Good afternoon, Chair Beidel and Vice Chair Hayes and members of the committee. I'm Kimmy Routson, Assistant Vice President of Government Affairs for MedStar Health, here to testify in support of SB 348 with an amendment. The Maternal Health Act of 2024 used a broad definition of high-risk pregnancies. Through the list of 36 infant and maternal health risks on the postpartum infant and maternal referral form, we have found that the high-risk definition encompasses most 85 to 90% of pregnancies. So our hospitals end up calling all birthing parents to ensure compliance with the law. Across all of MedStar's birthing hospitals, we're averaging about 16 calls per day, consistent across weekdays and weekends. We've learned some lessons over the past 6 months of the requirement, and our goal is to enhance engagement and reach more birthing parents. Senator Jackson mentioned Safe Babies, Safe Moms, and we've seen that when we engage our postpartum patients in DC, we see higher rates of engagement when we text versus call. And we see that same high level of engagement when texting other patient populations post-discharge. A multimodal approach would help us provide the patient with more resources and manage their issues more effectively. Then we can connect them with the right clinicians based on the specific needs of that specific patient. We have not seen research that supports or requires the 24 to 48-hour time frame, but do have research that supports prioritizing patient outreach by text. So thank you, Senator Jackson, for considering these points and proposing an amendment to strengthen the bill and to change call to contact. For these reasons, we urge a favorable report with amendments on SB 348.
Good afternoon, Chair Beidel, Vice Chair Hayes, and members of the committee. I'm Dr. Anna Banfield, the Chair of Obstetrics and Gynecology at MedStar St. Mary's Hospital. I'm also the co-chair of the System Subcommittee on Severe Maternal Morbidity Disparity Reduction and the Physician Perinatal Quality and Safety Lead for MedStar Health. I'm here today also in support of Senate Bill 348 with amendments on behalf of MedStar Health. The Maryland Maternal Health Act requires hospitals to call the birthing parent at least 24 hours and no later than 48 hours after discharge to evaluate their status and provide information about postpartum complications following a high-risk pregnancy. This bill would increase the contact window to allow an additional 24 hours to make contact. MedStar Health also supports the sponsor's amendment to change the word call to contact in the legislation to allow for additional outreach modalities, including text, to reach patients. Our practitioners have struggled to connect by phone in the 24 to 48-hour time frame required by law. Only 1/3 of birthing mothers, about 34%, are answering those calls. In Maryland's rural hospitals, it is even more critical that we contact this population postpartum in case there are emergent issues because care may not be as close to home. Expanding the timeline and modality will give our team the best chance to connect with patients, and MedStar has a multimodal model that is successful and sees twice as much engagement as the phone calls. Our Safe Babies, Safe Moms program in DC has the same goals of the Maternal Health Act to reduce disparities in birth outcomes using targeted, evidence-based strategies. The program uses texting to connect with postpartum mothers and has a close to 70% engagement rate, nearly double the contact rate we have seen with calls alone. This data and our operational experience convince us that to meet moms where they are, to honor patient choice, and to improve medical outcomes, we need to pass SB 348 with the amendment. Thank you.
Good afternoon. Good afternoon, and thank you, Chairwoman Bidle and members of the Senate Finance Committee for the opportunity to speak with you today. My name is Quinn Collins. I serve as the Executive Director for Nursing Strategy and Integration for the Johns Hopkins Health System. I appreciate the committee's focus on improving maternal health outcomes, an issue that remains a top priority for our teams and our patients. Johns Hopkins supports SB 348, postpartum communication requirements, clinical evidence, SUD intent, operational impact, and statutory authority. This bill updates the requirements for hospitals to contact discharged birthing parents with high-risk pregnancies from within 48 hours to within 72 hours. Providing evidence-based comprehensive care to birthing families is central to our mission. As we have implemented this legislation, one area of concern is the requirement of a post-discharge follow-up call within 48 hours. The bill offers no evidence or clinical rationale for selecting this timeframe. When we analyzed our own data from calendar year 2025, we found that most of our postpartum readmissions occur greater than 3 days after discharge. For that reason, we strongly support extending the required follow-up call window to 72 hours. A longer window aligns more closely with when complications are most likely to emerge and increases the likelihood of identifying symptoms that may not be apparent at 24 or even 48 hours. Extending the time frame better aligns with a critical window for assessing postpartum complications such as hemorrhage, infection, and mental health crisis. We will be able to catch more complications where their signs and symptoms do not present until the closer to the 72-hour mark. In closing, I urge the committee to consider a 72-hour outreach window to support flexibility in identifying high-risk populations and to recognize the clinical importance of direct communication. These evidence-informed adjustments will strengthen the bill and, more importantly, improve outcomes for the women and families we serve. We are also supportive of the sponsor's amendment to allow for other communication modalities to account for patient choice. Thank you for your time, and we urge a favorable report on SB 348.
Good afternoon, Chair Bidle and members of the Senate Finance Committee. My name is Joy Shucker, and I am a nurse leader at Sinai Hospital. Thank you for the opportunity to testify in support of Senate Bill 348 with amendments. As nurses, we see firsthand that the postpartum period is a critical and highly individualized time. We strongly support the bill's intent to ensure timely outreach to birthing parents after discharge, particularly those at high risk for complications. That goal is essential in improving maternal outcomes in Maryland. For certain high-risk patients, such as those with severe hypertension, hemorrhage risk, complex medical conditions, and acute behavioral health concerns, contact within 24 to 48 hours is necessary and often life-saving. Hospitals already prioritize these patients for rapid follow-up based on clinical judgment and discharge planning. However, for many birthing parents, the first 24 to 48 hours at home can be overwhelming. Patients may be recovering physically, managing pain, and caring for a newborn, all while managing sleep deprivation. In those situations, outreach that occurs slightly later or through a preferred method such as secure text or patient portal often results in better engagement and more meaningful support. This proposed amendment to allow outreach within 72 hours preserves urgency where it is clinically needed, while providing flexibility to engage patient in ways that are realistic, respectful, and effective.
This time frame remains consistent with accepted postpartum care standards and clinical guidelines. We also support allowing patient choice related to the methods with which we contact them. Some patients would rather a text or message via the patient portal or email rather than a direct call. We believe the slight change from call to contact meets patient choice preferences, affording them more autonomy within their care. Finally, it is critical that hospital outreach reinforces, not replaces, the ongoing relationship between the birthing parent and their OBGYN or midwife, who are best positioned to manage recovery and long-term maternal health. For these reasons, we respectfully urge a favorable report with a proposed amendment. Thank you for your time.
Thank you. Senator Connell, saw your light.
Thank you, Madam Chair. I'm a little skeptical of it. Help me to understand. So, like, why do you need the additional time? Maybe Natasha, maybe if you could answer, like, is it, why do you need to change it to 72 hours versus the current window? I mean, you're not saying not to make the call, right?
Right.
But how is it more beneficial to give it a little bit more time? I see that it could be sleep deprived, but I got to be honest, I've had a few kids, and I don't think I'm any less sleep deprived after 72 hours versus 48 hours. But I mean, like, so why do you need more time?
It just provides a bit more flexibility because of how rigid the timeline is in statute. As some of the nurses have mentioned, when it's a weekend, a holiday, or otherwise, patients don't always respond then. And sometimes the complications arise after that window. And so just the modest 24 hours gives a little bit more time to make those outreach. And it still falls within clinical guidelines. There's nothing that specifically says these sorts of calls have to happen within 24 to 48 hours. So it still aligns with guidelines to extend it, provide some flexibility, and it doesn't replace, as was mentioned by one of the nurses, the other sorts of outreach and contacts hospitals have with their patients.
Yeah. There's nothing in the existing law that says you have to speak to the person, right? Or does it say that you can leave a voicemail?
Correct.
Right?
Yes.
Okay. And then as far as the preferred modality issue, I understand what you're trying to do with the contact thing versus whatever, but does that mean that you're just going to forego the calling altogether and just start sending text messages? And I have to tell you, the patient portal sucks the life out of me sometimes. Like, you know, but so I don't know about that as being, and some people like it, I get it, but I've got like multiple logins and I can never remember any of them. So like, what I'm trying to understand then is like, so what does it mean? Can you just like check the box then and say contact? That means you did it by like sending them a text message, or are you saying that if the patient prefers a text message that you can text them? Because that's not, I think, what does the amendment say that you can contact them by their requested modality?
The amendment's very simple to change
it to
call
contact.
to contacts, just so that it gives that flexibility. And that does not mean the hospitals wouldn't do phone calls, but in the situations where patients do prefer other engagements, and I think as MedStar's data has shown, it is very effective for people who don't accept phone calls. And really, everyone's here not because they just want to check a box, because the nurses in the hospitals do care about having this engagement and making the follow-up with the patients, and just want this window, this change of time and modality to give a little bit more flexibility and really align with what we're seeing as the realities in the hospital.
For high-risk patients. Exactly. Right? And so these are high-risk patients to give them a call. Okay, and I think just one more question, Madam Chair. So can you, I don't know, maybe for the doctor, like, how is it that, I think what I'm trying to understand what you were saying, that you can identify some of the complications post-pregnancy better with a little bit more time versus the shorter window of time? I'm trying to understand, like postpartum depression or something, is that more likely to present 72 hours versus 48 hours, or what exactly is intended there?
So my colleague from Hopkins is the one who alluded to the 2/3 happen more than 3 days, readmissions happen more than 3 days after discharge.
Okay.
So those readmissions are not happening in that 24 to 48 hour window of when the current call is supposed to be made. I would say just anecdotally, since we don't have our data from MedStar, that's probably what we see at MedStar as well, that they aren't coming back within 24 or 48 hours. If they do have something going on, it's delayed. Most of the time, the mood changes that happen in the first 1 to 2 weeks after delivery, it is difficult to determine if that is true postpartum depression or baby blues, which is a more transient condition. So the actual recommendation and the guideline that we follow from ACOG for perinatal mental health involves having those patients come back somewhere for either a visit in the office or a telehealth visit approximately 2 weeks after delivery, because that's when we're better able to determine, is this something that is transient, that is happening because you have all that sleep deprivation plus the hormonal changes that are happening immediately postpartum, or is this something now that is more of a postpartum depression picture that we need to be managing in a longitudinal way, potentially up to 6 months, and then maybe for some people transitioning into a more long-term care situation for depression on a long-standing scale.
But they're usually seen in person at some point. What is the usual, like after birth, like what, after
Postpartum
discharge?
visits occur typically in the usual model at 6 weeks postpartum. Most places now do try to see patients a second visit in between. But that
Especially
is
for
also
high risk or
dependent on
something.
people engaging
Sure.
and coming to visits. And it also depends on what the patient's high-risk specific condition is. Most places have their patients come back if they have other high-risk conditions, such as hypertension, within 1 week of having delivered for an actual office visit with either a nurse or a provider so that they can have a physical blood pressure check done and can be evaluated for concerning symptoms for postpartum preeclampsia.
Okay, all right. Thank you, Madam Chair.
You're welcome, Senator.
Yeah, thank you, Madam Chair. So just a few follow-up questions to some of the points that my colleague opened up here. I think in one of your responses that you said readmissions happen usually at the 3-day mark. Is that kind of what your sense was?
Greater than
In the 3-day
the
mark.
majority of them.
So I'm just trying to understand why then, with the requirement to call between 24 and 48 hours, which is before the 3-day mark, wouldn't that be helpful to be able to circumvent potentially a readmission to catch them before they start coming back in? Isn't that part of the point
It
of?
depends on when the symptoms arise. I mean, this gives a larger window to catch those postpartum conditions.
But you're also, I guess, leaving potentially a wider window for a readmission too, and that, right? If you're not calling until a little bit later, you're missing
Potentially.
those folks that could otherwise come back beforehand. The process, it sounds like, in looking at, the Maryland Associated County Health Officers' testimony here, there was a work group that was set up, right, to kind of look through the different options. And was 24 to 48 the consensus of the work group? Was that not the consensus?
In reading
And I think the hospitals,
the testimony, that was the opinion. And now we have 6 months of practice and evidence.
so this hasn't been placed nearly a year yet, and we're coming back to the General Assembly asking for some modification, even after a consensus process that occurred that brought all the stakeholders together, I assume including the hospitals, right? Weren't the hospitals part of the stakeholder work group?
Yeah, that's my understanding, is that there was a stakeholder work group, subcommittee meetings, a complete process that the bill goes through. Again, as my colleague just mentioned, the hospitals, this went into effect in July, and from then, this is what they're seeing in reality when they're doing these phone calls. And again, because they really want to comply with the law, they really want to ensure engagement happens, we have put forward this bill and the amendment to ensure that that could happen. There's no intent to circumvent the law. There's no intent to weaken it. It really is coming from a place of trying to ensure that there is actual engagement.
And if I could just add, in our experience, the first phone call is not successful, in our experience, 54% of the time. So it also gives you a window to call back, because our intent is not to check the box and leave a message on the machine and say we tried. It is to make contact. So it also allows us to call back, because 54%
But even if you
of
made
the time,
if you made the window larger and you were making the call at hour 72, it still might be 54% people not answering the phone call, right?
Yeah, I don't know.
I mean, we don't have a huge amount of data here except the last 6 months look back, which seems a little bit short to, be reopening this after a work group process that just wrapped up in 2024, following legislation that, this committee had passed earlier, to now be like looking back at it, without the ability to kind of do another consensus kind of work group look. And it's just a very small window to seemingly be basing it on, I guess. Would there be resistance to calling within the first 24 to 48 hour window and then one at 72? Or maybe making it a text reach out, like a communication by text within the 24 to 48 hour, and if you don't hear back, then a call at the 72-hour mark?
So for MedStar, that is what our preference would be, is to have the flexibility to do the texting outreach, and then anyone who does not respond to the texting, then we would facilitate a phone call. So that gives us the additional flexibility to make sure that we're reaching everyone and we're doing the engagement and actually getting those concerns.
Okay. Okay. Thank you, Madam Chair.
Such a little bill that creates so much conversation. I don't see any other questions for this panel. Thank you all very much.
Thank you.
Thank you. I think we have a couple unfavorables. I'm sorry, what's this bill number? Okay, is Larry Polsky still here? Robin Elliott and Christine Crone? Pardon me? Joy was up on that panel. Dr. Banfield, I don't think was there. Okay. Dr. Polsky, why don't you start?
Madam Chair, members of the committee, my name is Larry Polsky. I'm here on behalf of the Maryland Association of County Health Officers in opposition to HB 348. I want to start by emphasizing that we have way too many maternal deaths in Maryland. Our maternal mortality rate is 10 times higher than the best performing nations around the globe, and deaths among African American women are even higher. I serve on the Maryland Maternal Mortality Review Team. Over 80% of maternal deaths in our state are judged to be preventable. 2 years ago, this committee voted to advance a bill to help decrease preventable deaths. The bill before you today will weaken an important component of that legislation less than 1 year after it went into effect. The 24 to 48 and I should mention I was part of the work group from 2 years ago. The 24 to 48 hour window to contact high-risk patients after discharge was carefully chosen by a diverse group of stakeholders as the optimal time to identify women exhibiting symptoms of some of the leading causes of maternal death, including those struggling with opioid use disorder and those with worsening symptoms of preeclampsia and cardiovascular disease. As Senator Lamb mentioned, the goal is to contact high-risk patients at a point when you can prevent readmission, not wait until further on when hospital care is already more likely. Overdoses cause 3 times more maternal deaths than the next leading cause. Having treated pregnant and postpartum patients with substance use disorders for over a decade, I've seen that those who lack access to treatment begin withdrawal symptoms and they worsen between 24 to 48 hours. Those women are more likely to seek illicit drug sources if they are not quickly linked to care. The quality of, and just in response to the amendment, which I had not seen prior, the quality of information obtained from a text in this healthcare context is inferior to a voice conversation. With that said, MACHA would be comfortable if a hospital staff makes 2 attempts to contact a patient by phone, and if they are unsuccessful, a text is certainly better than nothing. Maryland's maternal mortality rate, like that across the U.S., is shockingly high. We can do better. Maryland should not backpedal on a relatively new strategy that has the potential to help save lives. Thank you very much for your consideration.
Good afternoon, Robin Elliott here on behalf of the American College of Nurse Midwives. We too are in opposition to the bill. We do understand that with any legislation, there is always an implementation period and implementation challenges. So we would urge the committee and the stakeholders, and appreciate Senator Jackson lifting up this implementation question, but we would urge to handle it by the stakeholder group convening again. I was part of the stakeholder group. There were 25 to 35 people on each meeting, so it was a lot of people, including the Secretary of Health. So we would just ask to revisit this outside of legislation so that we can all work together on it. Thank you.
Good afternoon, members of the committee. Chair Beidel, thank you again for having me testify on Senate Bill 348. I'm with the American College of Obstetricians and Gynecologists, the Maryland section, who represents physicians who provide obstetric and gynecologic care to women and families across Maryland. We respectfully oppose Senate Bill 348, which would amend the Maryland Maternal Health Act of 2024. In an effort to not repeat the previous panelists' remarks, I will just conclude by saying Maryland ACOG strongly urges the committee to reject the proposed extension of the follow-up timeframe, preserving the 24 to 48-hour window as enacted. And lastly, if the committee believes a statutory change is needed, Maryland ACOG would not oppose replacing call with contact to allow patient-centered flexibility in communication methods. Thank you.
Thank you for your testimony. I don't see any additional questions. Oh, Senator Jack.
Thanks, Madam Chair. Just have a question, anybody can answer it. Can you point to research that directly demonstrates superior outcomes for 24 to 48 hours compared to 48 to 72-hour window?
There have been no randomized controlled trials trying different intervals of call, so there is nothing that shows that 72 hours would be superior, inferior, and
so what are you going by that suggests that 24 to 48 hours is?
So during the work group, I think what stood out more than anything else is, again, that 3 times more deaths are attributable to overdoses than any other maternal mortality cause. And women who lack access to either Suboxone or methadone after discharge, their symptoms will start to worsen within that 24 to 48 hour period. Generally, they're controlled in the hospital. If you can catch someone at that point, then you can get them in, link them with care. If not, then they will invariably end up using illicit substances, and then we end up with real problems. And then there certainly is additional data. There is additional data that shows that if there are going to be serious complications from preeclampsia, 90% of the time that happens by day 6 postpartum, keeping in mind that our cesarean section rate in Maryland is also astronomically high at 30+%, and all of those women are not going home until postpartum day 4 into 5, so delaying 3 more days to catch them, you're missing your window for serious preeclampsia problems. So no, that's not based on my personal, but so in my written testimony,
your experience?
In my written testimony, there's resource.
Sir, can you just answer the question?
Yeah, I'm sorry, Senator. So in my written testimony, you can find the citation for the preeclampsia data. And then I am saying that, yes, in terms of withdrawal symptoms, it is my experience after 10+ years of dedicated care that, yes.
Okay, thank you. And do you have any evidence that patients are actually reachable within 24 hours, particularly those who are transitioning at home?
Well, coming from a public health background, after 25 years of delivering babies, I would say that we deal with a population that is very difficult to reach, oftentimes lacking a whole lot of resources. So one of the things that we found is useful is, in this case, in this context, that the staff of the hospital would make sure the patient is aware that in that 24 to 48-hour range to expect a call and make sure that they were able to receive a phone call. If the patient would say, and we see this with some of our patients, that they're out of minutes and texting is the only way that you can reach them, then certainly that would be the default. But if a patient knows that they're going to be contacted by the hospital staff, I think they would be much more likely to pick up the phone.
Okay, do you have any evidence of that? Or is that based off your experience as well?
That is also based off my experience.
Okay. And so the Maryland Hospital Association, which represents 50 hospitals, based off of their experience, thinks that the 48 to 72 is a better window with a higher rate of contact success.
So again, I get to quality and quantity. Without a doubt, you can contact more patients with text. But I think any good clinician, physician, nurse practitioner would say that sometimes it's not what the patient tells you, but it's how they express it. And that does not come through in the context of a text. And you can imagine that for things like domestic violence, there are other situations where just texting is not going to convey the information that you need.
Okay, thank you. Thank you, Madam Chair.
Thank you. Senator Lamb?
Thank you, Madam Chair. So Dr. Paulson, you're an OBGYN, right?
Yes.
With many years of practice. And so when ACOG, the OBGYN Society, recommends this, and the thought here is that you're not doing any harm by 24 to 48 hours, and there potentially is some harm by extending that window, right?
Correct.
Okay. And, I think the more frequent touches in narrow windows, the better from my perspective. We're obviously trying to balance this. I mean, I would be fine if you called 24, 48, 72, 84, 96 hours in succession until you actually get a hold of someone. We're trying to balance that here, but there are some very real risks of not trying to catch things as early as possible. And just because you're not able to get a hold of someone within that 48-hour window doesn't mean that we should try and just make the window larger.
Well, as Robin mentioned, during the work group meetings, and there were multiple work group meetings, this interval was not chosen flippantly. There was a lot of discussion, and this was felt by consensus opinion from the stakeholders to be the opportune time to try to reach patients.
So last question here then, do you agree that more contacts are always better? So, when you support a 24 and 48-hour window of contact and a 72-hour window of contact? Well, if in an ideal world, right?
If your question is, would the hospitals contact in that 24 to 48 window and in addition contact, I mean, that would be fine. I would say that some clinical judgment would be used at that point. If patients monitoring their blood pressures at home, they had preeclampsia, depending on how their blood pressures have trended over those first 48 hours. So I'm not sure that it would need to be mandatory, but that would certainly be a potential best practice.
Or if they are not able to get in contact within 48, then contact them again in 7.
Absolutely, yes.
Okay, thank you.
Senator Jackson?
Is it possible that you can contact too early before symptoms present themselves and still miss out or as well?
There's no perfect, and it becomes a practical issue. So if the hospitals would be agreeable to contact patients every 2 to 3 days until the 2-week window, where patients are the first time that they're likely to have an outpatient visit, that would be fine. But otherwise, I'm not quite sure how you want the answer.
Well, it was testimony that sometimes it takes a little time outside of the 24 to 48 hour for symptoms to show up.
And again, at that point, clinical judgment can be used. So if it was my patient and I saw blood pressures were still concerning to me at the 48-hour mark, then I would want to recontact that patient 72 or 96 hours at some interval 1 to 2 days later to make sure they're doing well. And it's also in the context of understanding the resources and capabilities of your patient. Patients who have a tremendous amount of resources, that's fine, but for single moms, and we can go on and on about disadvantaged patients, that yes, I would use clinical judgment to do a follow-up call for those patients.
So one last question. So and the good senator brought this up, would you be okay if within the first 24 to 48 hours there was a text message, and then if there was no contact, the additional 24 hours could be used to make a phone call, a follow-up?
Well, again, I think that a phone call, a voice call, is the best way to get quality information. So if I don't think there's a substitute for attempting to make phone calls. Again,
Okay,
if those are several attempts have been made and they're unsuccessful, then defaulting.
But based on the data from Babies, Safe Mom program, there was a 60% engagement rate with texting in the District of Columbia versus 34% engagement here in Maryland by just phone call.
I guess what I'm trying to convey is I just don't know the quality of that 60%. I don't know what information was gleaned. There's no actual outcome measures. There's just the outcome is a phone call. The outcome's an engagement, but what we're trying to do is we're trying to decrease serious morbidity, somebody having a stroke because of serious high blood pressure, somebody ending up needing, also we can go through a whole laundry list of things with infections and other sorts of problems. We're trying to prevent that. We're not just trying to, quote unquote, engage someone. We're
Right.
trying to prevent deaths, and we're trying to prevent serious morbidity.
Okay. Thank you, Madam Chair.
Thank you, Senator. I think that ends the hearing on Senate Bill 348. Thank you all very much. Now, committee, you said I could remind you, we have 2 more bills. We have 31 witnesses. It is 5 after 5. Look, I'll stay as long as you like, but I just ask you to keep your questions short and address them directly to one person. Okay. No, they do not. Each one does not have to get a question. So Senator Washington is here. She's been very patient today. Senator Washington, we are going to now hear your bill. It is a bill that we've sort of heard a few times. It is the State Board of Social Work Examiners conditional license to practice social work. It has changed since last year. We have Senator Mary Washington, and you're going to bring up Felicia Ross, Amber Flanagan, Kaylee Powell, and Christy Love will be virtual. I will ask that the senator has as much time as she needs. I say that carefully. You have as much time as you need. The witnesses all have 2 minutes, so thank you very much.
Thank you, and I do appreciate, we have been working out this issue for a few years now, and I'm excited that I believe we're at a resolution, a good place to begin. So yes, Madam Chair, Vice Chair Hayes, and colleagues, for the record, I'm Senator Mary Washington, and I'm here to present Senate Bill 18. So, to the chair's point or comment, I do want to acknowledge and appreciate this committee working and engaging seriously and thoughtfully with all the stakeholders and impacted people on this social work licensure issue since Senate Bill 871, and that was during the 2023 session. We've debated, we've amended legislation, we've convened a work group, in fact, at your direction. And I just want to start with saying that the work group findings that was established, and it included the State Board of Social Work Examiners, some educators, practitioners, representatives of the Association of Social Work Boards, and other stakeholders. And it was charged with conducting a real comprehensive review of social work licensure and the requirements. And they met once or at least sometimes twice a month for over 18 months. And they produced a 146-page final report. And that final report really reflected extensive research, data analysis, and stakeholder input. So top items, the work group determined that all existing license categories should remain in place. So at first there was some consideration of maybe we should get rid of the bachelors, maybe we should get rid of, but they're saying they should all remain in place. The second is that what happens in our colleges and universities and the training programs and the experiential, both the experiential requirements as well as the educational requirements are good. There doesn't need to be, those don't need to be changed. And that alternative pathways to licensure should be, and this is the recommendation of the committee, of the work group, should be allowed at the bachelor and master's level. So that's what they kind of decided. So there was really a clear and overwhelming agreement that Maryland should allow multiple ways to demonstrate competency in this area. So in order to arrive at that recommendation, they looked at social work education nationally and in our Maryland colleges and universities. And they specifically reviewed the assertion that the exam passage rates are some indication of the rigor or the quality of the programs that we're preparing our social work graduates. And they found that every single social work program in Maryland is accredited and governed by the Council on Social Work Education, and that's a national accrediting body for social work profession. Also, that the accreditation needed requires multiple components, not a single pass or fail, but multiple components, including competency-based education, extensive supervised field work, and continuous assessment. And I want to just raise these again because we were really focused on a test and et cetera, and I think the understanding of the amount of training and hours of work and supervision that happens to get to the point is really important. So this process leading up to licensure, in order to become eligible for licensure, you must complete years of graduate level coursework, at least 60 credits. And again, this is before even graduating, 900 to 1,200 hours of supervised field education. Each person, each candidate must demonstrate their ability to practice ethically, to exercise professional judgment, and to work safely with real clients. And they are evaluated repeatedly by licensed professionals and faculty. So to be clear, students who cannot demonstrate confidence do not pass field placement and they do not graduate. So graduation from an accredited social work program is itself the result of rigorous screening, evaluation, and professional oversight. So each year, we can be satisfied that Maryland produces graduates, hundreds of them at the master's level, who have already met the educational and field-based standards of their profession. Another consideration that the work group met, and also we as legislators must address, is that Maryland, there is a workforce challenge. And I know that the committee knows that we face severe shortages in behavioral health professions. Social workers are essential across our schools, our hospitals, our community-based providers, government agencies, reentry programs. And yet too many otherwise qualified graduates are delayed or lost entirely at the entry and mid-level practice. You're going to hear from people that say rather than working in Maryland, they're working in DC or Virginia because they offer this, they have an alternative way to exercise their practice. In written testimony to this committee, Dr. O'Reilly, a Maryland social work educator with 25 years of experience who works in rural settings, really described what this looks like on the ground. She noted that 98% of counties designated as having a mental health workforce shortage are rural, even though rates of mental health diagnoses in rural communities are comparable to other urban regions. So in rural communities, depression, substance abuse, family challenges often go untreated, and not because their need is lower, but because licensed providers are harder to find. So Senate bill builds on these and other realities facing Maryland. So what do we do? What does the bill do? The bill implements the work group's recommendation in a very narrowed, considered, controlled, and fully supervised way. It reflects the work group's guidance, stakeholder input, and the committee's prior engagement and comments. It creates an alternative practice-based pathway to licensure at the bachelor's and master's level, while preserving the exam for those who choose to take it, and also they maintain it for the clinical licensure. And they're the only social workers that can operate independently without supervision. So we still require the exam for that professional license. Applicants would still be required to complete accredited education, supervise all the things that are required, and check background checks and meet all board requirements. I'm happy to say that the social work, that we're coming to a sense that we as Maryland need to do this, and the State Board of Social Work Examiners are favorable with amendments. And we've received some ideas about amendments from the National Association of Social Work, as well as SWARE. And in response to concerns about clarity and unintended consequences, we have offered an amendment, and this is something the committee, the board raised, is that they wish to maintain the conditional license. So the circumstances in which, around COVID, et cetera, when the exam wasn't available, or perhaps any other emergency, that there still be a conditional license. And that there would be we would have an amendment to change what we're doing here as practice-based licensure, which is actually more correct. And it's an alternative pathway while retaining the existing conditions. This approach reflects both the input of advocates as well as the board, and it assures that the practice-based licensure is clearly defined as a structured, supervised pathway, and it is full licensure while it's preserving the board's existing conditional authority to grant conditional licenses, should we have future public health or other disruptions. So the amendments that you will have before you will clearly establish parity in the rights and professional standings between practice-based and exam-based. So that means there'll be no like red mark or something on their license. It will set clear supervising standards, allow sufficient time to complete required practice hours. It will ensure that the supervised practice hours completed under this pathway count towards advanced licensure, and that also will provide for ongoing reporting and oversight so that we can assess how it's functioning. But of course, ultimately, I defer to the committee's judgment and appreciate your continued work to strengthen this bill. Now, as I'm going towards a close, let you know that other states have been doing this for quite a while. In fact, Illinois started and banned the requirement to have an exam. And again, we're not doing that. But they've added nearly 5,000 licensed social workers since 2021 without any increase in ethics and safety violations. So we have to look at the data and continued assertions that doing this, when other states are doing it, is going to result in ethics violations or safety to the public, do not withhold. There are there is clear evidence. Utah eliminated the exam in 2023, and they strengthened supervised experience instead. So no more exam, just more supervised experience. Minnesota expanded its provisional licensing pathway in 2024. Does not require an exam. Now, Washington, D.C., our neighbor, has created this alternative pathway, allowing applicants to qualify as we're describing now. So in just a couple months, over 250 individuals have used the pathway, and that's an 18% increase in master's level social workers in just a couple of months. Maryland would be aligning ourselves with others. Now, again, to be clear, we're not eliminating the exam. SB 810 does not lower standards. There is a significant role of supervision in protecting the public, and it does not create a lesser or second-tier licensure. Now, just a moment about the testimony that you will hear following this panel's, and we reviewed the letters of opposition, because that's what you do, and we found that some people signed up and they didn't list their affiliation, so we did some research. So much of the formal opposition submitted on this bill comes from the Association of Social Work Boards and from individuals who work for, consult, or otherwise are affiliated with ASWB. Let me say that again. It is the organization that develops, administers, and sells the social work license exam. There is a director of education and programs from ASWB who will be testifying, an item development consultant who's not identified on your list who will be testifying, an examination committee person who works for ASWB who will be testifying, and a HUMRO contractor who works for ASWB who will be testifying. In contrast, who you're going to hear from now are people who have done social work training in Maryland, have served on the work group over the last, and actually have worked on this for the last few years, and are our constituents. So I respectfully, so after this years of study, we did the work process, we have careful consideration of the evidence. This bill, as I said, does not weaken standards, I believe we have a path forward. We're listening to the expertise of the educators and the practitioners. We're listening to the people who are our next generation of social workers. We are listening to employers who are struggling to hire people to serve our population and dealing with shortage areas. And our communities need us to act now. So I ask respectfully for a favorable report on this bill as amended, and I thank you. And I'll give you my sponsor program panel, and happy to answer questions.
Thank you, Senator.
Oh,
Good afternoon, Chair, Vice Chair, and honorable members of the committee. My name is Felicia Ross. I'm an LCSW-C. I'm the president of SWARE, and I am out of District 23. The first time I sat here in 2023, I told you about failing my LMSW exam by 1 point. A 3.8 GPA from Simmons University and a master's program, over 1,000 hours of supervised clinical practicum, and then 1 point on a pass-fail exam, and I was not considered a real social worker. Not because I wasn't competent, because I hadn't passed an exam. And since then, I have passed the clinical exam, and I am now in the position to hire. I sat on the work group on social worker requirements for licensure as the NAACP appointee, and watched month after month as ASWB was more concerned with how concerns were raised than with addressing said concerns. And I want to address what I know you will probably hear today. You will probably hear this week in standards. There is no published evidence that the licensing exam predicts competent or protects the public, as our sponsor said. And to imply that exam failure reflects inadequate education when ASWB's own data confirms there are racial disparities is not a policy concern. That is a blatant macro aggression. You will hear this endangers clients. I currently cannot fill critical positions as a clinical director, not because qualified people do not exist, but because the current licensure process keeps them out. And we are losing quality providers from the communities they serve. And that is what is endangering our consumers and our clients. We saw a 4% decrease in LMSW since February 2024. And then you will probably hear that this devalues the profession. As our sponsor mentioned, there was an 18% increase in new licenses in 72 days with DC's educational pathway, and 58% of those licensees live here in Maryland. Our people are getting licensed next door because we haven't made it possible here. They work and pay taxes in a state they can't get employed, and that is what devalues the field. Before I close, Carla J. Abney, chair of the work group and president of the Greater Washington Society for Clinical Social Work, was not able to be here today, but she did ask me to share her support. She writes that SB 18 serves to increase the workforce of social workers to assist Marylanders by providing conditional licenses to BSW and MSW graduates as they work towards their full licensure. And so I respectfully urge a favorable report on SB 18. Thank you.
Go ahead. Please.
Hello, my name is Amber Flanagan. I'm from District 34. Hello, Chair Biden and members of the Senate Committee, the Finance Committee. Happy Black History Month, and thank you for the opportunity to allow me to speak. I respectfully urge a favorable report on SB 18. I am a Black woman and a master's level social worker whose experience reflect the real impact of Maryland's current licensure system. I earned an MSW fully prepared to serve my community, yet I was unable to pass the Maryland license exam after 6 attempts, each time missing the score by only a few points. With every attempt, I received no meaningful guidance or feedback, just another bill and another barrier to moving forward. That process was exhausting, financially, emotionally, and professionally. It made me question myself, not because I wasn't capable, but because the system offered no other way to demonstrate competence. As a Black woman, it was especially discouraging to feel shut out of a profession I was trained for and committed to with no clear path forward. That is when I pursued a licensure in Washington, D.C. through their practice-based pathway program. Since becoming licensed, I've been thriving. I am practicing safely and ethically, and I am always affirmed for my skills and the quality of my work. My performance speaks for itself. My pathway is confidential, and I am treated like the professional I am. My amazing supervisor has even said how sad it is that Maryland is losing strong social workers because of this barrier. My story represents many others. Students who are afraid that the exam will stop them before they start, practitioners who know they are competent but can't get past the test, agencies that can't hire qualified staff, educators who watch graduates leave the state, and communities, especially Black and underserved communities, who feel the impact of the workforce shortage every day. SB 18 does not lower standards. It recognizes practice, supervision, and real-world competence. It keeps skilled professionals working instead of pushing them out. Maryland invested in my education, but DC is benefiting from my work. Thank you for your time and your consideration. God bless.
Thank you. One more person to testify.
Good afternoon, Madam Chair and members of the committee. My name is Kaylee Powell, and I'm here today in support of Senate Bill 18. Because the current licensure system creates barriers that disproportionately impact Black social workers, like myself, and threatens Maryland's ability to meet the needs of our communities. I am a Master of Social Work student from Baltimore, Maryland. I recently graduated from Salisbury University and the University of Maryland Eastern Shore, earning degrees in social work and sociology with a cumulative GPA of 4.0 at both institutions. And yet, I am concerned that I may be held back from practicing social work due to the licensing exam. I want to serve Maryland in many capacities, particularly with children and families who have been historically underserved by our systems. My commitment to this work is grounded in lived experience, academic training, and a deep understanding of the communities that I serve cannot be measured on a multiple-choice exam. This bill creates an alternative pathway to licensure that values demonstrated competence, supervised practice, and ethical service, rather than the reliance on a singular exam. By doing so, it ensures that capable, well-trained social workers are not excluded from the profession due to barriers unrelated to their ability to practice effectively. To be clear, the issue is not that women of color are pursuing social work, are failing to serve their communities, promote social justice, or recognize dignity and worth of a person. Rather, the issue lies with the exam itself. An assessment format that reduces a nuanced profession to a multiple-choice exam cannot accurately measure lived experience, ethical judgment, cultural humility, or the values that guide real-world practice. I plan to graduate in May with my Master of Social Work, and I've never lived outside of Maryland. But if this bill does not pass and I'm unable to become licensed here, I will need to begin my career in a more accessible jurisdiction, such as Washington, D.C. or Virginia, simply to earn a livable wage. If you issue a favorable report and this alternative pathway becomes law, Maryland could follow the example of Washington, D.C., which increased its master-level workforce by 18% in over 2 months, or Illinois, which doubled its workforce in 2 years without an increase in sanctions. These policies do work, and they do not compromise public safety. Thank you for your time.
Thank you. Do I have any questions for this panel? Oh, wait a minute, we have one more virtual person, I'm sorry. Christy Love, can you unmute and testify for us, please?
Good evening, Chair Bidell and members of the committee. My name is Christy Love. I'm a social worker in District 32 constituent, and I respectfully request a favorable report on SB 18. I earned my MSW from the Howard University over 15 years ago. I took the licensing exam at least 5 times and missed passing by just a few points each time. Despite strong education and internship experience, my career growth was limited because I did not have the LMSW. That created real professional barriers and honestly a sense of stigma, even though I was fully trained and serving with integrity and competency. Last year, DC approved an educational pathway to licensure. Because of that change, I finally became licensed. Almost immediately, new job opportunities opened to me, and my salary improved. Pathways work. They strengthen the workforce without lowering standards. DC is not alone. Several other states have adopted similar approaches, and notably more than half of newly licensed social workers in DC are Maryland residents. That should matter to us. Maryland needs more social workers now more than ever. Social workers are not only therapists, y'all, and we are not limited to child welfare. We serve in hospitals, schools, senior programs, and community settings, wherever people need support and protection. I currently work with older adults, helping them maintain social connections, emotional wellness, and independence. I am a longtime Maryland resident, and I want to fully serve here, but my best opportunities have been in DC because of licensure access. SB 18 removes an unnecessary barrier and strengthens Maryland's workforce. Thank you for your time, your leadership, and your consideration. Again, I ask for a favorable report. Thank you.
Thank you, Christy. Do I have any questions now for this panel? Seeing no questions, thank you for your testimony. Now we have Charlotte Hoffman, William Doyle, and Daniel Raskover. Well, I don't think either of you are Charlotte, so she must not be here.
She is not here.
Is Sandra Moore virtual?
Good afternoon, Chair Beidel and members of the Senate Finance Committee. My name is Will Doyle. I'm a clinical social worker, Maryland resident in District 21, and the Vice President of Housing First at Pathways to Housing DC. I respectfully request a favorable report on SB 18. Maryland is currently facing a mental health workforce shortage and a growing demand for behavioral health services. SB 18 offers a practical and evidence-based solution to address both. The shortage of LMSWs is getting worse as they decrease by 4% from 2024 to 2026. Pathways to Housing DC opened in 2004 when we brought the Housing First model to Washington, DC. In 2018, we were thrilled to expand our work into Maryland. Using a client-centered approach, we serve Montgomery County residents experiencing homelessness who are living with substance use and co-occurring mental health disorders, particularly those whose needs are not met by existing programs. Since that time, we've significantly expanded outreach and housing services in Montgomery County. This includes serving youth through outreach efforts and operating the only homeless drop-in center for young adults ages 16 to 24 in the county. In doing this work, we've directly witnessed how the barrier of the ASWB exams has harmed our staff and clients, compromised our programs, and prevented the full use of available housing resources. As an employer of social workers, we are absolutely thrilled at the potential of hiring qualified professionals through this legislation. SB 18 would allow us to expand services and better meet the needs of Maryland communities. Due to a dramatic increase in need, we are currently working to grow our outpatient mental health clinic. The success of that effort depends entirely on our ability to hire social workers. Each year, we host 3 MSW interns in our Montgomery County programs with the goal of retaining them as employees. Right now, there is a real risk that despite our investment, they will seek licensure and employment in Washington, D.C. instead of Maryland. In just 72 days, 143 Maryland residents have already attained master's licensure in D.C. through their educational pathway. Passing SB 18 will help ensure that Maryland social workers can remain Maryland social workers and that our investments continue to benefit Maryland communities into the future.
Good evening to the Chair, Vice Chair, and esteemed members of the Senate Financial Committee. My name is Daniel Raskover, and I am a Master's of Social Work student at the University of Maryland, Baltimore. I also received my Bachelor's of Social Work from the University of Maryland, Baltimore County. Receiving a degree in social work on both the undergrad and grad level has afforded me the opportunity to meet some of the best and brightest upcoming social workers the state has to offer, and trust me when I say we've got some real change makers on our hands. We love what we do, and we are dedicated to bettering the lives of members in our communities. We care so much that we are spending thousands of dollars on a top-notch education from trusted educators in this field who test our knowledge in a variety of ways. Last semester, I had a 3-hour exam diagnosing a variety of different types of clients and a 20-page paper using theoretical framework to analyze a policy due the same week. Also, part of our education, noting that this is a course that we pay for, is our practicum placement. In my undergrad, I worked with a social worker at an elementary school, and this year I have the pleasure to work side by side with Trans Maryland. Wildly different opportunities, yet opportunities afforded to me because I am in this program. I'm on the ground in the field learning about communities I care about in order to be a well-rounded social worker when I graduate in the summer. I have hundreds of hours of in-community experience that is invaluable and nothing like I could ever learn in the classroom or on a test, which is why it's part of the curriculum. We need to have an alternative pathway to licensure that makes sense. No multiple choice exam, especially one that has been proven to be biased towards Black and brown social workers, will ever compare to the learning and growing we do not only with the community we are working in, but supported by board-approved supervisors as well. We love this state. We want to work here and serve our communities. Not offering an alternative option drives competent social workers out. Please help us stay here by creating an alternative path for us to do so. Please vote in favor of SB 18. Thank you so much.
Thank you. I don't see any questions for this panel. Thank you very much for your testimony. Okay, we have 3 people favorable with amendment: Kevin Meenan, Michael Massey, and Define McClellan.
Michael had to leave at 5:30.
Okay, I'm sorry. Thank you.
Good afternoon, Chair Beidle and members of the committee. I'm Dr. Daphne McClellan. I'm representing the Maryland chapter of the National Association of Social Workers. I'm their legislative chairperson, and I'm glad to be with you here this afternoon and glad to be able to support Senate Bill 18. It's been a lot of years that we've been working on this bill, and we are glad to see a bill that offers an alternative pathway that still lists the exam as an option, but also provides other options that will be available to people and still protect the public. So we know that the licensing exam has been difficult for many people and has shown disparities in pass rates. In fact, not only on the basis of race, but for older members and for people for whom English is not their first language. I know that people from the deaf community have testified in past years on this issue as well. These disparities reflect structural barriers that have shrunk the workforce Maryland urgently needs. We support Senate Bill 18 with some amendments. First, we would like to clarify whether conditional licensure is an ongoing alternative pathway and not just an emergency measure. Secondly, we clearly would like to specify which license levels are eligible, so the LBSW and the LMSW license, but that this pathway does not apply to independent clinical licensure. We recommend tying the 1,500 hours of supervision to competency-based standards, which would be set by the Board of Social Work Examiners with clear rules for documentation and oversight, perhaps even some letters of recommendation from the people who are doing the supervision, so we know that it's not just the hours that are being put in, but that the supervision is supported. We have seen amendments offered by the Board of Social Work Examiners, and we believe that working together with the sponsors, the BSWE, and like-minded groups in the next couple of weeks, we can find the right language which will meet people's needs. NASW would like to urge favorable with amendments. Thank you.
Thank you.
Good evening, Senator Beidle, or Chair Beidle, and Vice Chair Hayes, and members of the committee. My name is Kevin Meenan. I'm the board chair for the Maryland Board of Social Work Examiners. And I too would like to urge the committee to urge a favorable report with amendments, mainly in line with what Dr. McClellan was just saying and also what Senator Washington was saying previously. We see this not as necessarily an emergency bill, but a bill, determined to change the way in which we license social workers in the state of Maryland. LBSW and LMSW practitioners provide a number of services as generalists and advanced generalists in the practice of social work, providing assessment, planning, intervention, evaluation, case management, information and referral, counseling, policy, programming, and activities. We believe that these practices do require some type of competency oversight and measurement in order to move forward with what would be considered a full license. There is language in the bill that suggests that the practice hours for a conditional license would be for 1,500 hours. The board would like to take time to set those standards in consultation with other social work experts around number of hours and how to measure those competencies. The board also asserts that while a practice-based license, it sounds like an appropriate verbiage. We would like to assert a limited license on the front end, mainly because a limited license would not be eligible for the interstate compact license. So with that, sorry, ran out of time, but we would like to urge favorable with amendment. Thank you.
Thank you. Kevin, did you send in written testimony?
The board did, yes.
Okay, with the suggested amendment?
Yes.
Okay, thank you very much.
Welcome.
Okay, any questions for this panel? Seeing no questions, thank you for your testimony. Next we have Jennifer Henkel, Diane Brushrod, and Christine Crone, all unfavorable.
Good evening, Chair Beidel, distinguished committee members. My name is Jennifer Henkel. I'm the Senior Director of Member Engagement and Regulatory Services at ASWB. I'm testifying today in opposition to Senate Bill 18. I also serve as the Project Director for the Licensure Portability Grant funded by HRSA, which is overseeing the development and implementation of the Social Work Licensure Compact. ASWB has worked closely for several years with the Council of State Governments, the Department of Defense, and an extensive coalition of social work organizations to establish the compact. This is a bipartisan initiative to reduce barriers to care, mitigate workforce shortages, and ensure consistent access to qualified professionals, all while safeguarding public safety and trust. I'm here to express concerns about an optional exam requirement for entry into practice for bachelor's and master's level licensure in Maryland. Maryland, alongside 30 other states, has adopted compact legislation. The compact enables qualified social workers to obtain multi-state licenses, allowing them to provide services across jurisdictions while upholding essential public protections. Central to the compact and all the many professions you've heard from today, licensure requires an exam. The exam is a universal baseline requirement for competency. It includes this successful completion of a nationally recognized exam. So I urge the committee to carefully consider the implications of removing that exam requirement and its implications for Maryland social workers' participation in the compact. It's not arbitrary. It ensures licensure is consistent across states and that the public understands what a licensed social worker is. And also, so the board doesn't have to figure out a way to bifurcate the licensure and create a two-tiered licensing system. I'm happy to work with the board and the committee to come up with some ideas and systems about that. Happy to answer any questions. I also have a bit of good news. We have one fewer testifier. Stacey Hardy-Chandler was unable to continue later this evening, so you have one less person this evening. Thank you.
Good evening, Chair Beidel and members of the committee. My name is Christine Crone with the Greater Washington Society for Clinical Social Work, which was established in 1975 to advance clinical social work practice. Clinical social workers are licensed medical professionals who are trained to evaluate, diagnose, and treat mental health and substance use disorders. On behalf of the Maryland Legislative and Advocacy Committee of the Society, we respectfully oppose Senate Bill 18. Senate Bill 18 would create a conditional license for individuals who have not passed the required national licensing exam and would allow an alternative pathway to full licensure without ever passing an exam. No other licensed mental or behavioral health profession in Maryland permits practice without demonstrating competence through a standardized exam. Removing this safeguard for social workers undermines professional standards and raises serious public protection concerns. The bill would also impose new and unclear requirements on supervisors, creating additional administrative burdens for both supervisors and the Board of Social Work Examiners. The changes would likely reduce the number of qualified supervisors and available supervision sites at a time when supervision is already difficult to secure. Additionally, Senate Bill 18 would allow conditionally licensed master's level social workers to provide clinical treatment under supervision without requiring the clinical coursework or clinical internship experience that's currently required for clinical social work practice. We are concerned this creates a pathway for individuals to provide clinical care for complex mental health and substance use conditions without the educational foundation that ensures safe and effective treatment. For these reasons, we respectfully urge the committee to issue an unfavorable report on Senate Bill 18. Thank you.
One more.
Okay, thank you. Chair Beidel, Vice Chair Hayes, and members of the committee, good evening. My name is Dion Brown Bushrod. I'm a Maryland licensed certified clinical social worker, born and raised in Northeast Baltimore City, and I am here today in strong opposition to Senate Bill 18. Senate Bill 18 complicates Maryland's social work licensure system by making the licensing exam optional for bachelor's and master's level social workers. Health care needs are not optional, and the qualifications required to care for people should not be optional either. Bachelor's and master's level licensed social workers provide vital care. often independently and always with significant responsibility. They should not be treated as entry-level professionals or held to lower standards than compared to other healthcare providers. Today, this committee heard bills that expand and strengthen healthcare occupations. None of those bills propose removing or reducing licensing examinations. Last week, this bill's sponsor for Senate Bill 18 introduced Senate Bill 522, recognizing social workers as qualified healthcare professionals able to evaluate impairment in the workers' compensation system. That recognition is appropriate because licensure standards matter. The bill sponsor also co-sponsored Senate Bill 402, which will provide not pathways, but which will increase training and requirements for human service workers. So with other professions having increased qualifications, it does not make sense to decrease social work qualifications. Let's avoid setting troubling precedent that licensure requirements for social work is flexible, negotiable, or expendable. Lowering or bypassing the exam undermines professional credibility, parity with other healthcare professions, and public trust. And for those reasons, please vote to oppose this bill. Thank you.
Thank you. Do I have any questions for this panel? I don't see any questions. Thank you very much. We now have two virtual favorable, no, we have one left. Favorable, and it's Nina Bell from Morgan State University. Nina, are you ready?
Yes, I am.
We can hear you.
Good evening, Chair, Vice Chair, and members of the committee. My name is Nina Bell. I'm a PhD candidate of social work with the National Treasure Morgan State University. With more than 20 years of macro level and leadership experience, proudly serving urban communities such as Northern Philadelphia, Harlem, Southside Jamaica, Queens, and currently Baltimore City, where I've worked for the past 6 years. I'm here today in strong support of Senate Bill 0018. Briefly, I want to explain why this matters to me personally. Despite graduating summa cum laude in 2019 from the University of Southern California's Master's of Social Work program and having over a decade of leadership experience upon my matriculation and graduation, I was often screened out of roles that I was often highly overqualified for, solely because I lacked the title of LMSW. This was never about competence or baseline level knowledge. It was about access, reflecting a broader systemic pattern that affects and impacts Black and other people of color in social work. The 2023 Maryland Nonprofit Workforce Shortage Survey found that nearly 70% of Maryland nonprofits report job vacancies. Nearly half of them reported more openings than before the pandemic, particularly in the field of social services. Current reliance on the general licensure exam creates additional barriers, widening those workforce gaps. This bill allows Maryland to retain its talent, expand workforce participation, and remain competitive. I want to be absolutely clear, this bill does not create a two-tiered licensure, nor does it remove the licensure exam, nor does it change clinical standards or practice. It simply creates an alternative pathway, recognizing accredited education and demonstrated professional competence, rather than relying solely on an exam with well-documented and evidenced research racial disparities. SB 0018 is a concrete policy solution that expands employment, retention, and economic stability. This bill is about workforce sustainability, equity, and aligning Maryland's policies with the realities of who is actually doing the work. Please, in support of passage of Senate Bill 0018, thank you for your time and your leadership.
Thank you for your testimony. I do not see any questions. Thank you very much. I think we have, let's see. This is Dr. Frank Williams. Unfavorable. Dr. Williams?
Yes. Chair, Vice Chair, and members of the committee, thank you for the opportunity to speak. My name is Dr. Frank Williams, Director of Psychometrics at PSI, resident of the Ashburton neighborhood in Northwest Baltimore, and I provide consultation to the ASWB examination program. I want to emphasize why licensing exams remain essential to professional regulation and why exam modules were not pursued. The social work exam is not a barrier created by ASWB staff. It reflects minimum competence standards defined by practicing social workers themselves. Removing the exam may increase the workforce, but it would also increase the number of practitioners with gaps in essential knowledge, ultimately putting the public at risk. Last year, I led PSI's analysis of potential exam modules. Based on extensive data from ASWB and an independent HUMRO study, modular exams would significantly disadvantage test takers. Most candidates show uneven strengths across domains, and introducing separate cut scores for each module would sharply reduce pass rates. Reliability also drops when domains are split into small 50-item modules. None met the threshold reliability of 0.8, meaning scores would be less stable and less defensible. For these reasons, I advise ASWB against adopting modules, and I urge the committee to maintain evidence-based licensure standards. Thanks.
Thank you, Dr. Williams. I don't see any questions. We're going to bounce back to Sandra Moore, favorable. She's back into the virtual. Sandra, you want to give your testimony? Brianna first? Okay, I'm sorry. We're bouncing around. Brina Reed, you can go ahead. Unmute. Thank you.
Thank you. Good afternoon. My name is Benia Reed. I'm a Black woman, and I have been a consultant, an item writer, exam committee form review team as a volunteer. I'm speaking today on my own behalf in opposition to Senate Bill 18. I want to acknowledge the racial disparities in exam pass rates. I am familiar with the data, and those concerns deserve serious attention. However, eliminating the bachelor and master's licensing exams is not the solution. The exam remains the only objective, uniform measure of minimum competence across applicants. College programs and field placements vary widely, and without a standardized exam, there's no consistent baseline to protect the public. Having worked inside exam development for nearly 2 decades, I want to be clear. The social work exam is developed by an extraordinarily diverse group of professionals. The idea that it is written by or for a single dominant group is unequivocally false. It is also critical to acknowledge that broader structural inequities exist long before a test is taken by a candidate. The exam does not create those inequities, it reflects them. It is a thermometer, not the disease. Replacing the exam with 1,500 hours of supervision creates new barriers rather than removing them. Supervision is expensive, access is uneven, and quality is subjective. Supervision alone is not a reliable measure of minimal competence, and it shifts risk to supervisors, employers, and ultimately the public. In Maryland, nail techs, hairstylists are all required to pass a standardized licensing exam, even though they do not work with individuals who have mental health diagnoses, they aren't required to use clinical judgment, and they do not serve vulnerable populations in crisis. There's no alternative pathway that allows them to bypass their exams. Yet SB 18 would allow social workers who routinely make high-stakes decisions affecting vulnerable individuals to practice without one. Further, lowering standards in a female-dominated profession that serves vulnerable populations is dangerous. Equity is not achieved by lowering standards. It is achieved by addressing upstream inequities. For these reasons, I respectfully urge you to oppose Senate Bill 18. Thank you.
Thank you. I don't see any questions for this witness. We have Benia Reed on now. She is unfavorable. No, I'm sorry. Is that? No. Who do I have?
Sandra Moore.
Okay, Sandra Moore is back. Sandra?
Good afternoon, everyone. Thank you, Senator, Finance Committee, for this hearing today. My name is Sandra Moore. I am hoping for a favorable report on the SB 18. I began my career more than 30 years ago. I earned a 3.85 GPA from Grambling State University with a MSW. I was unable to pass for years. This haunted me. I questioned myself and wondered how could I successful academically still be blocked from practicing. I was even told to answer the exam like I was not Black, but to answer it as if I was white. Although deeply offended, I followed that advice. It still did not work. I never stopped serving the community, this work that has always been about clients and communities I serve. as Maryland faced rising homelessness, youth involvement in the justice system, and widespread unmet mental health needs, we need social workers who can understand and reflect the communities they serve. Last year, the District of Columbia created an educational pathway to licensure. Through that pathway, I finally obtained my LGSW. The only thing that has changed about me is the letters behind my name. Since then, I have been actively recruited, and I am. Is it time? Oh, wow.
You can finish your sentence. Go ahead.
Since then, I am, as I said, I've been in this field over 35 years. I am now filling multiple jobs offer. I live in Charles County, yet I am required to commute to Washington, D.C. in order to practice. I am tired of that drive, but more importantly, I want to work in the state where I live and where I pay taxes. Right now, I can't do that. I don't have that option. I would love to attain my LMSW in Maryland before I retire.
Okay.
And spend the rest.
Thank you, Sandra.
Oh, okay.
I said you could finish your sentence. I didn't say you could finish your whole story, but
oh,
thank
okay.
you.
I'm sorry.
Thank you. No, I understand though. I am happy that you're currently working. That's great. Do I have any questions for this person? Seeing no questions, thank you, Sandra. Thanks for sticking around. That ends the hearing on Senate Bill 18. And our last bill of the day, Senate Bill 326, is Senator Lamb, Physician Assistants Parity with Other Healthcare Practitioners. You have a panel, I think. Is he here? Where's the senator? There he is. Here it comes. Senator Lamb with Michael Tran, Robin Elliott, Dr. Jennifer Beauchamp, Kelly Schultz, and Jane Cranky. I was ready to call the meeting. Okay. Senator, you can start when you're ready.
All right, thank you, Madam Chair. Members of the Senate Finance Committee, I know the hour is late, so try to be brief here. We just happen to have the last bill. So for the record, Clarence Lamb, Senator District 12, here to present the Physicians Assistant Parity Act. This bill is a practical, technical update to Maryland law and makes some straightforward parity fixes to bring our physician's assistants to a level playing field with the rest of our advanced practice providers and other providers here in the state. The bill makes several changes to add PAs to sections of state law that already include nurse practitioners. These changes are not changing the scope of practice for physician's assistants, but just updating older sections of law to align them with the current scope of practice. Maryland law already recognizes physicians, nurse practitioners, and other licensed clinicians for their statutory actions, but does not consistently name physician assistants, even though PAs are licensed and routinely provide care as part of medical teams across Maryland. This inconsistency doesn't always show up as a daily delay in every facility, but it does create a fragile process. When the law omits physician's assistants, the system may require an extra handoff or a second clinician solely to satisfy a quirk of the statute, even when the physician's assistant is already clinically involved and qualified within the team. And so the bill really just adds physician's assistants to existing parts of the statute on provisions, for example, that pertain to correctional services and placement of pregnant incarcerated individuals. It adds them to be able to petition for guardianship of a disabled person. It adds them to certain healthcare decision-making as with regards to providing, withholding, or withdrawing treatment, for which authorization has been obtained. And it allows them to be a second on healthcare provider certification that an individual is incapable of making an informed decision regarding treatment. It also gives them the authority to working in conjunction with a physician to assent to voluntary admission of a minor or child to an adolescent unit of a state facility for treatment of a mental disorder. It also gives them the ability to sign off on voluntary admission of a disabled person. Other provisions include certifying an individual for involuntary admission to a facility or VA hospital, emergency evaluation, and the like. And the rest of it is really just kind of in the bill. It's really just adding things back into the statute that, for example, nurse practitioners have already the authority to do. This would create parity with the PAs. We agree with MedChi and the Office of the Public Defender on almost all aspects of the bill, so a lot of that has been worked out through a lot of negotiation and discussion that's taken place up to this point. The main point of dispute that's remaining is related to the use of physicians' assistants in involuntary admissions processes for patients with mental health conditions. While I agree with MedChi and the Office of Public Defender that involuntary admission is a significant civil liberty issue, I do believe that this bill is really just focusing on aligning this section with the decision-making process that we have already made and implemented into statute for psychiatric service in the scope of physician's assistants. And so with that said, I'm happy to continue work with the committee and also with the stakeholders and those who have continued concerns on the final version of this bill. So just in closing, I want to reiterate that this bill does not expand physician's assistants' scope of practice or create independent practices for PAs. They would still be able to practice within the scope and within facility credentialing and oversight. The goal here is really just to improve continuity and operational flexibility in an otherwise already strained healthcare system with many workforce shortages, as have been cited before, by ensuring that our statutes accurately reflect the licensed workforce that is already delivering care without changing benefits, adding mandates, and expanding scope. And with that, that is the bill. Happy to turn over to other members of the sponsor panel and be able to take questions at the end. Thank you.
Good evening, Robin Elliott here on behalf of the Maryland Academy of Physician Assistants. So at 6 o'clock, I bring good news in that instead of 22 bills, which there are 22 sections of law, Senator Lamb has introduced one bill, so thank you. As Senator Lamb said, there is agreement on almost every section, so I'm just going to highlight where there are differences. The first is in voluntary admissions. You will hear testimony asking to add some extra steps for PAs to be able to be the secondary signature. I will say nothing in the voluntary admission standards is proposed to change. These are voluntary standards. So if we don't have another secondary signature, that delays people in getting care. Very similar for involuntary admissions. And that's an issue that's been before this committee many, many times in terms of discussing emergency department wait times, the full range of issues. Part of the problem is we just don't have enough health professionals. And it is going to take a long time to build our health professional workforce. But we do have PAs in virtually every emergency room. So part of the solution in addressing emergency department wait times is to think about how to utilize PAs more effectively and efficiently. The third thing you will hear is some disagreement upon whether or not PAs should be considered primary care providers in the HMO statute. With this, I just wanted to lift up that in Medicaid, it's been in our Medicaid regulations for a long time, PAs are recognized as primary care practitioners, and then in Medicare, they've been recognized since 2022. So thank you very much, and happy to answer questions.
Good evening, Madam Chair, Mr. Vice Chair, committee members. Michael Chen with the Board of Physicians. The board is me too, and we urge a favorable report.
Good evening, Chair Beidel and Vice Chair Hayes and members of the committee. Jean Krinke here with the Maryland Hospital Association, just me tooing along with everyone. We think this will really allow PAs to practice at the top of their scope. So ask for a favorable report.
Thank you very much. I am very pleased to be in with this distinguished panel. Chair Beidel, Vice Chair Hayes, my name is Jennifer Beecham, and I have a proud graduate of the Maryland PA program, as well as been a practicing PA and educator for the last 15 years. As you've heard multiple times, especially in testimony today, how crucial timely access to quality medical care is within the state. Whether it involves primary care or emergency room visits, PAs are essential to delivering high-quality medical care across all healthcare settings. As PAs, we work collaboratively with physicians under our own Maryland licenses. As PAs, we are bound by the same medical and ethical standards as all healthcare providers, and we practice in the best interest of the patients. Senate Bill 326, as Senator Lamb most eloquently stated, includes PAs into areas where they currently practice. PAs actively manage to treat patients within emergency departments, many of whom have psychiatric disorders with their other medical conditions. PAs are often the patient's primary clinician during the emergency room evaluation. PAs then conduct a medical history, physical exam, order lab work and studies to determine whether there are any underlying medical conditions that require attention. PAs order the medication needed for acute agitation or for other treatment. We consult with crisis intervention teams for assessment. We obtain corroborating information from family members, and we manage the plans. We manage these plans up to the point at which requires a second signature. And at this point, the transfer to the most appropriate level of care causes significant delays in care. Addressing the workforce shortage issues with licensed healthcare providers that are already providing care, which is PAs that are in our emergency rooms, increases access to timely and appropriate medical care and is in the best interest of Maryland. So I ask for a favorable report on Senate Bill 326.
Good afternoon, Madam Chair, Mr. Vice Chair, and Senate committee members. My name is Kelly Schutz. I'm a practicing PA in Maryland for 27 years in the emergency department, and in the last 6 years in a leadership role, I've practiced in many Maryland hospitals, including Baltimore City. We know that psychiatric care and the delay of these patients is a well-known problem in the medical community. And these delays are even more significantly impacted because of the inability of our PAs to be the second signatory on psychiatric forms and for admissions. And this really greatly impacts our smaller community hospitals that have single physician coverage, and we see that gap readily. If you would refer to your written testimony, we have graph that's inserted in there. And this is showing that hospitals that only have single physician coverage have twice as much wait time for these psychiatric patients as hospitals with two signatories, which are two physicians currently. And you know, when you're looking at the data, you're not just looking at when the voluntary or involuntary paperwork is signed by the two signatories, because that typically in real practice happens at the time of sign out when the offgoing physician is meeting the oncoming physician. I have data, we look at data with the electronic medical record that timestamps the patient's time of arrival. It timestamps something like when the decision is made to actually admit the patient or transfer the patient. And you can't even do a bed search until those signatures are done. So that's really important information. And in Hospital 1, which has our greatest length of only single physician coverage, it's typically 6 to 7 hours of delay time compared to Hospital 3 that consistently has two physicians to sign for that patient to even get on the board for admission and a bed search to occur. So we need our PAs to help solve this delay problem and provide timely quality care for our psychiatric patients. We have PAs that are readily available there, and they're already doing the hard work up until that admission when it's time, you know, for the signature. So I ask for a favorable report on this bill. Thank you.
Very supportive as long as they're still the first signature and you're the second. So I thought that was helpful to hear from the doctor. So thank you very much for your testimony. Any other questions for this panel? Thank you. Thank you all for your testimony. We have Steve Wise, for favorable with amendment from MedChi. Sanjeev Verghese from Maryland Office of the Public Defender. Oh, let's just do Steve's first. Steve is favorable with amendment. And then we'll go to an unfavorable.
Okay.
Good evening, Madam Chair, members of the committee. Steve Wise on behalf of MedChi. The Medical Society is supportive of the bill with amendments in a few areas. I'm going to address 3 of those, and then I think we have 2 virtual witnesses, Dr. Davis and Dr. Morheim, I think. Okay. In any event, Dr. Davis, I think, is available to address the involuntary admission piece. On the voluntary admission, psychiatric duties for a physician assistant are considered advanced duties. In other words, you have to get special approval from the board, or you have to be working in an exempt facility like a hospital to be able to perform those. The majority of admissions obviously occur in the hospital, and majority of PAs will be covered by that exemption. Our amendment relates to those very limited incidents where the PA is outside the hospital, and we just want to be clear that they would have to have advanced duties. The reason for that is, if you look at the statute now, both for voluntary and involuntary, the folks that can sign off on this all have some mental health background. It's 2 physicians, or it's a physician and a psychiatric nurse practitioner, so not just any nurse practitioner, but psychiatric, licensed clinical social worker. So our logic is in keeping with the statute as it exists today. The final thing I'm going to mention is the ability for them to be identified as primary care providers. I recognize that that's the case with Medicaid and Medicare. What we're trying to sort out is what questions does this create with regard to billing. A physician assistant cannot practice in Maryland unless they have a collaborative agreement with a physician. What happens if that relationship ends, but the physician assistant has been recognized as the primary care provider under this bill? So that's an area we're just looking at right now. Maybe we can resolve that. Thank you.
Mr. Wise, I don't see any questions for you. You're lucky. See, it's late. Nobody's asking questions. But we will get back to you about those amendments. I have Sanjeev Verghese, if he's still here. Unfavorable.
Unfavorable. And I anticipated going after Dr. Davis and was ready to do a Me Too-esque.
Okay. Have a seat. Have a seat for us. Dr. Davis is virtual. So, Dr. Davis, would you like to unmute and give your testimony, please?
All right. You can hear me now? Yeah, okay. Good evening, ladies and gentlemen of the committee, chair, vice chair. Thank you for your commitment to be here so late. Sorry, it's like that. That's the way it is. My name is Steve Davis. I'm a Baltimore psychiatrist, 45th District. I'm testifying on behalf of MedChi in support of an amendment to SB 326, striking the sections of the bill that apply to involuntary psychiatric hospitalizations. There is a standard of care in Maryland for the evaluation of an individual who has a psychiatric condition, is in need of inpatient treatment, and who meets the dangerousness standard for involuntary inpatient psychiatric treatment. That standard of care is to have 2 physicians independently evaluate the individual who must both agree that the standards are met. When only 1 physician is available, the standard of care is to have a licensed mental health professional be the second evaluator. The 4 licensed mental health professionals permitted to be the second evaluator are psychologists, clinical professional counselors, clinical social workers, and psychiatric nurse practitioners. These mental health professionals have all completed standardized educational training programs via master's or doctorate degrees, leading to mental health licensure. You will note that other nurse practitioners, such as family medicine nurse practitioners, midwives, they're not included because they're not licensed mental health professionals. Physician assistants play an important and valued role in healthcare, but a PA is not a licensed mental health professional. The current standard of 1 physician plus 1 licensed mental health professional would no longer be met if a physician assistant was expected to perform the duty of a licensed mental health professional. I recommend that you not lower the current standard of evaluation for involuntary inpatient treatment. Thank you.
Thank you. And so now, Mr. Verghese, would you like to go?
Yes, thank you. Good evening, Madam Chair, Vice Chair, members of the Finance Committee. I'm Sanjeev Varghese. I'm the Deputy Chief Attorney with the Mental Health Division of the Public Defender's Office. piggybacking off of what Dr. Davis has stated, currently 2 physicians can sign these certs for an involuntary admission. But those physicians have all completed medical school, have all had psychiatric training, at least at the foundational level, as well as during their clinical rotations. That is not the same for PAs. My chief of my division looked at a couple of hospitals as its concerns about access to care in smaller areas. And she looked at late December through January, at a time when there's going to be the highest shortage of staffing due to the holidays. At Bayview, actually, let's start with Frederick. There were 11 cases. 10 cases where both certs were done by physicians. 1 case where there was a physician and a PNP on Christmas Eve. The longest time for certs was on Christmas Day. That was of 8 hours. At Tidal Health on the Eastern Shore, there were 13 cases. 10 cases by 2 physicians. 2 cases by a doctor and a psychiatric nurse practitioner, and 1 case where we only have 1 of the certs still in our records, unfortunately. At Calvert, we had 3 cases, 2 doctors, with 1 doctor and a PNP for 1. At Bayview, then relating that to a larger facility, Bayview had 33 clients. 31 of those clients were both, the certs were signed by physicians. So of the total of 60 cases that we looked at, 53 cases were signed by, or certs were done by 2 doctors. 6 cases were a doctor and a PNP. 1 case is unknown. We do not see that shortage. They weren't even utilizing social workers in those settings, who are often on the floors there at the ED. Thank you.
Are you finished?
I had one brief comment as it relates to
one brief comment.
The voluntary of a disabled individual is a special circumstance where individuals who are under guardianship are allowed to sign a voluntary when they have capacity to do so. That evaluation by a mental health professional is best suited in that environment. These are not certs that are being done in the ED. These are done on the unit when they're admitted. Thank you.
And I see we have one last person testifying. It's Dr. Dan Morheim, virtually. So if you'll unmute and give us your testimony, please.
Good evening. Thank you very much, Chair and committee members, many of whom I've served with when I was in the House of Delegates. I'm speaking favorable with amendment. The only area I'm concerned with is involuntary commitment. So you know me as a state legislator, but let me just briefly give you my ER background, because I've been doing ER shifts since the late 1970s. I came to Maryland in 1981, 13 years as chair, Department of Emergency Medicine, Franklin Square, and I worked clinically there and at Sinai Northwest, at Sinai Northwest later, but also Carroll County, Atlantic General, and St. Agnes. So I saw pretty much the breadth of emergency medicine. And I continued to do shifts for many, many years as a state legislator, and also volunteered at a homeless clinic, Navajo Indian Reservation, and other work. Involuntary commitments tend to take place in emergency rooms because people are brought in by family or by police. And the ultimate decision is whether you're going to take somebody's rights away or not. We initiate always a somatic evaluation because these people are often have medical problems as well. Might be drugs, might be malnourishment, might be diabetes, asthma. So we go through a whole medical evaluation simultaneously doing a mental health one. At the end of the day, the choice is I admit this patient to take away their rights for 72 hours, or I release them. And somebody says, well, I'm going to kill my wife. I'm going to kill myself. Then they say, well, it's a figure of speech. People say that all the time. You have to take it seriously. This decision is one of the most important, significant decisions we make. And you need to have 2 independent practitioners that are well-trained and thoroughly trained to do this. Frankly, we get along great with PAs. I've always worked with PAs. In fact, I sponsored PA legislation when I was in the legislature. But can you imagine a situation where the PA is with the doctor and disagrees with the doctor? Will they be able to stand up to that? You need 2 physicians who are experienced in this, who know what they're doing, who know how to gather all the resources, and you're making an involuntary decision. You're taking people's rights away. That's a very serious and powerful act. I've always considered it before acting, and that's why it really should be 2 physicians. And I urge you to take that portion of this bill, the only part I'm speaking to, and delete the involuntary commitment. Thank you.
Dr. Morheim, thank you, and your experience is valuable. Do I have any other questions? Thank you very much. That ends the testimony for Senate Bill 326, and that ends the hearings for today. 6:25, we did good. Thank you.